Fine. So thank you. And if there are any issues, तो आप any desk पे connect कर सकते हैं. Okay. Thank you. Bye bye. Hi guys. A very good morning to everybody. So let's get started from today. The topic would be respiratory system again. What I'll do is touch upon the salient features of pneumonia once again, so that we can get into the same thought process as we were yesterday. And I hope that, keeping my fingers crossed, hopefully everything goes well. So I'll just check in the app if the audio and the visual part is fine, and then we can get started. And today's objective would be to take care of the pulmonology and the nephrology component. So very easy topics, like, most of the time you will be feeling कि हाँ ये तो मुझे आता है. So what I'll do is keep on interacting with you so that I can point out certain mistakes which people think that they are knowing, but then sometimes those questions go wrong. Okay, ji. Should come up any second. Fine. So looks pretty decent to me at this point of time as far as everything is concerned. Just checking in the live feed in the app so that it becomes a little easier for me. Yeah, very good morning, guys. Ram Ram, good morning. So, time to get started, right? So, we spoke about pneumonia yesterday, and I spoke about a patient who's critically sick, specifically from the perspective that there could be a curve score of 2 or 3 happening. So, we will have to give antibiotics. Now, obviously, which antibiotics? So, ceftriaxone is a very potent antibiotic that we'll be giving. So, I would like to remind you that one of the antibiotics combinations that we were using for a case of pyogenic meningitis. Remember pyogenic meningitis, strep pneumonia again? The organism that we were using. Hi, Dr. Sampata, Dhananjay, everybody. For pyogenic meningitis, the antibiotic that we are using is by the name of ceftriaxone, and along with that, we also give vancomycin because of the risk of resistance. And I also told you that if there is the risk factors like alcoholism, etc., given in the question, then you must add ampicillin to give coverage for Listeria monocytogenes. So, pyogenic meningitis antibiotic algorithm should never ever go wrong. And then, second, for pneumonia, the algorithm should never go wrong. In pneumonia, it is even more simpler. It is respiratory fluoroquinolones that we'll be giving to the patient. So you can use levofloxacin, moxifloxacin, or gemifloxacin for the patient. And if you would be requiring, then you can, add like antibiotics if there is a requirement, that is coverage for Staph aureus and Pseudomonas, especially like the patient required intubation, because anybody who's having pneumonia, they can be worsening of respiratory distress and they can be respiratory muscle fatigue that can happen. So if I intubate, I know Pseudomonas will come in. So I will give coverage with meropenem. And most critically sick patients who are going into sepsis or septic shock would be having risk of Staph aureus anyway coming in. So linezolid is the antibiotic that we'll be adding in this particular patient. VRSA is vancomycin resistant Staph aureus. By default in intensive care unit, we will not go by algorithm, like first we will think in terms of MRSA, then of VRSA. We will assume that it is vancomycin resistant Staph aureus and we'll be managing the patient. Yeah, the page number is on the screen at the moment. That is 122. So effectively, what I have done is that I have explained 3 topics to you: pneumonia, pleural effusion, and pneumothorax yesterday. So I will be comparing the 3 topics. First, I will mention regarding the tracheal position. The tracheal position will remain central. Obviously, like a pneumonia is a condition. If I draw a crude diagram here like this is the left lung, this is the right lung, this is the trachea. So in pneumonia, like there is no any mediastinal shift that is happening. So what you will be able to notice is a big patch. And the patch would be present anywhere, right upper lobe, right middle zone, wherever. So the position of the trachea will be central when it comes to pneumonia. In this patient, when you will do percussion, when you do percussion over the chest, the percussion note will be dull because there is pus present. And then he will ask you about air entry. So can you comment quickly in the chat box? I want everybody to participate. What will happen to the air entry in a case of pneumonia? Options are obviously like, more, less, normal. So can you select quickly one? Which do you think will be like the most appropriate aspect there? Yes, the common misconception among, I'll say like this: 95% of students think that in pneumonia air entry will be reduced, but pneumonia में air entry reduce नहीं होती है because pus is in the alveoli. Pus is not in the conducting airways. So the air entry in this particular condition will be normal. Yes, guys, the air entry in this particular case will be normal. It will not be reduced. This is a common mistake that most of the people will be doing, because air entry is always normal because there is no obstruction of the airways. It is rather pus in the alveoli, and that pus in the alveoli will basically cause a change in the nature of the type of breathing that you can hear in the patient. When I started the topic of pneumonia yesterday, I taught that the first fact I taught was auscultatory finding of pneumonia happens to be bronchial breathing. So it is the nature of the breath sounds that will change, but the air entry will not be reduced. I repeat again, the auscultatory finding most reliable of pneumonia is not fine crepitations, or is it gonna be coarse crepitations. It is bronchial breathing, and because there is no obstruction in the airways, so the air entry will be normal. Now we will be comparing this for pleural effusion. For pleural effusion, what will happen is, like, suppose this is one lung, this is contralateral lung. Obviously, the lung will be having covering also, so I'll use a different color to show the covering there. And now what I'm saying is that there is fluid present. So this fluid will accumulate between the two layers of the pleura. And when the fluid will increase in size, like if I modify the diagram, though I've already done this yesterday, once again highlighted that meniscus sign that is coming up. And because the fluid is at positive pressure, so what will happen in this condition is there will be a contralateral tracheal shift in a patient. In fact, both in pleural effusion as well as in a pneumothorax, there is a contralateral tracheal shift. When you are noting down in the notes, I want you to note down in this fashion that trachea का position दोनों में shift हो जाता है, pleural effusion में भी और pneumothorax में भी. The only difference is that in pleural effusion it is water, and in pneumothorax it will be air at positive pressure. So what I am just highlighting once again is that there was initially a normal lung, but then because there was a penetrating injury to the chest, so the lung got collapsed. Lung तो यहाँ पे collapse पड़ा हुआ, like the lung will appear white. Obviously I can't draw white against white background, it will not be visible, so I'm showing color, but obviously the lung will be white. And all of this will be replaced by air at positive pressure. This air will generate, like, air will create that necessary impetus for the tracheal shift of the patient. So tracheal deviation, in fact, I can just highlight it a little better in the initial diagram also, like in this condition also. I can just show a slight deviation to the contralateral side. Yep, better now. So you will notice that contralateral tracheal shift is present in both pleural effusion as well as pneumothorax. The reason in one is water and the second one is air, because air also will generate force and pani bhi dhakka marega. Now the percussion note will be very, very handy for differentiation. Majority of my students, they are able to crack the question in 15 seconds because it was written stony dull percussion note. And for pneumothorax, I was very, very vocal yesterday regarding this, the word hyper resonant percussion note. So in my opinion, even if you don't remember the auscultatory findings, if you just focus on the position of the trachea and if you focus on the percussion note, you are sorted as far as identification of the problem is concerned. Though for completion, I will mention regarding what will be the auscultatory finding in pleural effusion. So in this case, because there is water over the lungs, so आवाज ऐसे आएगा as if the sound is coming from a distance. So the word would be distant breath sounds. I want to highlight the statement here, not distant heart sounds. Distant heart sounds is a feature of pericardial effusion or cardiac tamponade. If you're auscultating over the heart और ऐसा लग रहा है कि आवाज दूर से आ रहा है, फिर तो cardiac tamponade हो जाएगा. But यहाँ पे it is distant breath sounds in a patient. Yeah, you can call it decrease also. You can call it distant also. Distant थोड़ा is a much more error introducing data given in MCQs, क्योंकि distant वर्ड पढ़ के कई स्टूडेंट जल्दबाजी में पेरिकार्डियल effusion tamponade मार्क कर देते हैं. भाई breath sound लिखा है ना, heart sound नहीं लिखा. So the word that I would like you to note down is distant breath sound. Then your statement of decreased breath sound was also okay. For pneumothorax, again, nobody will make a mistake because I was very, very vocal about it. Absent air entry and absent breath sounds. So I think that if you read this data once, there is absolutely no reason that unless somebody is very casual or somebody is very sleepy, that they can mess up with respect to differentiation between pneumonia, pleural effusion and pneumothorax. And most of the questions that come in the paper nowadays, irrespective whichever exam you sit for, they will, if they say pneumonia pleural effusion, they will give some clinical findings. So you just have to identify on the basis of the findings what is the problem that is present. One of the easiest one to identify is pleural effusion because of the stony-dull percussion node. Then the X-ray will also be white, and obviously the white will be because of gravity starting at the bottom. Pneumonia can involve any part of the lung, so the white patch is what is radiologically called as consolidation. Now I ask you a question. I want you to answer without looking at the notes. What is the most common cause of pneumonia in AIDS positive patients? Overall, most common cause of pneumonia in AIDS positive patients. I give you two options, pneumococcus and pneumocystis jirovecii. Please comment in the chat box quickly. Pneumococcus is option number 1 and jirovecii is option number 2. Okay, so this is what a lot of students got wrong in the paper. The answer is not pneumocystis jirovecii. Answer is not pneumocystis jirovecii. The most common cause of pneumonia, guys, focus. If I said CD4 count is less than 200, if I said that gomori-methamine stain was present, then you answer pneumocystis jirovecii, okay. But overall, the most common cause of pneumonia in an AIDS positive patient is pneumococcus. Yes, guys. The guy is living in the community, na. So if somebody is living in the community, man, he'll get the infection of the community only. So overall, the most common cause of pneumonia in AIDS patient is pneumococcus. It's a silly mistake that is made by a lot of people, though a lot of people have got it correct also. But like it was 50-50 this time. So do take care of the fact, and I will touch upon pneumocystis jirovecii in about 5 minutes from now. Next is a very peculiar statement that I'm not asking you because most people don't believe it when they are initially told about it. The most common cause of tension pneumothorax is not penetrating trauma. In the exam, this was, I think, FMG exam, options were penetrating trauma, blunt trauma, barotrauma. And majority people in those circumstances mentioned it is penetrating trauma because after listening to a surgery class and even my yesterday's class where they talked about a stab injury to the chest, the impression that comes is penetrating trauma. I agree that the impression after surgery and a medicine class is penetrating trauma, but overall, the most common cause of tension pneumothorax is not penetrating trauma. It is barotrauma. This is line to line from Harrison. He has mentioned that though apparently it looks like penetrating trauma is more common, but most of the time tension pneumothorax happens when patient is on the ventilator. What I mean by barotrauma is it is a ventilator induced trauma that the settings on the ventilator were not adjusted properly. Like it happened in COVID time. So many patients got admitted and like one doctor was responsible for managing so many ventilators. By managing one patient on one ventilator itself is like a full night job. One patient on a ventilator, it's like a full night job for one doctor. Here it is like one doctor responsible for 10, maybe 20, maybe 30, maybe something more than that. I mean, it was most of the time crazy at that time. So many cases were admitted. So you could not keep a tab on the settings. What I mean by settings is values like peak inspiratory pressure, peak and expiratory pressure. The point is, if you will send more air in the lungs, lung is already injured, like in COVID, the lung is injured. Then if the settings are not correct, then the person will end up with development of barotrauma. That is why at COVID time, you would have seen that a lot of people recovered from COVID, but later ended up with pneumothorax because of the faulty ventilator settings. So the problem at this particular point of time is ventilator settings, which are not appropriate for the patient. So I will teach you also the important concept of ventilator setting. Only one ventilator setting is required for you guys. When I touch on the topic of ARDS after this, I will teach you like what is PEEP and what is like tidal volume, how do we maintain it and what should be the appropriate tidal volume. But at the moment, just hold on. The point to be simply remembered is if there is a faulty ventilator settings being maintained for a patient, that is you are giving more pressure than normal, barotrauma will be occurring. So I mentioned two very questions which I think like a lot of people don't realize the importance and they casually answered as jirovecii and penetrating, but I have done a course correction at the moment. I would rate these two questions as one of the most important two questions for the first session of today morning. I would rate these two questions as the most important two questions for today morning. Next is what is the best site for insertion of wide bore needle in a case of tension pneumothorax in adults and children? I've already clarified that, but I wanted to just put in record because obviously like I spoke about fifth intercostal space for adults also, and then I spoke about second intercostal space for adults also. So I want to put on record the statement that it is fifth intercostal space, usually anterior to the mid-axillary line. This is the standard answer. Otherwise, it will be second intercostal space and it will be lateral to the midclavicular line of the patient. Yeah. For children, by default, it is second intercostal space. And you have to be lateral to the midclavicular line. Why you have to be lateral from the midclavicular line is because you want to be away from the great vessels of the heart. Like you want to be away from SVC, IVC, aorta, and all those important blood vessels which are related to the arch of the aorta. Then comes this bacteria by the name of Legionella pneumophila. Legionella pneumophila is responsible for causing Legionnaire's disease. The peculiarity of this bacteria is that it can cause both typical and atypical pneumonia, and it is associated with development of syndrome of inappropriate ADH secretion. SI-ADH we read 2 times in a career, one with oat cell cancer, second is right now Legionella pneumophila. This will be the only MCQ in your exam where electrolytes will be given. Only in pneumonia we don't even bother about electrolytes, but today the patient came with confusion, disorientation. He will not begin like this. He will say patient is admitted with diagnosis of pneumonia. Patient is having severe confusion, disorientation. So the doctor thought that there is a hypoxia. So the doctor is checking the pulse oximeter readings of this patient, like the SpO2 of this patient is turning out to be normal. The ABG report, the PO2 is also normal. So the doctor is confused now. He's thinking to himself, what the hell is going on? Like the SpO2 is normal and PO2 is also normal, and still the person is having hypoxia, and still the patient is having disorientation. See, if a pneumonia patient is having confusion, disorientation, first thought process of any doctor will be that it is due to deficiency of oxygen in the body. The examiner will himself mention that SpO2 of the patient was normal, PO2 of the patient was normal, and then the doctor decided to do electrolytes of the patient and sodium was low. So that helps in identification that this patient is suffering from Legionella pneumonia, which causes loss of control over the release of ADH. And if you have loss of control over ADH, then more salt is going to come in the body, and the more salt will cause hyponatremia in the patient. Point to be understood. An important point to be understood here is that seizures may or may not be given. Like you said, seizures, sodium may not critically become like less than 125 or like dangerous hyponatremia. So it's not a necessity that you would always be having hyponatremia present. And yeah, SI-ADH will draw water. I mean, antidiuretic hormone का काम क्या होता है? It is responsible for excess of water in the body, and excess of water will contribute to dilutional hyponatremia. The statement to be noted by you here for the dilutional hyponatremia, though I will touch upon this point even when I teach you the kidney topic, but I want you to note the word here. I'm just giving you a heads up at the moment. Yes, Vipin, the moment you wrote it, even simultaneously, both of us were having the same mindset that the type of hyponatremia that is seen here is called as euvolemic hyponatremia. This is the third most important statement for today morning. I will be teaching you like details like hypervolemic, hypovolemic, and hypo U and hypervolemic hyponatremias will be discussed in the kidney section with electrolytes. But just wanted to say that the technical word for the dilutional hyponatremia component at the moment is euvolemic hyponatremia. Why I'm telling you this here is because he will interlink the two systems. In the topic of respiratory system, he will introduce electrolyte imbalance. And how will he introduce electrolyte imbalance? By writing word like euvolemic hyponatremia, expecting you to answer that this is euvolemic hyponatremia. I hope I've been able to explain to you that number one reason why any pneumonia patient will be unconscious or having confusion, disorientation, it is deficiency of oxygen. But if it is not a deficiency of oxygen, then it could be a electrolyte imbalance, which is triggered by SI-ADH in a patient. As I said, Legionella is a nasty organism which can be presenting as both typical and atypical pneumonia. So he will also ask you what is the test that we would like to do for diagnosis of this organism. Legionella bacteria is difficult to culture. So I will ask you the name of the culture media also. Hit the comment button and tell me what is the culture media for Legionella pneumophila. I would like to tell you that in the MCQ, most of the time he will not even give you culture option because culture is overrated. No, most of the time culture reports come sterile because patients have taken antibiotics. So your answer would be urine for Legionella antigen. It looks very, very surprising, but it's true that for diagnosis of Legionella pneumophila, you will not be answering sputum culture, transtracheal culture. You will be answering urine for Legionella antigen because this organism will be present in the bloodstream and is coming in the urine of the patient also. Normally, in a pneumonia patient, the thought process of any doctor will be sputum, 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 right? But I want you to go beyond that and answer it as urine for Legionella antigen. And I had a good answer here also, that ideally the selective media that we are using for this patient is a black color culture plate. There was an image of a black color culture plate that was given in, I don't recall now, it was FMG or NEET PG, because they occurred at a gap of 1 week only. So, the questions become mixed up. Last year, FMG and NEET PG, they occurred at gap of 1 week only. So, Bice media, that kala ring ka culture plate diya tha, that is buffered yeast charcoal extract. That charcoal will make the culture plate black. Normally, all culture plates are gonna be reddish in color or chocolate agar or maybe pink in color में conkeys, but first time you will read about black color culture plate. उसने काले रंग का कल्चर प्लेट दिया और बोला कि ये कौन से ऑर्गेनिज्म के आइसोलेशन के लिए यूज होता है. तो बफर्ड yeast charcoal extract, as all of you have answered very rightly, is the selective media that we are using for isolation of this organism. And what antibiotic we will be giving to kill this is universal macrolides. Whether it was curve score of 0, 1, 2, 3, when patient will come to me initially, I will know what bacteria is causing pneumonia. It could be typical, it could be atypical pneumonia. So by default, macrolides will be given. Maximum ye kar dega, macrolide will not be in the option, then mark doxycycline. If macrolide is not in the option, then mark doxycycline. So Legionella came up the discussion once again today. I just wanted to add these finer points like a very peculiar statement, euvolemic hyponatremia. I wanted to add up a very peculiar statement, urine for Legionella antigen. We read it for first time, it looks like, arey, ye to dummy choice hai. It looks like a dummy answer, dummy choice. But we will do a sputum culture for isolation. But I said blood culture is overrated, man. Most of the time, the culture report will turn out to be negative. And now I will touch upon another organism causing atypical pneumonia, where the person will be having black color urine. Black color urine. And you are wondering, ki, sir, are you talking about kidney disease or are you talking about a pneumonia? Guys, I am talking about a pneumonia which will cause destruction of red blood cells. I'm talking about a pneumonia that will cause destruction of red blood cells. The name is right on the slide, Mycoplasma pneumoniae, but I'll give a short explanation. The explanation I want you to listen to, and then we'll come back to this particular line. So all eyes on the screen at the moment, please stop noting and listen to my words. Mycoplasma bacteria does not have a cell wall. Mycoplasma bacteria does not have a cell wall. It has a cell membrane. Cell wall नहीं होता तो penicillin will be ineffective at this point of time. Penicillin will be ineffective at this point of time because penicillin कैसे काम करता है, वो cell wall के synthesis को inhibit करता है. तो यहाँ पे इसकी जो membrane होती है उसके ऊपर एक antigen होता है और इस एंटीजन का नाम होता है पी एंटीजन. मतलब बैक्टीरिया की मेम्ब्रेन पे या उसकी सेल वॉल पे, यहाँ तो सेल वॉल होती नहीं है तो उसके मेम्ब्रेन पे एंटीजन प्रेजेंट है और उसके अगेंस्ट ऑब्वियसली एंटीबॉडीज तो बननी है भाई. कभी भी बॉडी में एंटीजन होते हैं तो उसके अगेंस्ट एंटीबॉडी बनती है, फॉरेन एंटीजन आता है. अब दिक्कत क्या होती है कि जो हमारे रेड ब्लड सेल्स है, आवर रेड ब्लड सेल्स also by chance express a chemical which looks like P antigen. Our RBCs also express an antigen which looks like P antigen. It is not actually the P antigen, it is looking like the P antigen, so the antibody will get confused. Obviously the antibody will kill this bacteria, but the antibody will get confused और वो खुद के RBC को भी मारना शुरू कर देगी. ये जो मैंने प्रेजेंटेशन दी कि the antibody will start attacking self के RBCs is the reason why the person will start having hemoglobinuria. Hemoglobin is not red in color, it is brown to black in color. So the patient of mine will basically be developing, the patient will start developing a black color urine, that is hemoglobinuria. Normally we have cell wall, the bacteria, this bacteria does not have a cell wall, it has a cell membrane, that's like a cell wall deficient bacteria. And penicillin, how does it work? It acts by inhibiting the formation of cell wall. So the point is, because penicillin inhibits the formation of cell wall, penicillin will not work in this particular condition because there is no cell wall present, right? That's the one point to be understood. Why do we give macrolides? Because the bacteria will not respond to penicillin, it doesn't have a cell wall. Second, I said on the membrane there is an antigen, P antigen, and the antigen is like a chemical that looks like P antigen is present on RBCs also. So the antibodies forms against it, that gets confused, and that results in what is called as autoimmune hemolytic anemia. Due to this autoimmune hemolytic anemia, how the examiner will write this autoimmune hemolytic anemia will be, because RBCs are getting destroyed, so he will write words like low hemoglobin. He will write words like elevated LDH. If you ever read a MCQ in which LDH is given and hemoglobin LDH is elevated and hemoglobin is low, the examiner is trying to get you to the word autoimmune hemolytic anemia. This person will be having hemoglobinuria because see, when RBCs will get destroyed, hemoglobin will be released in the blood, so hemoglobinemia, and hemoglobin can get filtered via the tubules of the kidney and then will cause black color urine. So the peculiar thing I'm teaching you, pneumonia patient ko काले रंग का urine आ रहा है, which is not normal. And this entire presentation is, you can note a word now. Please start noting the word paroxysmal cold hemoglobinuria. If you look at the data, there was a sudden destruction of red blood cells, which resulted after a cold. Cold was a pneumonia, like cold like ठंड लग गया, सर्दी लग गया. So the guy had a pneumonia and then there was hemoglobinuria. And another reason is because from the pathological domain, there would be presence of cold antibodies in this particular case. Can you tell me the name of the antibodies there? No, it is not schistocytes. No, it is not schistocytes. This is not schistocytes here. We'll talk about schistocytes in the kidney segment. Yes, guys, can you tell me the name of the antibody? Yeah, it's an IgM class of antibody. That is understandably. Any infection will have IgM class of antibody. What is the भाई कोई भी गला भी खराब होगा तो IgM ही तो होगा यार. Come on. What is the technical name of the antibody? Yes, Sairaj Maine was the first one to comment on that. Pathology में ये present है. It is given in your notes. So what you need to note down for this condition is not all the things that I said. वो तो समझने के लिए था. What you need to note down is not exact verbatim what I said. What I want you to mainly, if you want to note down the whole thing, cool. But the main thing I want you to remember is that mycoplasma, acute में IgM होती है, chronic में IgG होती है. The name of the antibody which is present here is called as Donath-Landsteiner antibody. It is for the name of this antibody that I went into this long story of telling you bacteria is there, antibody is getting confused, it is attacking self RBCs in a patient. So the main point is for Donath-Landsteiner antibody. The aspect is mycoplasma pneumoniae causes PCH and that is Donath-Landsteiner antibody. To be remembered, it's a cold antibody which is responsible at this point. So atypical pneumonia को atypical क्यों बोलते हैं? Because there is passage of black color urine. Atypical pneumonia is called so because it is causing a development of like dilutional hyponatremia, है ना? चाहे आप बोलो इलेक्ट्रोलाइट इम्बैलेंस हो गया, चाहे बोलो ब्लैक कलर का यूरिन आ गया, तो उसको हम एटिपिकल pneumonia बोलते हैं. And the organism responsible is called as mycoplasma pneumoniae. तो finally note क्या करना है? तो note क्या करना है? तो organism name is mycoplasma pneumoniae. The antibodies against mycoplasma pneumoniae क्या करते हैं? वो खुद के RBC को मार देते हैं, और जब खुद के RBC मर जाते हैं तो then it would be responsible for, खुद के RBC मर जाते हैं तो उसको autoimmune hemolytic anemia बोलते हैं, also called as PCH, and the technical name is Donath-Landsteiner antibody, which is responsible for this. There are two reasons I told you atypical pneumonia. One is कि seizures are occurring. And second, I told you why there is a development of why are we saying atypical is because black urine is being passed. With pneumonia, you don't have black urine, you don't have hemolysis, you don't have a hyponatremia. That is why this lower part of the discussion is equally important. That majority of questions on pneumonia in any app you do will start by talking about Legionella and Mycoplasma. जानबूझ के Legionella. He knows that you have studied pneumococcus. He knows you have studied, antibiotics for like Pseudomonas. So most questions will revolve around these last के 3-4 statements that I said: Legionella pneumophila and Mycoplasma pneumoniae. तो अब तो हिंदी में भी बोल दिया. Okay जी. Organism specific pointers in pneumonia. The best test is urine Legionella antigen. Selective culture media, as I've explained to you, is what is called as BICE media. The full form of BICE is buffered yeast charcoal extract for Legionella pneumophila. The electrolyte imbalance which is seen here is due to SIADH, that is euvolemic hyponatremia, and the drug of choice for this is macrolides. Obviously we will give azithromycin or doxycycline, IV or oral, depending upon whether the curve score of the patient is low or high. I mean, if it's high, 2, 3, something like that, IV, otherwise oral antibiotics would be given. Now I will talk about Staph aureus pneumonia, which is the leading cause of nosocomial pneumonia or a hospital acquired infection. The first point to be remembered is that when do we say nosocomial pneumonia or hospital acquired infection? If a person presents with or develops pneumonia after 48 hours of admission. Options in the MCQ were 24, 48, 72 and 96. Options in the MCQ were 24, 48, 72, 96. If somebody develops a pneumonia after 48 hours of admission, we will say it is coming from the hospital environment. Let me give an example. A patient was admitted to the hospital for elective cholecystectomy and he developed pneumonia on the first day only. If pneumonia is developing on the first day, is carrying the infection from the house, then I will say community acquired. But suppose it develops at or after second or third day, then I will say it is a hospital acquired pneumonia, that is a nosocomial pneumonia that is coming in. The radiological finding in this particular condition. The radiological finding in this particular condition will be that of small cystic cavities. They would be small cystic cavities which would be filled with pus. These are like multiple small cystic cavities that would be filled with pus on both left as well as the right side. So this is a fairly virulent organism. It causes aggressive damage. These small cystic cavities filled with pus are called as, what is the small cystic cavities filled with pus called as? Yes, guys. What is the small cystic cavities filled with pus called as? क्योंकि they will unite to form lung abscess. वो तो ठीक है. Somebody commented, sir, lung abscess will be occurring, distal clubbing will be occurring in a patient. But then the point is, like, what is that small cystic cavities filled with pus called as? No, guys, that small cystic cavity. Man, I moved the slide, but it destroys the rhythm of the remaining class. So please try to take the notes running simultaneously. The small cystic cavities which are filled with pus would be called as pneumatoceles. Small cystic cavities which are filled with pus is what is called as pneumatoceles. This is itself a one-liner MCQ. Pneumatocele or pneumatoceles are found in, answer is Staph aureus pneumonia. These small cystic cavities with unite to each other. जो बुल्लाज होते हैं वो COPD में होते हैं. बुल्ला is not a formation of pneumonia. Bulla is not a feature of pneumonia. The pneumatoceles will unite with each other to form small cystic cavities filled with pus. And now, subsequently, when these pneumatoceles will unite with each other, there will be a formation of a lung abscess in the patient. In lung abscess, what will happen is that the pus will settle at the bottom and air will be present on the top. Pus will settle at the bottom and the air will be present at the top. So instead of writing like this, lung abscess, the examiner most of the time will write the following phrase. The phrase is air fluid level in a chest X-ray. Normally, we don't read about air fluid level in a chest X-ray. We read about air fluid levels in a X-ray abdomen. I mean, normally जो air fluid levels होते हैं X-ray abdomen में होते हैं. But if you read a question that says air fluid level and moreover says that air fluid level is present in the chest X-ray, that is the peculiarity. That is what I want to bring to your attention. That in those circumstances, like we know that things have really gone bad and the guy has ended up with development of a lung abscess. And lung abscess is one of the causes of development of digital clubbing that I will draw and show you subsequently. But at the moment we're discussing organism specific approach to pneumonia. So Staph aureus is one of the leading causes. He has also asked, how would you prevent the development of this Staph aureus pneumonia in the hospital? Then answer is repeated hand washing. This bacteria lives in our nostrils. So many times per day, accidentally we touch our nose. And then when the bacteria comes on a hand and we are holding a pen or something, or when we touch a surface, then the bacteria will be transmitted to that surface. Now some other nurse came and she touched the same surface where I had kept my hand. She will get that Staph aureus on her finger. She touches her nose. So the interpersonal transmission of Staph aureus will always occur. So that is why repeated hand washing before you touch a patient and after touching a patient. In fact, after touching every surface in the hospital, that is why chlorhexidine is available everywhere, left, right, center in the hospital setting. Repeated hand washes. Repeated hand wash by all doctors, nurses, preferably patients and attendants also. Obviously, non-medical people don't realize the things that you and me can. So sometimes it is a waste of resources. वो bottle को चुरा के घर ले जाते हैं. तो हम बहुत बारी क्या हॉस्पिटल वाले परेशान हो जाते हैं कि सर चोरी, क्लेप्टोमेनियक्स है ना, इंडियंस है ना, कुछ भी उठा के कहीं पे भी ले जाते हैं. पीछे होटल से सामान उठा लिया इंडोनेशिया में, बाली में. A rich family, they're going to Bali and then they're doing such things. So Indians are crazy people. You'll find this even in your hospitals. Repeated hand wash with chlorhexidine is the best way to prevent the colonization of the airways. But then they changed the question and they asked prevention from the perspective that a lead surgeon, like what happened was that, let me say, like अगर मेरे nose में Staph aureus है, if I'm operating on a patient, if I'm doing any invasive procedure on a patient, if the mask will come down, then I'm literally breathing into the operating field. And when I'm like operating, when I'm breathing into the operating field, my Staph aureus could be falling in the operating field also. So surgical site infections are also caused by Staphylococcus aureus. Surgical site infections are also caused by Staph aureus, and therefore, like the question was that because in one hospital with one unit, multiple cases are having SSI. What is SSI? It is surgical spot infection. तो ऐसे SSI सर्जिकल साइट इन्फेक्शन, तो उन्होंने लीड सर्जन और जो स्क्रब नर्स थी दोनों का नेजल स्वैबिंग किया in one unit of the hospital. Staph aureus infections in the wound were coming very high, so the hospital infection control policy के अंदर the lead surgeon and the OT technicians and the perfusionists and then the scrub nurse, everybody nasal swabbing was done, and unfortunately it is the lead surgeon and the scrub nurse both are turning Staph aureus positive. So they said कि अगर लीड सर्जन को स्टैफ ऑरियस पॉजिटिव है तो द हॉस्पिटल मेडिकल सुपरिटेंडेंट has debarred the surgeon from going in the OT. Understandably, if a surgeon is having staph aureus in his nose and he will go in the OT, by chance, when you are operating, the mask will obviously go down. He will be throwing the bacteria in the operating field, and that will result in SSI, surgical site infection. So that will also affect like the reputation of the hospital also. That will affect the reputation of hospital. And reputation once lost can never be retained, right? Whatever you do. आजकल तो सोशल मीडिया ट्रायल्स होते हैं, पीपल डोंट इवन लिसन टू द अदर साइड ऑफ द स्टोरी, दे जस्ट फॉर्म अ impression, this guy is bad, this hospital is good or bad, universal, like they will start boycotting hospital and stuff like that. In India nobody listens to each other ना, वो कहते हैं हमने बोल दिया सोशल मीडिया पे तो everybody is a lion. So therefore hospitals are very careful at the moment from the perspective of not allowing anybody with staph aureus positivity to go into the OT, because especially if you're doing regular, like if I'm doing OPD it's अलग बात है. But if I'm doing an interventional procedure and if I give an infection to the patient, then this cannot be allowed. So you guys now have to tell me, this is a PYQ. He said what antibiotic will be given to the lead surgeon and the scrub nurse to kill the staph aureus in the nostrils of these patients, of these fellow colleagues. Like they are very disappointed. Yeah, the medical superintendent has given me a letter. On that it is written that you are debarred from the OT till further orders. ऐसा भी नहीं कि 5 days 7 days 10 days, sir. He says like it is hampering my business also, no, I'm not going in the OT for 1 month. How do I like pay my EMI? मैं गाड़ी खरीद लिया BMW ना शो ऑफ करने के लिए, तो everybody goes off in BMW and he says मेरा EMI जो है वो पे नहीं हो पाएगा, मेरे घर का मैं गुड़गांव में मकान ले लिया मैग्नोलिया वाला 50 CR वाला, तो EMI इतना जाता, कह रहा सर कहाँ से करूंगा, मेरे को OT में जाने से मना कर दिया. So what is the antibiotic that you will be using in this patient? Yes guys, not bacitracin, it is topical mupirocin. It is topical mupirocin, the antibiotic that you will be using. You will be asking this surgeon to say, relax man, nothing wrong, just go to the chemist, purchase topical mupirocin cream, put it on your finger, put the finger in the nose, rotate left right 2-3 times per day, and after 7 days we will do your swabbing again, and after swabbing again the surgeon is happy because now the staph aureus is negative, and now he can pay the AMI of his BMW and also the Magnolia ka 50 crore flat that he purchased in Gurgaon sector 42. I think, yeah, Magnolia, Camellias, they're super expensive, man, right? So I speak to a couple of young doctors ना, वो कहते हैं सर अभी तो गुड़गांव के सबसे महंगे सेक्टर में रहने, मैं गुड़गांव में पानी भर जाता है, कहाँ क्यों रहना है वहाँ पे, कह रहा सर वो बस एटीट्यूड है ना, गुड़गांव इज लाइक अ पॉश एरिया. Anyway, coming back to the agenda, this was like just an example that I wanted to give to you, that topical mupirocin. Sir, 50 CR में US में ना you can buy a mansion which would be overlooking the Atlantic Ocean or Pacific Ocean. 50 CR, one can buy in America a mansion, huge mansion, overlooking the Atlantic Ocean or the Pacific Ocean, and we Indians are so crazy, we still want to live in Gurgaon where waterlogging occurs and the cars are floating in the water. Okay, so मैग्नोलिया याद रह जाएगा, म्यूपरसिन कैसे भूलेगा, अब तो नाम बता दिया ना मैंने, मैग्नोलिया तभी तो बोला मैंने, राइट, कैमिलिया मैग्नोलिया नाम ही इसी वजह से आया. So the names here are, it is topical mupirocin which will be used in this particular patient, and this not exactly a patient, he's a doctor colleague. He's a doctor colleague of yours, and he was very disappointed. So they create a question like this: a surgeon, lead surgeon has come, he has been debarred with the infection control policy and like infectious control policy. Guy has made him debarred from the OT. Now, what will you do? So on those particular patient, yeah. So in that particular fellow colleague, it is mupirocin that would be required for this person. Coming back to the agenda, Klebsiella pneumoniae. When will you answer Klebsiella pneumoniae will be alcoholic. The moment the question says the word alcoholic, so alcoholic is come today also, like in cardiology, alcoholic is coming today in respiratory system. If he says the word alcoholia, alcoholic and then says red currant jelly sputum, then it's gonna be Klebsiella pneumoniae as a organism responsible. I want to repeat my statement again. If you get a question, what is the leading cause of community acquired pneumonia? You don't need to note it down. Just listen to my words carefully. Leading cause of community acquired pneumonia is pneumococcus. But if I slightly twist the question and say the guy is an alcoholic and I don't say anything else, he say he got infected, then I will change the answer to what is currently on the slide, that is Klebsiella pneumoniae. The word alcoholic has so much of importance in the question that even if you don't read the word red currant jelly sputum, if that is given, excellent. If that is given, then it is excellent. Otherwise, alcoholic with community acquired pneumonia, because alcoholic people tend to have some they usually get infected with more dangerous organisms. And the reason for that is mainly that these patients would be having suppressed gag reflexes, cough reflexes. So alcoholic with community acquired pneumonia is Klebsiella pneumoniae. The X-ray of this particular patient is showing a very characteristic finding of a convexity. You can see it is convex in a downward direction. This that is currently formed is not a lung abscess. A lot of people answer casually as lung abscess दिख रहा था सर, पूरा white था. तो यार lung abscess में तो मैंने बोला ऊपर काला होता है ना, air should be there. This is not a lung abscess. Obviously there can be a lung abscess, but this is not a lung abscess. This bacteria can cause lung abscess, that is what I'm saying. But the one that you can see at the moment is not a lung abscess. Why? Because there is no air fluid level. There is no black subsequently. Yes, this is called as bulging fissure. Fine. I waited for a few seconds just to see that couple of people are able to recognize this. So it is pus in the interlobar fissure. That pus in the interlobar fissure is causing bulging fissure sign in a chest X-ray for Klebsiella pneumoniae. Very good. This entire discussion is what is also called as Friedlander's pneumonia. The bacteria is called as Friedlander's bacillus. The bacteria is called as Friedlander's bacillus, and the complete presentation is called as Friedlander's pneumonia. When you note down the spelling, be careful. It is not Fried, not Kentucky's Fried, right? Fried. It is Friedlander's pneumonia. That's because in micro, Klebsiella pneumonia is called as Friedlander's bacillus. And again, like this is a necrotizing pneumonia. So even in this condition, there can be a development of lung abscess in an individual. So most common cause of lung abscess is Staph aureus. Most common cause of lung abscess is Staph aureus, but don't be surprised if Staph aureus is not in the options. The answer can be even Klebsiella pneumoniae. And now I will describe a case before you for anaerobic lung abscess. Listen to the case here. The question said, this is a 20-year-old guy. On the Holi festival, this guy is Gen Z. On the Holi festival, he consumed alcohol. Like nowadays, these Gen Z, they don't know what is the importance of festivals. You're not supposed to drink. उसका मतलब है कि होली मतलब छुट्टी और छुट्टी मतलब दारू. तो आजकल देखो ना, मतलब कभी छुट्टी होती है चल दारू पीते. So the guy on a festival time took alcohol and then he did some drugs also. And due to cocktail of alcohol and drugs, this guy was sleeping continuously for 2 days. This guy, after taking alcohol and drugs, was sleeping for 2 days. His mom was trying to wake him up, but like she was not able to wake up. I mean, that was the history given, that the mother was trying to wake him up for 2 days and he was saying, no, I want to sleep. And he was going back to sleep. So she was very worried. So this is typical Gen Z. He has put a notice outside the room also. He has put a notice outside his room, knock before you enter. So his mom is totally afraid of entering the room directly. So his mom knocks on the door, beta, you are fine. Raja, beta, you are fine. No answer. So finally she opened the door. So the Raja beta is sleeping, nashe mein. And she said, do you want to eat something? Every mama will be concerned about her son. So she said, being a mother, right? She's a good mother. And routinely Indian mothers will pick up a broom and they'll give a solid beating. But today the mother had a soft heart considering the bad state of her son. So she did not give him a beating. And she said, beta, you want to eat something? He said, no, let me sleep. After 2 days, when this guy woke up, the guy had high grade fever with chills and rigors. And along with that, the person was also having very bad smell from the mouth, halitosis, because there was a purulent bronchoria, that is balgam aa raha tha. Purulent bronchoria was occurring in this particular individual. So a mother, being a mother, brought him to your hospital. Ideally the mother or father both should have first given a solid beating. But parents are like that only na. For them, their son is the best. वो तो कभी गलती कर ही नहीं सकता, इसके दोस्त गलत है, उन्होंने इसको गलत आदि लगा दी. Like that, their parents are defending. And now when you did X-ray, the X-ray is showing a huge destruction in the lung. Like if you look at the diagrammatic representation, it's like a big abscess that is developing in the lung of this patient. The chest X-ray is showing development of a lung abscess or like a big cavity filled with pus. It's a big cavity. Destruction is happening in the lung. In fact, I can say pus maybe like not very visible in this view, but then the cavity is very much visible. So the question that came in the paper, like he gave a story like this, that a guy had consumed alcohol after, intoxication. He was sleeping continuously for 2 days, and after that there's a purulent bronchoria, there's a cavity in the lung. So he said, like, what is the cause of development of this manifestation? So if you would have yeah, so what is the cause of this presentation? Your answer will be micro aspiration of saliva. Like anaerobes, though it's okay, but then it is micro aspiration of saliva which is responsible for this kind of a presentation. Because see, howsoever deeply you and me are sleeping, we never aspirate on our saliva. Howsoever deeply you and me are, howsoever deeply you and me are sleeping, we will never like swallow we keep on swallowing our saliva. We don't aspirate on our saliva. The problem in this question, what the examiner was trying to see was that, are you able to figure out that cocktail of alcohol and drugs is a disaster? Because if somebody will take cocktail of drugs and alcohol, then gag reflex in the person will be suppressed. The cough reflex in the patient will be suppressed. These are two important airway protective reflexes. These are two important airway protective reflexes. So in those circumstances, considering the gag reflex is less, the cough reflex is suppressed, there is micro aspiration of saliva, and that is reason for the presentation here. Can you tell me the most common bacteria in the saliva? I would like everybody to tell in the comment button what is the most common cause, what is the commonest organism in the oral cavity, what is the commonest bacteria in the saliva. I'm waiting for a few seconds. ओरल कैविटी में सबसे कॉमन बैक्टीरिया कौन सा होता है? And obviously it is not Staph aureus. Obviously it is not Staph aureus. Howsoever well you brush your teeth, if we don't brush our teeth for one day, the breath will be foul, because between the crevices of teeth the food particles will get stuck, and in between that the bacteria keep on proliferating. So what is the commonest bacteria in the oral cavity? The commonest bacteria in the oral cavity is anaerobes. Mutans is answer for caries, dental caries. What is the commonest bacteria in the oral cavity? The answer is not Streptococcus mutans. Streptococcus mutans causes dental caries. The commonest bacteria, come on guys, you are not remembering the information properly. The commonest organism in the oral cavity is not mutants, it is anaerobes, which are responsible for the problem. I repeat again, anaerobes give a bad smell. If a person will not brush his teeth for one day, even less than one day, the breath at the end of the day tends to be a little foul. So that's because between the crevices of teeth, the food particles keep on accumulating and these bacteria keep on proliferating. So anaerobes are the most common organism, and that is why the presentation is occurring with respect to anaerobic lung abscess in a patient. Since I had incorrect answers in this case, I want to highlight the following fact. If a question says Parkinson disease patient develops a pneumonia, what organism is responsible? It is anaerobes. Like Muhammad Ali, the biggest boxer of all times, died because of Parkinson disease. He died because of anaerobic pneumonia, anaerobic lung abscess. Atal Bihari Vajpayee sir was suffering from Alzheimer's disease. He also died because of pneumonia. That was aspiration pneumonia due to anaerobes. Head injury patient. In all CNS cases, I was always saying, secure the airway. In all the CNS cases, I was saying secure the airway, whether it was stroke, whether it was head injury, whether it was Parkinson, whether it is Alzheimer's disease, whether it is drug overdosage, like in this particular case. The common thing in all of these situations, this time the drug overdose was a combo of alcohol, like this guy drank a lot of alcohol, then he took bhang or heroin or whatever, right? These guys go crazy and ballistic over drugs, and they think it's a cool thing to do. When you talk to them, to bolega, I mean, what's your problem? It's my life. That lingo, that Gen Z life. He says it's my life. He will not even write proper words. So, I mean, they think it's a cool thing to do. So, I mean, once in a while, somebody is, going out and experimenting, understandably, but they think that it's like it brings out their creativity. And when you talk to these people, they will say, I feel more creative. I said, what creativity have you done? Nothing. And I will create a website. I will create AI. You will create AI. Okay. Already the system is saturated. So, I mean, these guys, yeah, Maha Life, that MAH. Yes, yes, yes. I've seen that lingo so many times, in those forums, etc. Maha Life and stuff like that. So, PD, AD, head injury, stroke, drug overdosage. Sir, medical students are also doing a lot of substance abuse in the form of smoking. In fact, you'd be shocked to know that almost 50% of doctors smoke. in spite of knowing the harmful effects. I don't know why. I mean, I met recently, like I had to go to Max Manesar and Fortis Manesar. So, like the lead surgeon there, robotic surgeon, I mean, dynamic chap, no? And he's from, I think he's from Anantnag or he's from Kashmir, right? He's from Kashmir, Anantnag, or I forgot, like, you know. But anyway, like a dynamic chap, right? Robotic surgeon, and he did it from Jammu, and almost 10 years of experience. And I found him smoking outside. So I just went out, shook hands, and like, how are you? The usual camaraderie. And then I was like, boss, ye kya? And he's like trying to hide that cigarette. मैं कहा यार मैं तेरा senior हूँ वो तो ठीक है, but that doesn't mean कि यार तू you will break your lungs across. So like a lot of time, you know, most doctors are like, I don't know why. I mean क्यों कर रहे हैं मुझे समझ नहीं आता. But then मतलब ठीक है, यंग एज में एवरीबडी डज एंड एक्सपेरिमेंटेशन इज ओके. यहाँ तक एक्सपेरिमेंटेशन की बात है वो ठीक है. बट इफ समबडी इज लाइक, आई विल बी ऑनेस्ट एंड ब्लंट विद यू आल्सो, कि अगर आप भी बीच में उठ के सुट्टा मारने जा, अकेला कोई सिगरेट पीने जा रहा है ना, या अकेला कोई दारू पी रहा है, दैट्स द कॉज ऑफ प्रॉब्लम. इफ यू आर अलोन एंड यू स्मोकिंग, that's the cause of problem. You 4 5 guys, and like I'm not being judgmental, I understand young age hai, people trying to experiment, look cool, etc. So once in a while chalta hai yaar. So experimentation is different from addiction, where it is like चल यार सिगरेट पी के आते हैं, चल यार दारू पी के आते हैं. That is what is the problem there. So yeah. Okay, coming back to the agenda, I just wanted to educate young doctors regarding the harmful effects of that, because that makes you mentally weak, man. I mean, if you are drinking, if you are smoking, there's so many things in life that you can do to, you know, overcome stress. But like, don't do that, right? That's my suggestion, apart from the coaching part that I'm telling you. And coming back to the agenda now, PD, देखो, young, I am not being judgmental. I'll be very frank with you. You know, when you are in college and you know, young guys and testosterone, I understand कि चल यार मार के आते हैं, लड़ाई करते हैं, you know, something things, crazy things happen with boys. But after a while, you need to like man up and say, yaar, enough is enough, and now no experimentation. Okay, fine. Coming back to the agenda, PD, AD, head injury, drug overdosage, any of these situations, the biggest risk factor in all of these patients, whatever be the scenario given in the question, your answer will be that in all of these conditions, the gag reflex and the smoke and gag reflex and the cough reflex will get suppressed. And because of the gag reflex and the cough reflex will get suppressed, that is when you get a aspiration pneumonia developing in these patients. And as far as the aspiration pneumonia occurring in a patient, then what is the organism that is responsible here? The organism that is responsible here is anaerobes. Then the organism that is responsible here is anaerobes. जिम भाई एक ही बार ज्वाइन होता है और वो होता है ब्रेकअप के बाद में. Just joking. Okay, anaerobes are the leading cause of organism that is responsible in this case. So the oral cavity, the most common organism in the patient, the most common organism in the oral cavity happens to be anaerobes. To get your attention back, please comment on one more question. What is overall the most common organism? Overall, what is the most common organism which is present in the GI tract? Waiting for your answers. What is the most common? चलो most common organism in the GI tract is most common organism in the GI tract. No, it's not E. coli. No. Okay, if you're saying E. coli will come when you will be going to Golgappe wale bhaiya every day and eating Golgappas, and that Golgappe bhaiya has never washed his hands ever in his life. That is when E. coli. Sir, it is not E. coli. E. coli will come and will cause diarrhea if you're eating like from a local place. H. pylori causes gastritis. No, it is not H. pylori. The number one organism in the GI tract is anaerobes. That is bacteroides, man. The most common organism of the GI tract. This was a question in the paper. I'm not doing a chit chat with you guys. The question said, what is the most I keep on doing chit chat in between. This was not chit chat. The most common organism in the GI tract is anaerobes. And what is the commonest organism? That is bacteroides. And why are they living in the body? Because they live in symbiotic relationship with human body. What is that symbiotic relationship? We give them shelter. And what are they producing for us? Vitamin K. जो anaerobes होते हैं, they are basically anaerobes. They are like living in our body. We are giving them place to stay. And what are they doing? They are producing vitamin K for us for the gamma carboxylation of 2, 7, 9, and 10. So a lot of miscellaneous data which is present here, but I hope I've been able to communicate to you guys right now, right here, that the number one cause of pneumonia in any patient having a suppressed, yeah, jhalmuri also, exactly. Exactly. I know what you are leading to. Okay. Suppressed gag reflex and suppressed cough reflex is the reason why this would be occurring. And now we come to that question, which are gonna be like always asked in the exam. The green color slide, the unmistakable green color slide of Gomori methamine stain. One, they will just give a photo like this and they say, what is the stain? So your answer is, this is a fungal stain. This is the Gomori methamine stain that I can see. What are you seeing in the stain is the black cyst of Pneumocystis jirovecii. So this is what is called as a crushed. This is what is called as a crushed ping pong ball appearance. This is again a question of micro slash medicine slash pathology. Crushed ping pong ball appearance. Crushed ping pong ball appearance of the cysts of Pneumocystis jirovecii. The older name for Pneumocystis jirovecii was obviously Pneumocystis carinii, but yeah, currently the name would be totally different. So here, like Gomori methamine stain, crushed ping pong ball appearance, your answer would be what I think everybody is now getting a hang of, that is Pneumocystis jirovecii, which formerly was called as jirovecii, which was formerly called as carinii. The trigger in the question will be immunocompromised patient, like he will say HIV positive patient. Don't rely on CD4 count. CD4 count can be low, even TB can come. Mark my word there. Don't rely on CD4 count. What will you rely on? You will rely not on CD4 count is not diagnostic. CD4 count is not diagnostic. It is chest X-ray and the sputum staining with Gomori methamine stain, which is gonna be diagnostic. Don't rely on CD4 count. That can be a distractor in the question. CD4 count is never diagnostic of any infection. It is suggestive of an infection. How will you identify? The X-ray will be bilateral infiltrates. The main identification will be, he will say HIV positive patient came with breathing difficulty. He was having cough also. He was having breathing difficulty. The doctor did a chest X-ray that showed bilateral infiltrates, and sputum staining with Gomori methamine stain shows that ping pong ball appearance that I just explained to you. This is evidence-based medicine, that we don't rely on CD4 count. Yeah, we can do bronchoalveolar lavage also if the person is critically sick and he is not able to cough. Then yeah, instead of sputum, I can go for bronchoalveolar lavage also. But the point I want to bring to your attention is, the more important point I want to bring to your attention is that Pneumocystis jirovecii diagnosis is not based on CD4 count. It is based on X-ray showing bilateral infiltrates and sputum stain with Gomori methamine stain / ball showing pink ball appearance. Then this can be a two-step question in the exam, and he will say, how will you treat this patient? Your answer will be trimethoprim and sulfamethoxazole. The last question on this slide before we move on to the next one, can you tell me what is the best way to prevent this infection? What is the best way to prevent this infection? So direct fluorescent antibodies would usually not be required. It is Gomori methamine stain that is sufficient for diagnosis, and a chest X-ray with increased alveolar gradient. How do you prevent this infection? Yes, guys, more people to comment. Nadeem has already done. Pentamidine, okay. The answer will be same. Trimethoprim and sulfamethoxazole will be used for prevention of this infection also. And alternative name for this particular patient is cotrimoxazole. Pentamidine is used only in those circumstances where there's an allergy. Like suppose I say to you that the person is having sulfur drug allergy. I'll just write it in case. Like suppose there is a sulfur drug allergy. Then I cannot be giving trimethoprim and sulfamethoxazole to the patient. So I will go in for pentamidine nebulization, and that will help me in managing this patient. The important thing that I would now like to tell you is, and that looks very surprising when you read it the first time, that we also give steroids for management of this particular infection because of the inflammatory changes in the lungs that need to be reduced. Mark my words, the steroids are used only in the treatment part. Steroids are not used in the prophylaxis part. Steroids obviously not in prophylaxis. It is gonna be in the treatment part that the steroids would be used. So trimethoprim and sulfamethoxazole with steroids. If there is severe respiratory distress, if the PO2 of the patient is less than 70, if NEET PG aspirants, if you're listening to me carefully, there was a question in which ABG report in this case was given. So remember, if the PO2 of the patient is less than 70, that is severe hypoxia, then we will give steroids. On this, the query of lot of doctors is, sir, why are we giving steroids in pneumonia? Will that not decrease immunity? Normally, we are taught never give steroids in infection. So my point is, in COVID also, when we were killing the organism, inflammatory reaction was being set up. and that was worsening the patient and causing into ARDS. When COVID virus was dying, when body was killing the COVID virus or antiviral drugs were being given, patients were going into cytokine storm. If you remember 2021-22, when we were treating patients with remdesivir, when we used to give remdesivir, the virus used to die. But the bad news is the chemicals or the inflammatory mediators released during the killing of the virus, they used to cause a cytokine storm and patients used to deteriorate. In the same scenario here, when you kill Pneumocystis jirovecii, NEET PG aspirants, be very, very careful. If you kill Pneumocystis jirovecii, then it can trigger a cytokine storm in a patient, and therefore steroids would be given. In FMG exam, they've not asked this, so I'll not be vocal about it. But in NEET PG, they've asked, like the ABG report was given, PO2 was 70. The answer will be trimethoprim sulfamethoxazole with steroids. What is trying to say is that you are killing the bacteria and is still causing respiratory distress. You see, normally when you kill the fungus, the person should be improving. But here the doctor gave the treatment and the respiratory distress worsened. तो बोला अब क्या करोगे? So it is that you will give, obviously you will continue with the anti microbial, but you will add steroids in the regimen because you want to take care of the impending cytokine storm that could be developing in a patient. Yes, Shiva Balan, you're perfectly right for that word cytokine storm that was occurring in COVID, and I'll repeat that cytokine storm concept again. When we were killing COVID with remdesivir, that is why remdesivir we stopped. We loaded the patient with methylprednisolone, and what is the price we had to pay? Mucormycosis came in. Mucormycosis came in because we were using hypotensive steroids in a patient. So one problem, you give a solution, a new problem comes up. So in COVID, we were very busy because there were no established algorithms. But here the established algorithm is that when you are gonna take care of this patient with trimethoprim sulfamethoxazole, when you kill the infection, then the cytokine storm that may occur, not all cases, but if it is occurring, then we have to give steroids. So take care of the fact that if he mentions PO2 less than 70, respiratory distress, or makes it fancy by saying words like alveolar arterial gradient is increased. PO2 less than 70 / increase alveolar arterial gradient, steroids would be given for management of this patient. This covers a list where I have tried to cover micro, I've tried to cover some pathology, some medicine component, overall rolled into one. I would rate this as the second most important slide for today. After that initial inputs that I gave you, every word that I have said on this slide is a question from the previous years. Every word that I have said on this slide is a question of the previous years. This is a non-negotiable slide. This is a non-negotiable slide. And all aspects, including the ones at the bottom, like aspiration pneumonia, head injury patient, everything that I've said are questions of the previous year. So you need to give the respect to the slide as warranted. I mean, when I'm saying it is important, it has to be important. Non-negotiable data on this slide, never to be forgotten from the RESPI domain. Now we will talk about ARDS, that is acute respiratory distress syndrome, where the lungs will become totally white in the patient, extensive bilateral whiteout in the patient. We did not, sir, medical science is not hit and trial. We do randomized control trial and then we do meta-analysis. So I will modify your statement, Kastub. It is like we do RCT, and then after doing a randomized control trial, some people will get treatment, some will not. We see the effectiveness and then we do a meta-analysis. That is how science operates, man. That's how science operates. There's no other shortcut, right? We can't say कि 200 साल पहले कोई जड़ी बूटी थी, है ना, उस किताब में लिखा है कि वो फलानी बीमारी में काम करती है, कैसे काम करती है पता ही नहीं है. We do proper, I mean, that's how science operates. Okay, so what is the most common cause of acute respiratory distress syndrome? I would like you guys to comment and easier questions at the moment. What is the overall most common cause of, I understand somebody lost dear one in COVID, very bad feelings. Most common cause of ARDS is very good. But I think मैंने ये बताया हुआ है एंड इसमें गलती नहीं होनी चाहिए थी. द मोस्ट कॉमन कॉज इज नॉट सेप्सिस, सर. द मोस्ट कॉमन कॉज इज निमोनिया, देन इज सेप्सिस. आई हैव सेड इट 100 टाइम्स. इवन मेडिसिन में तो हम इतने साल से बोल रहे थे. देन वी ड्रॉप द ईमेल टू रॉबिन्स. तो अभी जो रॉबिन्स का नया एडिशन उसने भी ठीक कर दिया. अब पैथो वाले भी जाग गए. पैथो वाले तो रिच पीपल होते हैं ना, गुच्ची का बैग यूज करते हैं, YSL का बैग यूज करते हैं. स्पेसिमेन ही तो काटना है, 3 घंटे काम करना है. तो वी वर सेंडिंग मेल्स टू रॉबिन्स के ऑथर्स कि सर इट इज निमोनिया गिवन एवरीवेयर एंड यू आर सेइंग सेप्सिस, सो इट इज कॉजिंग कंफ्यूजन. तो द लेटेस्ट एडिशन ऑफ रॉबिन्स हैज फाइनली वोकन अप एंड दे सेड अच्छा चलो, है ना, तुम बोल रहे हो तो सही होगा, राइट. भाई कहाँ 4 घंटे काम करना है ना, 4 घंटे स्पेसिमेन देखना स्लाइड में माइक्रोस्कोप में, कॉम्फी सा एनवायरनमेंट होता है, ऐसे कॉफी का मग लेके है ना, यू आर पियरिंग इट टू माइक्रोस्कोप, गिविंग अ रिपोर्ट एंड देन यू राइट प्लीज कोरिलेट क्लिनिकली, एंड द गाय इन दैट वार्ड 24 घंटा ड्यूटी कर रहा है, हर पीस का बैग, यस। तो दैट गाय हु इज डूइंग 24 आवर्स, व्हेन ही सीज दैट प्लीज कोरिलेट क्लिनिकली ना, तो शरीर में आग लग जाती है आपके, यू नो, यू सेंड अ रिपोर्ट, उस पे लिखा होता है ना प्लीज कोरिलेट क्लिनिकली, तो यू फील दैट रेज आउट ऑफ योर बॉडी कि भाई मैंने भेजा क्यों था तेरे को, पैसे कमाने के लिए, ऐसे ही मांग लेता पैसे, हम दे देते तुमको। ओके, द मोस्ट, सी यू सेंड अ लैब रिपोर्ट बिकॉज यू थिंक यू विल गेट समथिंग एक्स्ट्रा, अदरवाइज क्लिनिकली थोड़ा बहुत तो अंदाजा लग ही जाता है। एनीवे, कमिंग बैक टू द एजेंडा, या most common causes pneumonia caused by followed by sepsis. If I change the question into direct cause, the answer is pneumonia. If I say most common direct cause, it is pneumonia. If I say indirect cause, then it is gonna be sepsis. So these are some of the important questions that are to be remembered. And now I will focus on what other things are you supposed to know. Other things that you're supposed to know from the perspective, like here I've just said pneumonia and sepsis respectively, but there are a couple of other causes also that should be remembered, general causes that should be remembered. One of the important causes that they always asked and was asked in NEET PG was, he gave a scenario of a person having acute pancreatitis, and he said third day the patient started having breathing difficulty with drop in saturation, x-ray was totally white, and he said what is the differential diagnosis now? Your answer will be that the patient of acute pancreatitis has gone into ARDS, acute respiratory distress syndrome. It is because of again the cytokines which are released during the pancreatitis process that cause damage to even the lung parenchyma. The next cause is TRALI, that is transfusion related acute lung injury. Transfusion related acute lung injury, the points to be remembered are, it usually starts within the 6 hours of transfusion, like you started the transfusion now, within 6 hours respiratory distress will occur. It is more common with fresh frozen plasma. It is more common with fresh frozen plasma as compared to blood transfusion. And how do you reduce the incidence of TRALI? How do you reduce the incidence of TRALI? The best way to reduce the incidence of TRALI will be that avoid multiparous donors. You see, if a woman has already had multiple babies and she's also had multiple blood transfusions, then her body will be full of antibodies. And when you will give her antibody blood to somebody, then these antibodies will attack the lungs of the recipient and will cause TRALI. The best way to prevent TRALI is avoid multiparous donors. What I mean by multiparous donors is, like this lady is a grand multipara. So she had multiple RH positive pregnancy. She's herself RH negative and she had RH positive babies. Along with that, she received blood transfusion also from various donors in these deliveries because she lost a lot of blood after delivery. So her body is loaded with antibodies against RH factor, as antibodies loaded against the antigens on the RBC. So when you will be giving the blood of this multiparous donor to somebody, then the antibodies will attack the pulmonary endothelium of the recipient and will trigger TRALI in the patient. So just remember, multiparous woman is loaded with too much of antibody, and if you give her blood to somebody, TRALI as a manifestation can occur. The next case that I would like to mention for ARDS is this guy. He was drinking and driving a bike. He had a head injury. Now he is brought to the hospital and you are supposed to do a rapid sequence intubation. When you're doing a rapid sequence intubation, the bad news is that while you were doing intubation, the patient vomited and he aspirated a lot of stomach secretions. Aspiration of stomach secretions or aspiration of gastric contents, as Anjali also put in, is called as Mendelssohn syndrome. So whenever you are doing, like, why anesthesia people are so particular about not consuming anything for minimum 8 hours before surgery is right in front of you, that aspiration of stomach contents is a disaster and can kill the patient even before the surgery starts. And especially in emergency, when we have to intubate patients who are full stomach, it could result in Mendelssohn syndrome in a patient that will cause chemical pneumonitis. The last entry that I would like to say is the worst industrial disaster in the world. The worst industrial disaster in the world was Bhopal gas tragedy. People in India woke up to a gas entering their houses. That is methyl isocyanate. When gas was entering into the houses, what happened was that people started rushing upstairs. They thought that they'll be safe. The bottom line is that when a gas leak happens, you are supposed to lie down. You are supposed to cover your face with a wet cloth. You're supposed to close all the doors and the windows, and you're supposed to lie down because most gases are lighter than air, so they tend to float. Here, what people did was, because they found that there was this smell of the gas, they tried to go outdoors, or they tried to go to the upper stories of the house. And if they will go upstairs, or if they go into the open area, then there will be more exposure to gas. What they should have gone is, they should have gone into the basement, and in the basement they should have lied flat on the ground, because gas will be higher, so it will remain above the level. So this is a normal, like, a drill that happens. Like, lots of time chemical drills are conducted in malls, etc. So you will see Indians laughing when drills are conducted in Japan, when drills are conducted in Israel, when drills are conducted in Dubai. Everybody follows the rule. Now they made it a rule, no? Dubai, when the drone alarm will come, on your mobile notification will come. Imagine, within your mobile phone, you put on silent. Like Dr. Azam was telling me, he put his mobile on silent at night, and the whole phone, he had 2, 3 phones, Indian phone, US, Dubai phone. Whether you are using Indian number, Dubai number, doesn't matter. The phone will start vibrating because you are in that drone area, and it will be a total shocking red color alarm. Screen will become red. It's an alarm saying go to the basement. It will not shut off by itself, right? You can't just turn it off. And after 5 minutes, message will come. We have intercepted the device. Care about their people, no? They care about their people. So the point to be understood is, toxic gas inhalation can result in, and drills are to be taken very seriously, sir. Drills are to be taken very serious. Even plane drills, no, aeroplane drills. If fire will break out, everybody will stand up. You're supposed to go down. Nobody understands that. Recently, you would have seen a Japanese airline plane caught fire on landing, and within 1.5 minutes, the whole plane was evacuated because they were Japanese. Imagine now Indians. First they will pick up the bag, then they will elbow somebody in the nose, and फिर वो गाली देगा मोटी वाली, है ना? उसके बाद में then they will be going there. So it is like, I mean, discipline है ना यार, civic sense. Educated people in India, I mean, anybody who's flying by plane would be earning something in the range of 30, 40, 50 lakhs. Only then, net worth of the family, right? Must be 30, 40, 50 lakh to understand that you fly by plane. And here people will be, पहले तो मारेगा बाजू ऐसे कि हट पीछे. And that is when the problems would be occurring. And in Japan, within 1.5 hours, nobody picked up their baggage, man. Everybody went down the emergency chute, and you'd be shocked to see that video. After 2 minutes, the whole plane caught fire, and the whole plane became like unrecognizable. I mean, the whole jet fuel, no, because jet fuel was leaking from the engine, and like the whole plane caught fire, and I mean, all of those people would have been burnt alive, right? So toxic gas inhalation, and for toxic gas inhalation, I mean, that's again a chemical drill which is lacking, but I just wanted to explain to you at this particular point of time. Yeah, I understand. Drills, notifications, Philippines, Ukraine, again, they're doing a great job, man. And they take things seriously. I mean, everybody, citizen, you feel a part of the government, right? You don't say ki inka kaam. Anyway, coming back to the agenda, these are a couple of important causes. Now I will teach you regarding, now we will talk about diagnostic criteria for this condition. The most important statement for ARDS. The most important statement for ARDS is what comes now. This is the word that you're supposed to pick up in the MCQ, PaO2 FiO2 ratio. इसको रटना है. PaO2 FiO2 ratio less than 300 is the main diagnostic criteria. Yeah, Chernobyl had a different story. PaO2 FiO2. I'll not get into Chernobyl now. We'll lose the focus then. Right, PaO2, FiO2, the value is less than 300. That's one of the main diagnostic criteria for this condition. And ARDS, the second important statement is ARDS is an example of non-cardiogenic pulmonary edema. There is यहाँ पे bat wing edema नहीं होता है. Bat wing edema is cardiogenic. Here heart is not involved. Like COVID will attack lungs, pneumonia will attack lungs, chemical pneumonitis will attack lungs, toxic gas will attack lungs. Heart is not getting involved, but still there is a pneumonia. There was no heart failure. COVID pneumonia or sepsis or pancreatitis or TRALI, is it attacking the heart? No, it is attacking directly the lungs. So because the attack is directly on the lungs, therefore this would be a non-cardiogenic pulmonary edema occurring here. And how will the examiner write the word non-cardiogenic pulmonary edema? वो तो क्योंकि English से आप बता दोगे ना यार कि the heart is not involved, so it is non-cardiogenic. He will write the fact echocardiography of the patient shows left atrial pressure is normal, because if the heart is involved, the left atrial pressure will rise, because usually when the heart is involved, left ventricle will fail, then left atrial pressure will also be elevated. A indirect measure of to find whether heart is failing or not. A indirect way to find whether heart is failing or not, do a echo. If the pressure of the left atria is elevated, that means heart is failing. And if the pressure is normal, that means the heart is not getting involved in the patient. So non-cardiogenic pulmonary edema is a main feature which is present here, along with X-ray showing bilateral infiltrates within 7 days of lung injury. Guys, what I'm teaching you at the moment are technically called as Berlin's criteria. Berlin's criteria, Berlin, the country in West Germany, the city in West Germany. Berlin criteria are used for diagnosis of. That's again a question. Berlin's criteria is used for evaluation of. Answer is ARDS within 7 days of insult. Within 7 days of any kind of insult, the insult can be toxic gas inhalation, it can be pancreatitis, it can be toxic gas inhalation, or all the examples that I said. If within 7 days of insult, X-ray will turn totally white, echo report is normal, and PaO2 FiO2 ratio is less than 300, it is ARDS. I'll say the fact once again, try to learn with me. If within 7 days of the insult could be toxic gas inhalation, it could be trauma to the chest, it could be chemical pneumonitis. If the lungs turn totally white, the echo is normal, that means heart is not involved, and the PO2 FiO2 ratio is less than 300, it is ARDS. If you find that too much to remember, remember one word. In any MCQ, if PO2 FiO2 ratio is given, it means that the question is on the topic of acute respiratory distress syndrome. This is a pure non-cardiogenic pulmonary edema because heart is not involved. And now he will ask, what is the treatment? For the treatment part, first I will give an explanation, then I will make you underline the data. Normally, you are all aware, tidal volume. Tidal volume is the amount of air that goes in the lungs and out of the lungs, one breath that we take. Normal tidal volume is 12 ml per kg. Normal tidal volume on the dashboard of the ventilator is taken as 12 ml per kg. Like for 40 kg man, I will take something like 480 ml. For 80 kg man, I will take something like 960. So the tidal volume depends on the weight of the patient. Now in ARDS, like at COVID time, when we were ventilating patients at 12 ml per kg, we were not realizing that the lungs are already injured. Already lungs में damage है. We were ventilating at 12 ml per kg, and what was happening is कि lung burst कर रहे थे, pneumothorax हो रहा था, left, right, center. In COVID time, we were ventilating patient at 12 ml per kg, and lungs were bursting of patients. There was pneumothorax that was happening, and we realized we are doing wrong. Then we changed the strategy, and we decided to give ventilation at 4 to 6 ml per kg of body weight, in contrast to what was initially being done. And we found that now the patients were doing very well. So the first thing is, with respect to ARDS, we go for low volume ventilation, we go for low tidal volume ventilation. That is, we deliberately select low tidal ventilation because already the lungs are inflamed, the alveoli are having inflammation, the alveoli are injured. So we will deliberately select lower tidal volume to prevent barotrauma, to minimize the chances of barotrauma. There's a second parameter on the ventilator setting called as PEEP. PEEP stands for, the name is peak and expiratory pressure. This peak and expiratory pressure is simply to prevent the collapse of the alveoli. The full form of PEEP is peak and expiratory pressure. The value of this is round about 5. We can increase up to 6, 7 also. The peak and expiratory pressure, what it does, it tends to prevent the collapse of the alveoli. If you prevent the collapse of alveoli, then there will be more surface area available for gas exchange. So there are two technical things I want to say at this moment, that for any patient of ARDS for ventilation, what we should be doing is that we should be selecting low tidal volume. We should be selecting the lowest mathematical value tidal volume appropriate for a person, that is low tidal volume should be selected. But the PEEP that should be selected should be of the highest that can be tolerated, that is 5, 6, 7, 8. Lower limit is 5, upper limit is 8 centimeter of water. So the point is that the PEEP that we select, that should be selected at like the highest possible value to keep more alveoli open for more surface area. And the tidal volume should be kept at the least value so as to prevent the bursting of the alveoli during the phase of inspiration, because the alveoli are inflamed. In the exam, he created permutation combinations. What were the permutation combinations created of tidal volume and PEEP are in front of you. Options were, both values were low, low. Both values were high, high, low, high, high, low. I'll say this again. In the MCQ, one option was high tidal volume, high PEEP. One option was low tidal volume, low PEEP. What will you select? I have tried to explain to you with rationale that select the lowest tidal volume to minimize the barotrauma. But for PEEP, select the highest variety of PEEP so that you can get more alveoli to open, so that you get more surface area and you prevent the collapse of the alveoli. the selection will be low tidal volume and high PEEP. अब इसको उल्टा मत कर देना, उल्टा मत कर देना. So like tidal volume को लिखे तो ऐसे 2 अल्फाबेट हैं तो low word कर देना, और PEEP में 4 अल्फाबेट्स हैं तो it is like high. I mean that's just a hack to remember. Otherwise obviously you are smart guys and you will not fall in the trap. But I just want to say, just in case you say कि सर याद नहीं हुआ, then how to remember is TV tidal volume is 2 alphabets, so the word is low. And PEEP is 4 alphabet, so it is like high. So low tidal volume and a high PEEP, as Kevin mentioned very rightly. Write it, man, write it, in your notes, or write it, or type in the chat box so that you remember that low tidal volume and a high PEEP is the main way for management of this patient, and that is what is technically called as low volume ventilation. This is the main strategy that we use for management of patients of ARDS, that is low tidal volume ventilation. Additional point which I want to bring to your attention is that this is the only condition where you will be keeping the patient in prone position. If you remember 2021, when somebody was having pneumonia, we used to tell patients ki pet ke bal leto. You would have seen so many advices of senior doctors coming that all pneumonia patients should be lying on the tummy. Prone position improves ventilation. Studies have shown that prone position improves ventilation in lungs which are damaged by COVID-19, which is going into ARDS. So prone positioning, yeah, that helps in recruitment of alveoli. It causes a better gas exchange. So this is again a very peculiar position, because normally though like all patients will be lying supine or partially sitting up, but here it would be like prone position that is recommended. In fact, this is the only condition where you will say prone positioning. The third point is only for COVID. COVID is still around, but this entry is only for COVID. If a person is having COVID-19 pneumonia, then to prevent the person from, it redistributes the blood flow in the posterior lungs. Exactly, Ashok, you have a point. COVID-19 pneumonia, he says you have to give steroids also to the patient, that is methylprednisolone. So that culminates the topic of ARDS in one single slide. This point number 3, don't answer steroids for like pneumonia, don't answer steroids for like pancreatitis induced ARDS. Don't answer steroids for trauma or like chemical pneumonitis induced ARDS. Only if he specifies the word COVID-19 will you answer methylprednisolone in management of ARDS. And though I have been like saying this term again and again, please answer for my satisfaction. What is the cause of death in COVID-19? Why did patients of COVID-19 die, by the way? You can add it here. Cause of death in COVID-19, pneumonia. Like patients were having pneumonia, then they were dying. So what was the cause of death in COVID-19? Yes. Like when I was a student your age, then there was like this SARS virus. No? Now this is called as SARS-CoV-2. COVID-19 is called as SARS-CoV-2. When I was like a MBBS student, then SARS came. And then we had swine flu, then we had bird flu, right? So all of them cause death ultimately. Nowadays, they don't cause death because they've been curtailed and we have antibiotic treatment also. What is the cause of death in these patients? Guys, good morning. The cause of death is ARDS. In all of these infections, what is the cause of death? Answer is acute respiratory distress syndrome. No, guys, the answer is ARDS. Why does a COVID patient die? Why do a SARS patient die? Why does a swine flu patient die or a bird flu patient die? If the treatment is not started, these patients will go into what we just discussed right now. Topic of interest. Good morning. Swine flu, bird flu. They would contribute to development of death due to acute respiratory distress syndrome. So ARDS is the cause of death in that's why we discussed the topic na bhai, respiratory, like what causes these cases to go bad. Like in Hindi we used to say इनका pneumonia बिगड़ गया है. We used to say आपके पिताजी का या आपके दादाजी का निमोनिया ना खराब हो गया, डबल निमोनिया हो गया. तो नॉन मेडिकल कह रहे हैं डबल निमोनिया हो गया, तो डबल निमोनिया तो दोनों लंग्स खराब हो गए. I mean non-medicals will not understand ARDS ना, they are not going to understand why this is like totally white. वो तो एक्सरे फिल्म देखे बोले सर ये इतना white कैसे, तो बोला डबल निमोनिया हो गया. So that's when they figure out अच्छा मतलब केस बिगड़ गया है. Like, I mean that's just a way to explain, because see not everybody is a technical person like you and me that you can explain things like that. So we used to say नहीं यार इनको ना डबल निमोनिया हो गया आपके फादर साहब को, तो that's like the people are able to relate to the illness also. So we will manage the patient on a ventilator, guys. ARDS is not something that can be managed at home. Obviously it is managed in the hospital in prone position. You have to intubate the patient and manage him with the word being low volume ventilation. The most important word is low volume ventilation. That's the word Yes. Low volume ventilation. Uh, no, why will we give steroids in SARS and flu? हमारे पास दवाई है ना यार. ओके, अब आपने पूछा है तो मैं बोल देता हूँ यार. आई थिंक ऑल ऑफ यू आर अवेयर ऑफ दिस. What is the what is the treatment for COVID-19? Which antiviral drug is given for COVID-19? Question open to everybody. You are a NEET PG aspirant, you are a ANICET aspirant, you are an FMG aspirant. कोविड-19 के लिए एंटीवायरल ड्रग बताओ प्लीज. रेमडेसिविर मत बोलना, वो तो पहले से ही बंद हो गई थी बिकॉज ऑफ लाइक इट फेल्ड टू शो मोर्टेलिटी बेनिफिट. सो टुडे oh man, remdesivir was like discontinued now because it was not showing any mortality benefit and the cytokine storm was more. Today if somebody has COVID-19 pneumonia बोल रहा हूँ, pneumonia, COVID-19 is still around, so you and me can have fever, we will take paracetamol and we will be fine. But if somebody will have COVID-19 pneumonia, then what is the antiviral drug that we will give? Come on guys, I expected answer here. You guys are taking it too casually in the chit chat. Molnupiravir. And I mean you cannot say कि सर मुझे नहीं पता है कि COVID-19 निमोनिया के लिए क्या दवाई यूज होती है. नहीं भाई नहीं, that's all old thing. Nirmatrelvir, that also came up. This is WHO approved. आप गूगल करो, डालो जरा, चैट जीपीटी गलत बताता है. WHO approved is Molnupiravir, that is COVID-19 pneumonia. No, बच्चे, all those are old things, you know. That is what chat GPT will keep on throwing at you. COVID-19 pneumonia, the WHO approved drug is Molnupiravir is the main drug that is used. So don't get carried away by the discussion कि हाँ सर आज तो easy topic है तो I know everything. It's not like that, ना. H1N1 is Oseltamivir. You don't need to give steroids, sir. Why are you giving steroids? To prevent the conversion into ARDS. निमोनिया के लिए थोड़ी ना स्टेरॉइड देते भाई. मैं आई हैव बीन लाइक लिटरली स्क्रीमिंग माय लंग्स आउट मैन. आई मीन द कमेंट सेड कि मैं समझा ही नहीं पाया. If somebody is having a pneumonia by a particular agent, you are gonna kill it, right? Giving oseltamivir to swine flu, bird flu, nobody gives a damn to COVID nowadays क्योंकि molnupiravir है. If somebody has a pneumonia, suppose somebody is dialysis dependent, type 2 diabetes, has a pneumonia caused by COVID-19, molnupiravir. If you and me will have COVID-19, paracetamol. उसका भी जरूरत नहीं है ना. Maybe one paracetamol or any other painkiller, that alone would be required in the patient. COVID-19, H1N1, influenza A, H3N1. For that we have to give, that Paxlovid. That is, yes, that's again a question of your exam. Respiratory syncytial virus. That Paxlovid, that is used for management of respiratory syncytial virus, and H3N1 is amantadine. For any particular infection, doctor, you have to give a specific treatment to the patient. If the person is deteriorating, when you kill the organism and there is release of inflammatory cytokines and there is deterioration going towards cytokine storm, that is where you can easily be remembering, then you can easily remember regarding that we have to give steroids to a patient. So ARDS, specifically COVID, he has mentioned steroids. Otherwise, this is the basic treatment that you will be giving for this particular patient, like molnupiravir, then is oseltamivir, amantadine, Paxlovid for respiratory syncytial virus. So the point is we give specific treatment to our cases. Specific treatment to our cases. Okay. So we sorted for ARDS, acute respiratory distress syndrome, and it's not a adult version of RDS in children. वो बच्चों में होता है RDS. Respiratory distress syndrome is that surfactant deficiency that will be occurring in children. So this is one slide that covers that entire data. Berlin's criteria में PO2 FiO2 ratios of paramount importance, and 2 points guys जो I expect you never to go wrong. 3 points that I want you to never go wrong is what is overall the most common cause pneumonia. Point number 1. Major diagnostic criteria, PO2 FiO2 ratio less than 300. Third aspect, tidal volume low and high peak. I will say them quickly, 5 seconds for each. Number 1 cause pneumonia. Diagnostic criteria, PO2 FiO2 ratio less than 300, and it is low tidal volume and high PEEP that would be used. They will obviously be describing long case of pancreatitis, requirement of blood transfer, requirement of fluid requirement, analgesia, and then subsequently the bilateral whiteout given in the X-ray, the echo report given normal, the PO2 FiO2 ratio less than 300, and within 7 days of the insult, that is Berlin's criteria, would seal the diagnosis with ARDS for you. If it is a 2-step question, then he will say, what will you do? So you will say, I will be placing the patient in prone position after intubation, first intubation, then proning, and then prone ventilation with low tidal volume ventilation. Okay, guys. So I think we are sorted for ARDS. Now we'll talk about COPD, which is going to be present in cigarette smokers, obviously, and they can end up with the damage to their lungs. So I have a question for you. There is a woman from Haryana. She does not smoke. Like sometimes rural women might be smoking BD, but like this woman does not smoke, but she's having COPD features. What is the cause? A woman from Haryana, Rajasthan. She's a non-smoker, but she is having COPD features present. What is the cause exactly? It is the chula that is responsible for it. What is the technical word you'll be using for that will be, the technical word that you'll be using is that this lady could be having is a development of anthracosis. Anthracosis would mean that what can happen in these patients is the use of chula, that is use of wood. जैसे आप देखे होंगे वो दिखाते हैं टेलीविजन पे दिखाते हैं दैट विमेन इन इंडिया आर गोइंग इन द जंगल एंड फ्रॉम जंगल वो सूखी लकड़ी लेकर आते हैं, दे गेट दैट वुड एंड देन दे यूज इट फॉर कुकिंग. सो इफ यू आर यूजिंग wood or you are using that gobar ka upla, right, cow dung, right, cow dung in any village in India, man, anywhere you go to you saw the cow dung cakes. So that cow dung cakes are being used for cooking. So wood, cow dung cakes, coal. Now obviously that Pradhan Mantri Yojana is there, that gas cylinder is being given, no, that Ujala thing is coming up, right, that I mean, obviously the two schemes, Ujala, Ujjwala, you guys know better about it. But then what I'm trying to say is that what is happening is that women in rural India, they are having inhalation of soot in the lungs. They're having that black carbon fiber going in the lungs, and that is what is technically called as it is LPG cylinders that need to be given to the patient, right? Ujjwala, exactly. Ujjwala is the correct word for them. So anthracosis is a manifestation with wood, cow dung cakes, and coal used as a fuel, and that can cause that soot to go in the lungs of a patient. And traditionally, it will anyway be a cigarette smoker, and all these patients will be having damage to the lungs, so they will have breathing difficulty. So we will now evaluate the grading of difficulty, that is by MMRC, that is Modified Medical Research Council grading of dyspnea. This Modified Medical Research Council of grading of dyspnea, grade 1 dyspnea is when the smoker is made to walk on an incline. The complaints of this guy is shortness of breath, but the shortness of breath is not on walking on straight surface. He says, when I'm walking on an incline, that is when I tend to feel a little breathless, like he went to a park, and like the park sometimes can be having an incline and then the track is going down. So while walking on the incline in the park, he's feeling a little uncomfortable. But when it comes to like MMRC grade 2, Modified Medical Research Council grading of dyspnea, here the person is having shortness of breath even on walking on a straight surface. Because he is having shortness of breath, you will also notice that the guy will walk very, very slowly. Like you asked him to walk like 100 meters only. You asked him to go from point A to point B, which is hardly 100 meters or 100 yards only. And you asked him to just take, but you will notice that the person will be experiencing shortness of breath. But this shortness of breath will be while walking on a straight surface. The guy is still breathless. Shortness of breath is like uniform. So I'll remove the word SOB all the time here because that is uniform. Obviously, because I'm talking about dyspnea, the dyspnea means shortness of breath only. Dyspnea means shortness of breath only. Here, what you will notice is that the question will say that the patient walks slowly, like you are making him walk with his wife. This smoker is 60 years of age. His wife is 60 years of age. Wife is a non-smoker. Husband is a chain smoker. So both 60-year-old patients are walking together, like for a walk from point A to point B. So he walks slowly than the peers and is not able to catch up with his wife. So you just encouraged him gently that, see, if she can walk a little faster than you, why don't you try? And he's saying, okay, I will try, but he will not be able to catch up with her. Like if you make him walk fast, you will make him, like you will see the panting, you will see the visible breathing difficulty that comes up in this patient. So walks slowly than the peers of the same age group. Meaning of the word peer is that person of the same age group is walking with this patient. We are not making him compete with like his grandson. His grandson is running here and there, like children keep on playing. So obviously I don't expect a 60-year-old man with COPD to keep up with a 10-year-old grandchild who's going to be playing and running and saying, Dadaji, let's play frisbee, let's play some cricket. So obviously he's not going to keep up. But This particular man, when he's walking with his wife of the same age group, or like with his friends of the same age group, he's walking slowly than the peers. Now, we take up this situation again. Stop noting for a while and hear me out, and then I'll give you time to note down. Like I asked this gentleman to walk from point A to point B. He came to me last year, 2025. Now he came to me in 2026. So he's still walking very slowly, still walking very slowly. But this time I noticed he stopped. So मैं उसको बोला क्या हुआ sir? I asked you to go to point B. He said, sir, like let me catch my breath. He's breathless. He says, doc, just give me 5 seconds, doctor. Can you give me 10 seconds, doctor? Like let me catch my breath. And then he again started walking. So this time I tried to be a little rude to him. मैंने बोला अरे यार मैंने बोला ना वहां तक चल के दिखाओ. The guy will still not be able to do it and will again stop intermittently, and he will be like a little now embarrassed. He says, doctor, like I'm sorry. He's being apologetic. He says, doctor, I'm feeling so breathless. No sir, give me 10 seconds, sir, give me 15 seconds. I will catch my breath. Next time I will try. Next time when he tries, again the same thing. He will walk maybe 20 steps and then again he will maybe try to do it faster, but he will go out of breath. So the difference between grade 2 and grade 3 is that the patient in grade 2 is also walking very slowly than peers. In grade 3 is also walking slowly than peers. But what is the difference? He stops intermittently. So I will write this data here. This is what the MCQ said. Patient walks slowly than the peers. Same thing. Patient walks slowly than the peers, but stops intermittently. No, this is not claudication. Claudication will cause pain. This is shortness of breath that I'm describing at the moment. If I was saying patient is walking 200 meters and is stopping intermittently, that is claudication, pain in the legs that are coming. But today we're not talking about claudication pain. We're talking about shortness of breath being experienced by an individual. The previous person was walking slowly than peers. In Burgers disease, where you're talking about claudication, patient will never walk slow. He will walk at the pace, stop. Normal pace, stop. Normal pace, walk. The word is normal pace and stop. That's intermittent claudication in that BDP ne wala thrombojatis obliterans. This is slower pace, stops intermittently. That would be grade 3. No, it's different from NYHA, and you are seeing the difference, Rohit. You are picking up immediately because in this particular patient, it is stopping intermittently. But if he is not able to do daily activity, if the patient is having shortness of breath on daily activity, what I mean by forget about walking. Daily activity would mean like change of clothes. Change of clothes. Now in NYHA, I had told you that change of clothes was an NYHA 3. I'll write down that also, but that difference is present. Too breathless, change of clothes, taking a bath. Sir, we don't even like a normal person will not even realize now that the person has to go to person has to take a bio break. Bio break would mean that person wants to go to the washroom and urinate. So it will take max a minute. Patient will go wash, flush, come out, right? Wash hands, come out. So max a minute. And here the guy would be like as if he's run a half marathon. So it is like either he will write the word too breathless to leave the house. Like you told the patient today, like yesterday it was very hot, but in the evening it was like a dust storm. Then it became a little cooler. So you told the man कि यार चलो थोड़ा सा ना सर आप थोड़ा walk कर लो ना. So he says no I can't. तो मैंने बोला क्या हो गया सर अब तो the weather is a little pleasant, it's not so hot, like it was 42 in the day and after the dust storm it was like 34 32, so 10-degree difference you tend to feel a little a little calmer with that environment. So I said, sir, take a walk. No sir, I can't do, no, I'm too breathless to walk. So what you will notice in the patient is if this kind of description is given in the question, too breathless to walk or go out of the house, refuses to go out of house, like suppose it rained. तो रेन्स के बाद तो थोड़ा सा प्लेजेंट हो जाता है ना, इट्स अ लिटिल इमीडिएटली आफ्टर द रेन्स, लेटर इट्स अ लिटिल ह्यूमिड एंड हॉट, बट लाइक इमीडिएटली आफ्टर द रेन द विंड इज ब्लोइंग, इट्स अ लिटिल comforting, it's a little relaxing, especially in a hot Indian summer. So I told the guy, sir, please take a walk with your wife, and like the guy is not able to do it. That would be MMRC grade 4. So I just want to bring to your attention, though Vipin has already written that if I give you a situation from the heart failure perspective, if I talk about heart failure perspective, and I say patient is having shortness of breath on change of clothes, like patient washroom गया, कपड़े चेंज करे, उसने नहाया था, नहाने की कोशिश करी, नहा नहीं पाया, चलो कपड़े बदल लेते हैं, ड्राई ऐसे मॉपिंग करके आ गया, उतने में ही सांस फूल रहा है, then you will say NYHA grade 3. Then you will say NYHA grade 3. आपको यही दो MCQ याद करने हैं. If he says heart failure patient is having breathing difficulty on change of clothes, then don't answer 4, then it is NYHA 3. But if he says change of clothes, minimal activity by shortness of breath, or by MMRC, it is grade 4. So that's the point I just wanted to say, that this point has been asked in the exam. Heart failure given, then you say NYHA, New York Heart Association grading of dyspnea is for heart failure patients. And here it is MMRC, Modified Medical Research Council grading of dyspnea. So at the moment, I wanted to talk about the symptom profile of a COPD patient who has been puffing his lungs across. Now we will talk about the GOLD classification and grades of COPD. This I will rate as again a very important slide for the first session today. GOLD 1, GOLD 2, GOLD 3, GOLD 4. Those are the common questions that would be present. Yeah, no dyspnea, that would be 0 now. If there's no at rest, that would be like, if it's totally fine, then it's perfectly okay. Okay, coming back. GOLD 1, 2, 3, 4. In all of these questions, he will say timed vital capacity. One of the main criteria for diagnosis of obstructive lung disease is timed vital capacity. Timed vital capacity in all of them will be given to be less than 0.7, less than 0.7, less than 0.7. So this will be just a filler option in the question. What are you supposed to check out is not the timed vital capacity. Most people check out only the time vital capacity. You are supposed to check out the FEV1. Now write with me, keep the focus on the board and write with me right now. If the FEV1 is more than or equal to 80%, you say person is having GOLD 1, that is mild COPD. But suppose he gives a question in which you notice that timed vital capacity is less than 0.7, and along with that you notice that the FEV1 of the patient is between 50 to 80%, then you will say it is GOLD 2. Now note the third point, timed vital capacity with FEV1 of the patient between 30 to 50%, then you will say it is GOLD 3, that is gonna be severe. And then comes very severe. When I say the word very severe, then very severe would imply that again the same thing is being satisfied, but there's a danger difference. The FEV1 of the patient is less than 30%. When this question came in NEET PG, a lot of guys casually, he asked severe, and a lot of doctors casually answered it as FEV1 less than 30%. Because the normal thought process is classification is mild, moderate, severe. Here it is mild, moderate, severe, very severe. उसने severe पूछा, students less than 30% आंसर कर दिया, जबकि आंसर क्या था 30 to 50%. So this was a value based question that was asked in NEET PG, and it was like just in the pressure of the exam that people got this question wrong. So इसको एक बार लिख के practice करना है. Normal classifications are mild, moderate, severe. This classification has mild, moderate, severe, very severe. Actually ये तो unofficial terms है guys. These are unofficial terms now. They don't use mild, moderate, severe. Now they will ask you grade 1, 2, 3, 4. And it's a fact to be remembered, so do with me. Time vital capacity sub mein, visualize with me without looking at the slide. I'll deliberately move it. FEV1, FEC ratio less than 0.7. 80%, 50 to 80, 30 to 50, less than 30. फिर से बोल रहा हूँ, फास्ट बोलूंगा. More than 80, 50 to 80, 30 to 50, less than 30. I hope याद हो गया होगा. यहीं पे याद करना. If you are being lazy and if you're not noting this, guys, if you think you want to do this by yourself later, it's not gonna happen. So make it a point. Note it right now, right here. GOLD grading of class COPD. First one's grading was dyspnea. Now is the overall condition of the patient, because we take into consideration the lung function, we take into consideration the obstructive lung disease, how bad it is, because proportional to how severe the disease is, we are gonna treat the patient, because the treatment will vary. Like, if somebody is having GOLD 2 versus GOLD 3, then I'll be more aggressive in drugs. If it's GOLD 1, I will be less aggressive in drugs. In any patient, based on the symptoms and the exacerbations, will be either less aggressive or more aggressive. It is rational drug usage that will be doing, and that is why this GOLD classification is like super important and is asked in the exam. GOLD stands for Global Initiative. GOLD is that global initiative for chronic obstructive pulmonary disease. I mean, that's just a term that they've used. GOLD, like, it looks very catchy statement there. It's a global initiative for management of COPD in patients, but then the word is like very fancy, and that is why people want to that's why the examiners want to hear about it. Now the next thing that I'll teach you is again super important, especially if you are a NEET PG aspirant. He will talk about GOLD groups. Earlier was GOLD classification as mild, moderate, severe. Now is the treatment groups in the patient. For treatment groups in the patient, A would mean that the person is having less symptoms, like MMRC maybe 1, maybe 2, and has not been hospitalized. But if I change the spectrum, Whereas say the patient has multiple hospitalizations, multiple exacerbations, then it will be like more aggressive treatment. I'll repeat my statement. From the treatment perspective in GOLD, he says that you have to create groups as A, B, and E. These ratios should be recorded after bronchodilators or without bronchodilator. No. Whenever you are, it's always post bronchodilator. Now all ratios are taken post bronchodilator only. No? All ratios are post bronchodilator only. Or after taking the medicine, all ratios are taken post bronchodilator. The best effort of the patient. Okay, it's post bronchodilator. Now comes the treatment part. The treatment part is GOLD groups. GOLD groups would mean now the classification has been changed. I'm giving you update. The update of COPD is that now we don't say A, B, C, D. If you listen to previous version, whether 6, 10, whatever, it was A, B, C, D. Now it is A, B, and E. Simple. A simply means that like the guy is having limited symptoms, maybe one hospitalization or no hospitalization. So I can use any bronchodilator. He says if person is having minimal symptoms, you can either use a SABA also or you can use a LABA also as and when required. I mean as and when required, and the patient will just do fine. But if the symptoms are more severe, like the person is having breathing difficulty and he is not able to do daily chores or is walking very slowly, then I should be giving in this particular patient. Yeah, the grading considered in COPD groups is GOLD or MMRC. This is symptoms. No, symptoms are MMRC. Symptoms are MMRC, and then this is symptoms MMRC. So we're taking into combination two things, MMRC, and we're taking into consideration hospitalization and exacerbation. Hospitalization is done for exacerbation. So two things are taken. If the question himself says A, answer any bronchodilator. For B, you have to be aggressive. You have to give two things, LABA and LAMA. And the commonest combo that would be used in this patient would be tiotropium. And along with tiotropium, the second molecule that would be used is formoterol, or we can use even indacaterol as I asked you yesterday. The advantage of indacaterol is it needs to be taken once a day. Formoterol needs to be taken twice a day. If he says the word E, that is classification as E, then E means excessive problems in the patient. I mean, how to remember is E basically means that there is excessive illness, there is excessive problems in a patient. So you will go all out aggressive. What I mean by all out aggressive is that now you will also add steroids. And the question that will be asked to you will be that how does a doctor decide whether steroids are to be added or not to be added, because steroids are normally given in asthma, which is an inflammatory disorder. In COPD also we are giving steroids. Asthma is an allergic disorder, so it makes sense to give steroids. In COPD, we don't regularly give steroids because routinely COPD is not like a inflammatory disorder, right? It's caused by lung destruction. We are still giving steroids now because they tend to reduce, because injury will also cause inflammatory changes. See, one is pure inflammatory disorder. Asthma is pure inflammatory disorder right from day one. Histamine, so inflammation. COPD, the damage causes inflammation. The damage causes inflammation. So he says, how will the doctor decide? Your answer will be, I will run a blood test on the patient by the name of AEC. What does AEC stand for? AEC stand for absolute eosinophil count. If the absolute eosinophil count on a blood test is more than 300 cells per cubic millimeter, that is when you will decide to give steroids in a patient. This is an important aspect that I said, guys. How does a doctor decide whether you should be giving steroids in COPD? Because traditionally steroids are given in asthma, which is an allergic disorder. Here the inflammatory changes are present and they're causing, then I mean due to damage, inflammation is coming. So the decision making is based on blood eosinophils. So we will revise the data here, A, B and E. I will remove it from the slide. A is any bronchodilator. I hope याद हो गया होगा. B में थोड़ा symptoms ज़्यादा है तो give to B second alphabet so two things, LABA, E से LABA and then LABA given to the patient. In E it is excessive, so you got all out aggressive, that is okay, but to add steroids, that step intervening, he will say how the decision making process will be done. The decision making process will be based on the addition of steroids in this patient. Roflumilast is like a last resort that you use. That's the old classification, Sairaj, that you were talking about. That he was talking about like roflumilast, phosphodiesterase 4 inhibitor. So I understand where the question comes from. You listen to my older version there. So, but yeah, I mean, this is the current approach that should be followed. And he does mention roflumilast, but he says that it's not. It's like a last resort that can be added, but will not add significant to improvement in the symptoms of the patient. Mucolytics, they don't have any significant role in reducing mortality. डे टू डे लाइफ बलगम आती है तो उसके लिए थोड़ा म्यूकोलाइटिक्स एम्ब्रोक्सोल कैन बी गिवन एंड एसिटाइलसिस्टीन कैन बी गिवन, बट द टेक्स्ट बुक इज नॉट vocal about the use of mucolytics for the patient. The main thing is cut down the inflammatory changes and do a bronchodilation in the patient. And now we will focus on certain questions which are related to this information, including some of the information discussed earlier also. So let me handle these questions. All of these are MCQs of the previous years that I'm clubbing together at one single place. Clubbing is normally seen in all lung cases. Clubbing is a standard problem that is seen in all lung cases but is not seen in COPD. So that is one MCQ. Clubbing कहाँ नहीं मिलती है? तो lung cancer में मिलती है, suppurative lung disease में मिलती है. It is always seen in suppurative lung disease but is not seen in patients who are suffering from COPD. So there are two MCQs that I've covered here. Fastest clubbing is seen with lung abscess. Within 6 weeks, clubbing will come. Normally with cancer, it takes a very long time. Patient had more exacerbations and hospitalization. AEC is less than 300. No, we will not give ICS, but because exacerbation is there, Pranav, I will give IV hydrocortisone. For that exacerbation, no, I will be giving IV hydrocortisone to the patient. That is more effective, na? Like, why would I waste my effort in giving ICS to the patient? I will give IV steroids to the patient. Hydrocortisone will be given. So, Pranav, that answers your query. Fastest clubbing is gonna be lung abscess. And no clubbing is seen with COPD. In you and me, our our transverse diameter of the chest, your shoulder to shoulder diameter is more than the AP diameter. But in patients of COPD, you will notice that AP diameter is more than the transverse. If the AP diameter is more than transverse, we call it barrel chest. And most patients of COPD will sit leaning forward. Now, obviously, I have a good plus size table, so I can lean like this. A COPD patient will be sitting leaning with his hands on his thighs, and he will try to lean forward, trying to use his accessory muscles of respiration. So, therefore, tripod position में बैठते हैं. And along with this tripod position, आप देखोगे कि lower part of the chest will be sucked inside because diaphragm will be contracting with more force. The lower part of the chest will be sucked inside. The reason why the lower part of the chest wall is sucked inside because diaphragm is trying to maintain saturation. So the chest wall will be sucked inside, and this is what is called as Hoover sign. What is Hoover sign? It is a paradoxical inward movement of the chest. In you and me, an inspiration, our whole chest expands. If you breathe in, your whole chest will expand, but in this case, when the person will breathe in, some part of the chest wall will be sucked inside. Why it is being sucked inside is because of the extra effort of the main muscle of inspiration. Diaphragm is working harder than normal to maintain the oxygen saturation. So the diaphragm कहाँ पे attached होता है? It is to the inside side of the lower ribs. Diaphragm is attached to the inside the lower ribs, so diaphragm is working harder than normal. It will pull the skin inside. That's what is called as Hoover sign. So that's again a one-liner. Hoover sign is seen in COPD. The patient will be sitting in a tripod position with a barrel chest. That's a standard profile of a COPD patient, sitting, leaning forward, sitting, leaning forward. In all patients of COPD, there is air trapping. In all patients COPD, there is formation of bullas and blebs, so there is air trapping. So he has asked, how would you measure the residual volume? Because residual volume will increase. Residual volume will increase due to air trapping. This is a MCQ from physiology, but is asked in medicine also. What is the best way to measure residual volume? Then don't answer spirometry. Spirometry cannot measure residual volume. So what parameter will be used? Your answer will be given as body plethysmography. Or another test that I would like to mention here, and I want to check out your physiology notes, is helium dilution method. There are two ways by which we are able to identify that the patient is suffering, having a residual volume in excess of normal. Either we can do a body plethysmography or we can do a helium dilution method, but residual volume will always be increased in all patients because of air trapping, क्योंकि बुल्लास होते हैं, ब्लेब्स होते हैं. Emphysema has a reduced DLCO. ये कैसे होता है? I'll explain to you at the bottom of the slide once I'm done with the remaining statements. So this one is still in pending. This one is still in pending. I will explain to you when I move down the slide. But this is a statement to be remembered. Residual volume is more. He made combinations in the paper. Residual volume is more because of air trapping, and DLCO is less. I'll prove to you how. At the moment, I'll use English only. Alveolar scarring. At the moment, I will draw a diagram also for this. But the theory is that if there is alveolar scarring, तो कोई भी gas diffuse ही नहीं कर पाएगी, and if the gas cannot diffuse, the DLC of the patient will be less. The combinations are RV is more. Reason is air trapping, bulla, blebs, उसमें हवा फंस जाती है, and alveolar scarring की वजह से DLCO less हो जाता है. I'll give a line diagram for the same. IV हाइड्रोकोर्टिसोन एफ कॉर्लिन का जो इंजेक्शन आप लगाते हो, हाइड्रोकोर्टिसोन 100 milligram is a standard shot that always nurse patient will come now before the patient settles. Nurse will say, doctor, you want me to give Efcorlin? Say yes. COPD exacerbation, severe acute asthma, because it will take, you are the lone resident, you will be handling 10 patients together, so it might take a while for you to register, okay, COPD and asthma patient has come. Nurse knows the patient by face क्योंकि रोज रात को आता है वो, every weekend या every weekend पे वो इंजेक्शन लगाने आ जाता है. So you will realize COPD patients, they'll have lot of their cheeks will be pink. COPD के patients ना, their cheeks will be pink because of plethora, because hemoglobin less होता है, so erythropoietin becomes more. So these patients will have rosy cheeks and he'll be like panting for breath, and you give a hydrocortisone shot to this guy, कहता discharge कर दो, कह रहा नहीं अभी रुक जा, अभी और भी treatment करेंगे. Hydrocortisone shots should be given to all patients by default. Don't use oral steroids. इन गवर्नमेंट हॉस्पिटल हमारे पास कुछ होता नहीं है ना, तो हम ओरल स्टेरॉइड चला रहे होते हैं, एंड ओरल स्टेरॉइड से एवास्कुलर नेक्रोसिस ऑफ हिप होता है, कुशिंगोइड अपीयरेंस होता है. तो दो इन अ गवर्नमेंट सेटअप, बिकॉज दे डोंट गिव अस प्रॉपर लाइक वेपन्स टू फाइट द डिजीज. आप क्या करते हो, आप प्रेडनिसोलोन की गोलियां चलाते हो. आई थिंक अ लॉट ऑफ यू, इवन इन योर फैमिली, इफ यू आर हैविंग समबडी विद सीओपीडी ना, इफ दे आर सीइंग सम सीनियर डॉक्टर, ओल्ड डॉक्टर, दे विल स्टिल बी गिविंग स्टेरॉइड्स. But he says that there is no role of steroids for management of this patient, and then if the person will deteriorate, then we will obviously use NIV, as I explained to you already. And I also told you NIV is contraindicated in unconscious patient. And now comes the most important MCQ of this particular segment that I've discussed. All these are questions of the previous years. What is the best mortality to reduce? What intervention is best to reduce mortality in COPD? Then it is LTOT. LTOT stands for long-term oxygen therapy. That's like one of the best ways by which you are able to reduce the mortality. How would you give LTOT in any patient of COPD? Is that you will ask this patient to purchase a device which can make oxygen from air. How will you reduce mortality in a case of COPD? You will ask the patient कि सर आपको एक ना 30-35,000 का डिवाइस खरीदना है जो हवा से, एयर से ऑक्सीजन बनाता है. कहता है हवा से ऑक्सीजन बन जाएगी. मैंने कहा, कहता मैं सिलेंडर ले लूंगा. पेशेंट विल से आई विल परचेज अ सिलेंडर और रेंट. नो सर, रेंट पे मिलता है 500 रुपए में, तो मैं सिलेंडर ले लूंगा. तो मैंने बोला कि यार सिलेंडर ले तो लो के, बट हाउ विल यू ओपन इट? यू नो, इफ यू सीन द ऑक्सीजन सिलेंडर, यू नीड टू ओपन उसका जो ऊपर वाला बोल्ट होता है, उसके लिए चाबी सा आता है ना, यू टू लॉट ऑफ फोर्स टू ओपन. सो मैंने बोला सर, यू आर नॉट हैविंग फिजिकल कैपेसिटी टू बी opening that bolt of the oxygen cylinder. Second, that oxygen that will come from there, that will be chilled, because compressed oxygen होती है, so it will be cold air. That cold air will tend to worsen your bronchospasm, and then suppose you have to go to the washroom, so you have to remove it and then go, right? He says that, do you think the device I can carry? I said, yeah, it will have trolley, it will have wheels below, and you can just pull it along with you, and therefore when you walk to the washroom, you will not be like as if I've run a half marathon. तो कह रहा है कि सर ऐसा क्या लेना है मेरे को, what is the device that you'll be using? So yes guys, you guys can help me out. I think some guys have commented on that also. I mean, what is the device that you can purchase and the patient can be taking oxygen? Yeah, obviously. More people please, I'm waiting for the comments here, so that, yes guys, so that we are able to see. The objective is to give oxygen to the patient. You can give it via cylinder also, or you can give oxygen by help of like any particular device that the patient can purchase. And obviously, like to this device, you will obviously be having a transparent plastic nasal cannula. Yes, you will be having a transparent plastic nasal cannula. Yes, oxygen concentrator, exactly. You can ask the patient to purchase a oxygen concentrator, right? That's one of the devices that can be used in COPD. The point is, this will be having a plastic transparent nasal cannula, and the quality of this nasal cannula, this plastic cannula का जो quality है, that should be very good. Otherwise, it will cause lot of allergy, it will cause lot of inflammation also. So what we should do is, like, you know, ensure good quality nasal cannula, because oxygen has to be given at a rate of 1 liter per minute. Patient is saying, sir, I'm purchasing a 30,000 का device, and the 30,000 का device लेने के बावजूद भी, like, you are asking me to take at 1 liter per minute, I can take at 6 liter also. So I told him, no, I don't want you to have oxygen at 6 liters per minute. He says, sir, I'm spending money and you don't want me to still take oxygen at 6 liter per minute or 2 liter, 3 liter. I said, I want you to have residual hypoxia. So somebody commented on this yesterday also, and I said I will touch upon this fact again. We deliberately want COPD patients to have residual hypoxia to make their muscles work than normal. We don't want to completely treat the hypoxia because normal saturation in our body is 95 to 98%. But in COPD, you will not want a saturation of range of 95 to 98%. You will be giving oxygen at a rate of 1 liter per minute for 16 hours per day. वो कहता 16 hours, why not 24 hours? मैंने कहा आप लगा के सो जाओगे, मुझे कोई दिक्कत नहीं है, 24 hours ले लो. बोला मेरी तरफ से तो if you are gonna be comfortable with the transparent nasal cannula to your nose and you wanna sleep, be my guest. I mean, it's okay. So in this particular patient, we'll ask the patient to purchase a simple oxygen concentrator. This will be making oxygen from the atmosphere, and this oxygen concentrator will then be connected to a plastic transparent nasal cannula, and oxygen is given at 1 liter per minute for 16 hours per day with a target SpO2 of 88 to 92%. And the technical word for this, as everybody commented rightly, is called as LTOT. LTOT stands for long-term oxygen therapy. The basic point is long-term oxygen therapy. It is a long-term oxygen therapy, which is the major mortality reducing intervention that you will do, along with obviously quitting smoking. So just a quick chat, quickly mention kar dena what drugs that you can be using for quitting smoking. Best drug to quit smoking. Options: varenicline, bupropion, nicotine. Quick answers please. I'll wait for 10 seconds for you to answer. Varenicline, nicotine, bupropion. Yes, guys. Yes, guys. Okay, maybe the chat stopped the mind. So I am very curious to know that answer from you guys. So yes, what is the best way to quit cigarette smoking in the patient? Okay, okay. The main medicine by which you are able to quit the habit of cigarette smoking would be varenicline. The best way to quit the habit of cigarette smoking would be varenicline. Varenicline will basically block the pleasurable effects of cigarette smoking. They have asked a question in your exam that it acts on which nicotinic receptor. So this medicine acts on alpha 4 beta 2 nicotinic receptor, and it is a partial agonist. This medicine is not an antagonist, it is a partial agonist. It will block the pleasurable effects of cigarette smoking. All of you know sufficient pharma. I don't need to explain that antagonist will obviously block, but even partial agonist will block the pleasurable effects of cigarette smoking. So varenicline is the first main drug by which you will be able to quit cigarette smoking. And second will obviously be that you will be using nicotine in the patient, because you have to go for NRT. So there would be 2 points that would be given. Like a lot of you might be sitting for INISET also. So there the answer will be varenicline as well as NRT, that is nicotine replacement therapy. For nicotine replacement therapy, the question has been what is the best way for delivery? So I'll give you a couple of options here. One of the options is that I can use a chewing gum or lozenges. Chewing gum or lozenges, that is either of the two approaches. They mean the same only. From the oral cavity, the medicine is getting absorbed. Then I have a nasal spray also available, and the third one available for nicotine will be like a transdermal patch. So let me know that which among the following will be the most effective method for delivery. Options in the paper was transdermal patch also, nasal spray also, and lozenges also. I'm waiting for answers here, and I think I saw Ankit answering that in some forum also, or Ankit sir had mentioned this on his Insta also. No sir, the answer is not patch. Answer is not patch. माउथ के सरफेस एरिया से एब्जॉर्प्शन. बच्चे आंसर इज नॉट पैच. द बेस्ट आंसर इज लोजेंजेस. माउथ से एब्जॉर्प्शन बेस्ट होती है. माउथ से एब्जॉर्प्शन बेस्ट होती है. तो चूइंग गम, आजकल तो डॉक्टर के प्रिस्क्रिप्शन की जरूरत भी नहीं है इसके लिए. सर नेजल सरफेस एरिया स्मॉलर देन द ओरल कैविटी सरफेस एरिया ना. सो यू विल सी लॉट्स ऑफ टाइम पीपल वॉकिंग इनटू अ केमिस्ट शॉप एंड सेइंग कि मुझे एंटी स्मोकिंग की गोली दे दो, चूसने वाली गोली दे दो, या चूइंग गम दे दो. You don't need a doctor's prescription for nicotine replacement therapy. Anybody can walk into a chemist shop, go into Amazon or any other medical website, 1mg.com or anywhere, and you can just order it without a doctor's prescription. Yeah, Blinkit obviously. Blinkit also. I mean, this can be ordered by anybody without a doctor's prescription. You don't need any special advice for it. It's just that awareness of the patient has to be there. A lot of people there said bupropion. Bupropion is used only with concomitant anxiety. Like a lot of cigarette smokers are anxious people also. थोड़ा भी स्ट्रेस हो जाता है तो वो क्या नर्वस हो जाते हैं, नहीं यार चलो सिगरेट पी के आते हैं, पहले सिगरेट पी लूँ फिर बाकी काम करेंगे, घर पे इलनेस होगी सिगरेट पीना शुरू कर देते हैं, है ना? मतलब एनीथिंग, इट्स जस्ट माइंड वाला गेम है. सम पीपल गेट नर्वस वेरी सून, कईयों को फर्क ही नहीं पड़ता, है ना? कईयों को होता है एग्जाम हमारा सो जाते हैं. Right, so it depends on how body will react. Some people when exam will come closer they tend to feel more alert. Some people when the exam will come closer they will feel more sleepy all the time. So that depends on body to body. But then the point I'm trying to say is that the main approach is NRT is not NRT, it is varenicline. This is the best superior drug to quit smoking. I'm putting 2 stars, I'm putting a single star to say that if the question says what is the single best intervention to help a person quit smoking, it is varenicline and LTOT would be used. And then comes obviously the role of drugs, which I was speaking about. The role of drugs would mean that what drugs would be given to the patient, it is LAMA. We can add LABA, and then we can add inhaled corticosteroids if especially the absolute eosinophil count of the patient is turning out to be more than 300 cells per cubic millimeter. I have just tried to summarize what is the medical advice that you would be giving to any COPD patient. That is oxygen concentrator, then is going to be varenicline, and then is going to be LABA, and add inhaled corticosteroids, and you would be able to manage your patients effectively or relatively better. COPD का most common complication बता दीजिए. Waiting for your answers quickly. Overall, what is the most common complication of COPD? Yes, guys. Overall, what is most common complication of COPD? Yes, guys. Overall, most common complication of COPD is. Yeah, waiting for options, man. Yeah, cor pulmonale. Overall, most common complication of COPD is cor pulmonale. Cor pulmonale would mean that the person will be having right ventricular failure, and that right ventricular failure will be due to pulmonary artery hypertension. Meaning of the word cor pulmonale is right ventricular failure due to non-cardiogenic cause. Right ventricular failure, if it occurs due to a non-cardiogenic cause, that is when we say it is cor pulmonale in a patient. The most common complication of COPD is cor pulmonale, right ventricular failure due to a non-cardiogenic cause. And what is the problem here? It will be a development of pulmonary artery hypertension occurring in these patients. This is a common complication, though sometimes we can be having rupture of bulla also. If a COPD patient will be having rupture of bulla, then the manifestation that will occur in the patient will be pneumothorax. What is the type of pneumothorax that will be seen if there is a rupture of a bulla? Options are tension pneumothorax, traumatic pneumothorax, secondary pneumothorax, spontaneous pneumothorax, rupture of a bulla. Yes, guys. If there is rupture of the bulla, what is the type of pneumothorax that will occur? Tension, traumatic, secondary, spontaneous. Yeah. The answer would no, it is not this because it is a pre-existing lung disease. See, some people can have bulla without COPD also. अगर मैं simply बोलूँ ना rupture of bulla हो गया even without COPD, then your answer would be given as spontaneous pneumothorax. Guys, spontaneous word will be given only when there is no pre-existing lung disease. Suppose I say to you, patient had COVID, and after COVID, person had pneumothorax. Or I say patient had interstitial lung disease and there was pneumonia and there was a COPD and there was a pneumothorax. If in the question a pre-existing lung disease is given, if in a question pre-existing lung disease is given, pre-existing lung disease can be COPD, it can be COVID, it can be interstitial lung disease. The point I'm trying to say is that if you specifically notice, if you specifically find pre-existing lung disease is given in a question, then your answer would be given as what I'm highlighting at the moment. Then the technical word would be called as secondary pneumothorax in a patient. If pre-existing lung disease was not in the options, then you can answer spontaneous, perfectly fine. But considering that there is damage to the lung parenchyma, it is secondary pneumothorax that would be answered in this case. So what I've described before you is COPD at the moment, and now we will talk about bronchial asthma, which is even much more simpler topic. Okay, bronchial asthma next. Bronchial asthma के लिए तो the usual question that they've asked in FMG exam is very simple, that what is the increment of FEV1? By how much percentage FEV1 should be increasing? Your answer is that after giving bronchodilator, FEV1 should rise by 12% over the baseline value to say that the patient is suffering from bronchial asthma. And either it will be written in percentage or it will be a volume. The volume would be like 200 ml of air. So it is a reversible bronchoconstriction in the patient. And DLCO is increased in asthma. I'll give you the reasons why, because COPD mein DLCO is less and in asthma it is increased. So as I go down, the DLCO explanation will come. At the moment, the data is 12%. Explanation I've given. Diagram has not been given, Pranav. Explanation has been given. Diagram will come. More than 12% is the concentration for bronchial asthma, or more than 200 ml of air. So we call it reversible. And asthma usually, like, he might write words like intrinsic asthma and extrinsic asthma. So extrinsic asthma presents in adult age group and has a normal immunoglobulin levels, can coexist with nasal polyps. I wanted to remember that there are two alphabets. One is extrinsic and second is going to be a intrinsic asthma. Extrinsic and intrinsic asthma. So main word to be remembered is जो adult onset asthma होता है उसके लिए याद करना है आपको. The word is extrinsic, and the surprising thing is that they are having normal immunoglobulin E levels. You see why I'm teaching you this is normally the thought process of anybody is asthma is a disease where IgE is elevated. So in this particular condition of adult onset asthma, pediatric onset asthma has elevated IgE, and that tends to improve with age. Most children who are asthmatic before 10 years of age, child will have repeated requirement nebulization. After 10 years, hardly any nebulization. By 2025 is like मुझे बचपन में asthma था, अभी कोई दिक्कत नहीं. Lekin some people develop asthma in teenage years, and then the asthma tends to worsen with age. So pediatric onset asthma, the childhood asthma जो first 10 years of life में मिलता है, वो second decade में जाके less severe हो जाता है. And people say वो बचपन में asthma होता था, अभी कुछ नहीं है. But if it's starting in teenage age group, if it is gonna be in a teenage age group or like in an adult person, then you will notice that the asthma tends to worsen with age. Yes, David Beckham is an example of that. That would be adult asthma with normal immunoglobulin E levels, which can coexist with nasal polyposis. So remember this statement. जो बच्चे वाला asthma है उसका नाम है intrinsic. Intrinsic मतलब जन्म से आया. तो जन्म से आया या जन्म के बाद हो गया, then you will notice that it will improve with age group, but extrinsic asthma tends to worsen with age group. And the main investigation of choice for diagnosis of bronchial asthma is spirometry, where there will be a 12% increment in the value of FEV1 after giving salbutamol and before giving salbutamol. Like for example, he can give you a case where the FEV1 of the patient on presentation was 50%. The FEV1 value of the patient is 50%. It is less. Normal FEV1 कितना होता है? तो normal FEV1 is always more than 80% of the total air in the lungs. आप एक सेकंड में जोर लगा के 80% एयर बाहर निकाल सकते हो. लेकिन an asthmatic patient, because asthma is a disease of expiration, तो उसमें हवा लंग्स में फंस जाती है. तो FEV1 सपोज 50% है, तो you will give salbutamol to the patient and you will ask him to wait outside the spirometer room for at least 15 minutes. After 15 minutes, your technician will call the patient in the room again. और जब आप FEV1 चेक करोगे तो FEV1 will tend to become towards normal. The FEV1 will tend to normalize in the patient. That normalization is because beta 2 agonist is working. Like suppose in the patient initially the FEV1 is 50%. And then it is increasing to 65%. So that threshold of 12% is getting exceeded. It may not become normal. I might require more puffs for it to become normal. With 2 puffs, it may not become normal. I mean more treatment. But my point is, if the increment is more than 12%, we say bronchial asthma. If the increment is less than 12%, what is your diagnosis? I want everybody to comment in the chat box. What is the diagnosis if the FEV1 increment is less than 12%? साल्बुटामोल दिया आपने 50%, उसका FEV1 50% था. It increased from 50 to let me say 55%, 60%, चलो 10% इंक्रीमेंट हो गया. What will you say? COPD. And now my question is, if it is equal to 12%, तो क्या करोगे? If it is equal to 12%, what will you answer? Last time's FMG exam, it was equal to 12%. If FEV1 increment in the MCQ is equal to 12%, what will be your answer? Less than 12% COPD. More than 12% bronchial asthma. If it is equal to 12%, what will you answer? Last time's FMG exam question, I think it came in any set also. Increment equal to 12%. Yes, guys. Yeah, it is both. Your answer is ACOS, asthma COPD overlap syndrome. This was the answer of the January FMJ exam, and this came, I think, in November INISET also. This was the answer in last time January 2026 FMJ exam, and this came in November INISET also. That is ACOS. That is gonna be, yeah, clinical correlation required is a good joke there. Asthma COPD overlap syndrome. This is ACOS, that is asthma COPD overlap syndrome, or FEV1 increment of equal to 12%. If the FEV1 of the patient is less than 12%, your answer is right. We will say COPD. If the FEV1 increment of the patient, in all the words, it is increment only. I'll just rephrase it. Yeah. If the FEV1 increment of the patient is less than 12%, if the FEV1 increment is more than 12%, the answers will vary. I think most guys have answered it correctly. I am gonna just write down for formality here only. Less than 12%, you will say person is having COPD. Okay, now better. I will say COPD. And if I say more than 12%, then you will say bronchial asthma in a patient. This was slightly a tricky question that came in the paper. A lot of guys took a lot of time to figure that out. I mean, one guy said I read the question at least 3 times. And then I was able to understand that this is a combination that is present. FEV1 value in asthma should be rising by more than 12%. Like 50% से 65% हो गया तो asthma हो गया. अगर 50 से 60 हुआ less than 10%, then we will say it is COPD. And if it is gonna be specifically mentioned equal, then it is gonna be ACOS, that is asthma COPD overlap syndrome. Okay, cool man. Happy that you were able to figure that out. In all patients of bronchial asthma, we will also be doing is a flow volume curve. In a flow volume curve, we will be writing inspiration and expiration like this. I want you to draw the curve with me in couple of colors. The first one is perfectly normal. I will ask the patient to blow into the mouthpiece of the spirometry machine. When person will breathe in, मैं बोलूँगा जितनी ताकत है उससे breathe in as hard as you can and fill air in your lungs. So what I'm trying to do is achieve a TLC of 6 liter. Like you all know that total lung capacity normal is 6 liter. So I will ask the patient to fill max amount of air in the lungs, that is 6 liter, and a normal person can do that inspiratory effort, and a graph will appear on the curve like this, like a parabola. Now I will tell the patient, breathe out as hard as you can. I will ask the patient, breathe out as hard as you can. I will say, जितनी ताकत है उससे सांस बाहर छोड़ो. You know that lungs never become empty. However hard you will breathe out, your lungs will never become empty. So residual volume will be something like 1.2 liters per minute. So first is a curve of a normal person. This blue curve is for a normal individual like you and me. That I asked my patient कि first fill air in the lungs. Then I said, बाहर को छोड़ने के लिए breathe out as hard as you can. So at the moment this is perfectly normal. Now I will show for asthma COPD patients what will happen. In a asthma COPD patients, lots of time there is air trapping. Because of air trapping in the patient, the TLC can be more than 6 liter also. So I will be now showing a curve of this asthmatic patient. Like this, inspiration is okay. So the shape will be the same. But I am showing more than slightly 6 liter. I'm slightly increasing it to more than 6 liter because there is air trapping. And now when the person will breathe out, asthma is a disorder of expiration. The curve will now get a scalloping. It will get a scooped out pattern because of a prolonged expiration. They will give you a graph like this where you will notice specifically that the TLC of the patient might be slightly more because of air trapping in an asthma exacerbation. And you will also get a concavity. This concavity is the main thing for diagnosis of obstructive airway disorders. This that I've shown at this moment is a pre-bronchodilator effort of the patient. Pre-BD means it's a pre-bronchodilator effort of the patient. And you can notice the shape here. The shape is called as a scalloped pattern. It is called as a scooped out pattern. Like for example, when you take out an ice cream, right? You take out a scoop, then it will cause a depression. So this is because of the prolonged expiration that is happening in an asthmatic. Once you're able to obtain this curve, you will tell the patient that now I will give you 2 puffs of salbutamol. You will tell the patient, I will give you 2 puffs of salbutamol. Sit outside the spirometry room. After 15 minutes, my technician will call you. Now see what will happen after 15 minutes. The patient will once again be breathing into the mouthpiece. The computer will record a similar kind of a curve that is still in the patient because air trapping is there. So residual volume will be more. But I hope you will be able to notice that when I'm drawing the graph, I'll use a different color so that it's a little more in contrast. This in green that I'm showing is post bronchodilator. This in dark green is the post bronchodilator curve of the patient, which will be the same. But now you will notice that because the airways will open, so the scooped out pattern will become lesser. You can notice that the scooped out pattern will become relatively lesser. So what they did in the paper was they had given these color coded graphs. One was normal tracing, that is in color blue. One is the pre-bronchodilator effect. One is the post-bronchodilator effect. And I hope I've been able to explain to you at this point of time that there is an increase in the area under the curve. If you check it out, there is an increased surface area under the curve. You can see that concavity, that scooped out pattern has become relatively less. The computer by itself, by default, will flash on the screen. What is the change in the area under the curve? This dot, dot, dot that I'm showing. This is the increment in the FEV1 of the patient. This is the change in the AUC. What do you mean by AUC is area under the curve. जो graph बनता है उसमें area under the curve is taken. So change in the area under the curve is being evaluated here. The change in the area under the curve is that the computer itself will give you a value 15%, 20%, whatever. If it says less than 10%, less than 12%, obviously COPD. I told you the algorithms there, but this is the main graph that I want you to remember for bronchial asthma. This is a scooped out pattern, scalloped pattern, and you will have an improvement when the person will be taking a bronchodilator. I hope it's clear, guys. Let me know if I need to repeat anything. I hope it's clear, guys. Pretty straightforward there. The spirometry curve and a flow volume curve both can be asked to you. Flow volume curve is the one which is usually asked. इट्स वेरी सिंपल सर. इवन दोस्त वो जो टेक्नीशियन होते हैं ना 8वीं 10वीं पास होते हैं वो भी बता देते हैं कि सर ये तो एस्थमा वाला है. तो आई डोंट थिंक सो दैट वी नीड एनी स्पेशल एफर्ट टू बी एबल टू रिमेंबर इट. इट्स अ कॉन्केविटी एंड द कॉन्केविटी will basically improve. Now can you tell me the latest test for diagnosis of asthma? Can you tell me the latest test for diagnosis of asthma? Because this test will require cooperation of the patient. This test will require cooperation of the patient. When you tell a person breathe in, breathe out, patients do opposite. You and me are doctors. We know what is inspiration, what is expiration. Most of the non-medical people are not able to understand inspiration, expiration. They make a mess of this particular part. Asthma is क्योंकि inspiration is active process. तो तुम्हारा ब्रोंकोस्पैज्म है, जोर लगा के कर लोगे ना. एक्सपिरेशन तो पैसिव प्रोसेस होता है. सोचो तुम्हारे एयरवेज स्पैज्म में है, इंस्पिरेशन में तो जोर लगा के हवा भेज दोगे. इंस्पिरेशन में तो जोर लगा के हवा भेज दोगे. एक्सपिरेशन में क्या है, वो तो पैसिव प्रोसेस है ना. एस्थमा इज अ डिसऑर्डर ऑफ एक्सपिरेशन. The point is bronchospasm is present all the time. In inspiration, you can still force your way across, but in expiration, it's a passive process. Asthmatics get tired because they have to push air out of their lungs. That's why it's primarily an expiratory disorder. And I got very good answer. Yes, guys, the main test nowadays does not require cooperation of the patient. You'll ask him to breathe out. And the main test for diagnosis of asthma is FeNO. FeNO is fractional excretion of nitric oxide. It is in the exhaled breath in the patient. At this moment, I also want to introduce one more MCQ, especially for NEET PG aspirants, inhaled nitric oxide test. This inhaled nitric oxide test is also called as vasoreactivity test. The question in the paper said inhaled nitric oxide test is used for diagnosis of, and some people casually answered it as bronchial asthma. In asthma, it is exhaled nitric oxide. We're talking about inhaled. That inhaled nitric oxide test is used for diagnosis of pulmonary artery hypertension. Please note that in the side. Even FMG students, you have to note this. Pulmonary artery hypertension, the bronchodilation, the vasodilation part can be achieved by nitric oxide that is inhaled. So when you're attempting questions, take care of the fact that if it is written inhaled, then it is pulmonary artery hypertension. And if he says the word exhaled, then it is FeNO, that is fractional excretion of nitric oxide, because it is a gas which is released due to inflammatory processes. And most of the asthmatics that come to us in adult age group are having type 2 asthma. That type 2 asthma, like we read about diabetes, we nowadays read about type 2 eosinophilic asthma, for which you will have to use biologicals in the patient. You will have to use, I will talk about those drugs also, like benralizumab, etc. Type 2 asthma is which does not respond to very well to steroids. Type 2 asthma is where you get poor response to steroids, and therefore you have to use biologicals in the patient. So I'll be talking about these biologicals. The cytokines involved in this are like interleukin 4 and interleukin 13. That's again a pathology aspect, and value more than 50 particles per billion indicate that eosinophilic inflammation which is present here, and there would be poor response to steroids. I'll say once again, type 2 asthma means poor response to steroids. We have to use biologicals. We have to use biologicals. The cytokines involved in pathogenesis of asthma. Obviously, we know histamine, but he will not ask you histamine. He will ask you interleukin. So interleukins are like interleukin 4 and interleukin 13, and values higher than this indicate eosinophilic inflammation. So at this moment, I've tried to explain to you how do we diagnose asthma routinely in practice. Flow volume curve. Routinely, the test we do in the patient for diagnosis of bronchial asthma in real time, what we do is we do a flow volume curve. But he says that flow volume curve as a test is dependent on the cooperation of a patient, and it is sometimes can have like interpretations which can be having a bias as well. So a new test that is available is called as exhaled nitric oxide test, FeNO, where the values of nitric oxide should be more than 50 particles per billion. And the advantage is that it especially helps in identification, or it's like better suitable for assessment of those patients who are having asthma, which is more difficult to control medically with conventional medicines. In the light of this information, now I will ask you like how can you prevent asthma? Before I ask you prevent asthma, can you tell me, suppose somebody is having acute asthma right now, what will you give to the patient in acute asthma? Will you give SABA or will you give LABA? Please comment in the chat box, everybody. If a patient is having asthma attack right now, will you give SABA or will you give LABA? Acute asthma exacerbation, what is the treatment that would be given to the patient? Quick answers at the moment. Acute asthma exacerbation, what is the management that would be given in the patient? SABA, LABA, just quick answers please. Okay, I'm getting good answers here. Keep commenting guys. Acute asthma exacerbation, what will you give to the patient, SABA or LABA? Okay, so I think 99% of the doctors are wrong. 99% of doctors are wrong. I think Ajay's comment was the first one that I could pick up was correct. For acute asthma exacerbation, we don't give SABA. SABA has been stopped since 2018 for management of acute asthma exacerbation because it is short acting, so you will require again and again. And the problem is tachyphylaxis. No, sir, acute asthma exacerbation does not require oxygen. It is formoterol. It is LABA with inhaled corticosteroids that should be used for acute asthma exacerbation. You will ask the patient to use a PMDI. You will ask the patient to use a PMDI, that is powdered metered, that is a pressurized metered dose inhaler. P stands for pressurized and it will be metered dose inhaler. So for acute asthma exacerbation, you have not read your pharma properly guys. For acute asthma exacerbation, it is LABA with inhaled corticosteroids. Where will you answer SABA is if I change the question. If I say, how will you manage a patient of severe acute asthma? If I change my question and say, doctor, how will you manage a patient of severe acute asthma? That is where you will be saying that I will be starting the patient on nebulization with salbutamol. That is an emergency drug and should be respected as such. That is, nebulization with salbutamol needs to be started. For acute asthma exacerbation, if I give SABA, no, that's a misconception. There are a lot of people who think that LABA will take a long time to happen. LABA is rapid onset. It is long acting with rapid onset. A lot of people think I'm talking about salmeterol. No, I'm not talking about salmeterol. I'm talking about formoterol. So the drugs that I'm talking about have a rapid onset. So this is a very old concept that people have, that, oh, LABA will be having delay in onset of action. How will the patient improve? No, he will improve immediately, sir. LABA with rapid onset is formoterol, that is used for acute asthma exacerbation. It is the GINA guidelines that are being asked. For severe asthma, we have to admit the patient and use, Duolin is used lots of time. It is nebulization with salbutamol. After nebulization salbutamol, at the back side of the nebulization chamber, there is an inlet for oxygen. Always attach oxygen. Never give direct air-driven nebulization. It will worsen the ventilation perfusion imbalance. So it should be oxygen-driven nebulization that should be given to the patient. Oxygen-driven nebulization that should be given to the patient. Long acting is not slow acting. Exactly. Subcutaneous terbutaline is not, it's now going banned now. Terbutaline is being banned. It is oxygen-driven nebulization that will be used for this patient. You would do nebulization salbutamol, you give oxygen-driven nebulization. Now what we will do is we will be giving IV hydrocortisone. We will be giving IV hydrocortisone injection. There is no rule of IV hydrocortisone injection in management of patients of acute asthma, but in severe asthma, hydrocortisone is given. Can you tell me why? Yeah, I should be asking you guys, how will you differentiate? I was supposed to ask you this. Okay, I will tell you. I will tell you. Tell me first, how will hydrocortisone work here? Hydrocortisone inhibits the enzyme by the name of phospholipase A2. And phospholipase A2 is a mediator which is responsible for synthesis of these mediators of asthma like leukotrienes. Leukotrienes then result in production of subsequently histamine. So we are suppressing the inflammatory cytokine production. You will also be using IV magnesium sulfate. Yes, the same magnesium sulfate that is used for management of eclampsia will be given here. The rationale for this is magnesium is an antagonist of calcium. It will relax the smooth muscles. Why do you give magnesium is because magnesium is an antagonist of calcium and calcium is required for the contraction of the smooth muscle. Magnesium is an antagonist of calcium. Calcium is required by the smooth muscles for contraction. So it will neutralize the bronchospasm. Additional drug that you can be giving at this patient is nebulization with ipratropium bromide. The ipratropium bromide takes some time to act. That is why it has been mentioned a little later. This is management of acute asthma versus severe acute asthma. How will a doctor differentiate between the two? You can ask the patient to purchase. Like that pulse oximeter. If you notice in a multiple choice question that the oxygen saturation of the patient is between, if the oxygen saturation of the patient at room air is between 90 to 93%, if you notice that the respiratory rate of the patient is less than 25 beats per minute, 25 per minute, sorry, not beats per minute, 25 times per minute. If you notice that the pulse rate of the patient is between 100 to 110 per minute. If in any question of bronchial asthma, you notice that the pulse rate is something given in the rate of 100 to 110, respiratory rate is less than 25, and saturation on room air is about 90 to 93, and patient is like can speak full sentences. Patient, most important thing is patient can talk. Patient can talk full sentences. Like he can say to you, sir, I am feeling breathless, but at least he can complete the sentence. He's speaking slowly, but he can talk full sentence. He's breathless. Obviously, an asthmatic will be breathless, but if I can talk full sentence and he says, how will you manage the patient? You will say that at home only. You will ask him to take a puffer, or that is PMDI, that is gonna be a pressurized meter dose inhaler, and that will help him take over or manage the attack. But suppose if I write in red that pulse oximeter shows SpO2 less than 90% at room air, the respiratory rate of the patient, I asked the person's wife only to count the respiratory rate. She says it is 30. That is again, non-medico can also count the respiratory rate. Now they can check pulse oximeter. More importantly, the pulse rate of this patient is very fast. It is going more than 110. And this patient cannot talk full sentence. He speaks words like this guy. He's like, sans. Nahi. He's trying to act like this. He's not saying like, mujhe saans nahi aa raha, I'm not able to breathe. It's like, like he's breathing hard and he says saans, right? Like I'm having breathing difficulty, saans nahi aa raha. So inability to complete, like here he will speak in words. The person will not be able to communicate like you and me. Obviously, all patients of asthma are breathless, but if the patient is so breathless that he's using some words and some phrases, instead of saying full, no, normally person will come to you, he will say, my name is this, or doctor, like, I have come to you for a consultation. Hello, doctor, I've come to you for, like, somebody will greet you and will then start talking to you. Here, he will not even greet you, nothing. He'll just start talking. Yeah, you can do nebulization with Duolin also. Absolutely, we do nebulization with Duolin also. The problem, Duolin is a brand name, right? The point is tremors, palpitations. They are big time with SABA. So that is why we moved on to LABA for this patient. So at this particular moment, guys, I don't think so that you should have an iota of doubt regarding this management. I expected that you guys knew this, so I did not put it in the printout because I thought this is well known by you from pharmacology. But when I asked like that SABA and LABA part was going wrong, so I hope it is clear at the moment that as far as use of drugs is concerned, and believe me, if you got this data wrong, that means you have not studied drug acting on respiratory system at all with care. It is just superficial reading and you thinking it ho gaya. It is not like that. A lot of epinephrine beta is for brittle asthma. Na? Epinephrine is for brittle asthma in emergency. So we don't use epinephrine routinely. Coming back to the agenda, how will we prevent asthma attacks from occurring? ये तो deterioration हो गई थी ना, due to poor AQI, the patients will be having attacks frequently, so I need to prevent. So if you will say how will we prevent, your answer will still be LABA with inhaled corticosteroids as needed. I will now talk about prevention of asthma. For prevention of asthma, which is the last thing before we go for a lunch break, I will talk about kya karenge. So the same puffer will be used here, but the doses of all drugs will be lesser. It is low dose inhaled corticosteroids and LABA, but it is as needed. What I mean by as needed is कि जब उसको जरूरत पड़ा, like after the Diwali season, you will notice that there is a lot of pollution in India. So after Diwali, the AQI, anyway, that actually the cause is not Diwali. The cause is not the crackers. It is the burning of the crops which is contribute, because the whole food basket of India, Madhya Pradesh, UP, and then Punjab, that's the grain basket of India. They burn crops to sow that rabi crop, because all of us eat wheat and all of us eat rice. So like we need that food at time, and therefore the farmers will burn the crop, and that burning of that crops causes that AQI to decrease nearing around the Diwali time, the October and November session. So we will be telling the patient to keep this buffer with them and low dose ICS and LABA as would be needed. But if the AQI is worsening, suppose I gave you a scenario and I say that, okay, doctor, now it is November, patient moved on from October to November, the AQI status is worsening and the attacks are also worsening. Then what will you do in the patient? As the AQI attacks will worsen, then we will ask the patient to take the same medicine daily. Earlier it was low dose inhaled corticosteroid and LABA as needed when the attack is coming, now to be taken daily. Now if the patient is still having attacks in spite of low dose maintenance inhaled corticosteroids and LABA, what will you do next? Can somebody comment in the chat box quickly? What is the upgrade? If in spite of low dose steroid attacks are there, AQI is still rising. Now AQI in Delhi has reached 1000 and the meters of AQI stopped working. Person is taking low dose steroids as it happened last year in India. 2025 December was horrible time for people. What will you do? Yeah, what high dose? What high dose? Yeah, we will not give high dose steroids, man. We don't give high dose steroids. It is medium dose steroids that would be given here. So your answer would be medium dose inhaled corticosteroid with LABA. It is a step up treatment that I'm teaching you, which even the pharma guy has treated, has explained to you. And the same thing is what I'm also telling you, that first we start with low dose only. Low dose as and when required. Then is low dose daily with IBS. We don't increase the dose of LABA. Why are we not increasing the dose of LABA is because LABA के side effects क्या होते हैं? What are the side effects of LABA? Beta 2 agonist. Yes guys, what are the side effects of LABA please? What is the side effect of LABA? We are not increasing the dose of formoterol very significantly. We are increasing the dose of steroids because asthma is an inflammatory disorder. What is the biggest side effect of beta 2 agonist? Palpitations. Does beta 2 act on beta 1? Does beta 2 act on beta 1? Comment in the chat box, yes or no. Do you have beta 2 acting on beta 1? Waiting, guys. Does beta 2 act on beta 1? Yes or no? Yeah, beta 2 acts on beta 1, man. That is why तो हो रहा है. आप खुद ही तो बोल रहे हो palpitations होते हैं. तो beta 1 पे असर करेगा. Then would be tremors. Palpitations, tremors, hyperglycemia, and hypokalemia, that fall can occur, sore throat can occur, pain in the throat can occur. These are the common side effects with beta 2 agonist that can be seen. The common side effects are in the form of palpitations and tremor and hyperglycemia and sore throat that can be occurring in a patient, and even hypokalemia can occur if it is subsequently used. So we don't significantly increase the dose of LABA. Obviously it is being taken twice a day, so okay, in maximum dosages. So we don't increase the dose of LABA, but we increase the dose of steroids. Question for everybody. He had mentioned the fact that medium dose steroids से भी improvement नहीं हो रहा है, तो क्या करेंगे? यस, अभी बस भूख का इलाज कर रहे हैं आपकी. फटाफट से बताइए, व्हाट इज द अपग्रेड आफ्टर मीडियम डोज स्टेरॉइड्स? इट इज लो डोज स्टेरॉइड्स टिल नाउ. व्हाट इज द अपग्रेड? एंड आई थिंक दिस इज वेरी सिंपल क्वेश्चन दैट आई एम पुटिंग अप टू यू guys. If medium dose steroids are not working, the AQI in Delhi is about 1000, the guy has been taking low dose, then his medium dose steroids, and still it is not moving. What will you do? Waiting for another 10 seconds. भाई ये तो पढ़ना होता है. You will add LAMA. The algorithm is you will be adding, yeah, anticholinergic drugs, you will be adding LAMA in the patient. So he says add on LAMA. That means अभी इसका क्या क्या दवाई चल रहा है. He is on medium dose steroids, LABA and LAMA. Now what is the medicines that are being given in this patient? At this particular point of time, patient is using medium dose inhaled corticosteroids. He is using a LABA and he is also using a LAMA. Let me know that all these three medicines should be in three separate canisters or should it be a single canister? Should it be a three different canisters or should it be a single canister of the medicine? It has to be a single canister which is to be added. The LAMA that will be added in this particular case is tiotropium. This is the algorithm for preventing and further deteriorating of asthma so that he does not go into severe acute asthma. We will add LAMA in the patient, that is medium dose inhaled corticosteroids, and LABA and LAMA, all medicines are given. At this point of time, he says what is not recommended. It's for poor countries. He's written oral steroids plus minus. What he says is that this should ideally be avoided. This is a common practice in India in government hospitals that we give oral steroids. All of you who have worked in GMC would be knowing that we left, right, center give स्टेरॉइड्स. टायोट्रोपियम लॉन्ग एक्टिंग, भाई लॉन्ग एक्टिंग ड्रग देना है. शॉर्ट एक्टिंग 6 घंटे का ड्रग दोगे, पेशेंट रोएगा, बोलेगा फिर अटैक हो रहा है. तो बार बार थोड़ी ना पफ लेता रहेगा. पूरी जिंदगी यही काम थोड़ी ना करना है कि हर थोड़ी देर में पफ लिया. दैट मेक्स द पर्सन फील सिक. वी वांट हिम टू लीड लाइक नॉर्मल लाइफ. एक सुबह 8 बजे, एक रात को 8 बजे, बाकी 12 घंटे काम करो, चिल करो. It is medium dose steroids with LABA or oral steroids. Oral steroids are not recommended. The biggest red flag with oral steroids is risk of avascular necrosis of the hip. The biggest red flag with oral steroids is it is avascular necrosis of the hip. Obviously, other side effects are there, like it can cause Cushing in a patient. It will cause for hypercortisolism. So I don't need to explain that to you. But this is one of the main assessment algorithm that you need to remember. And now comes one of the most important things that he has said. He said, if person is not improving in spite of this, आपने उसको मीडियम डोज स्टेरॉइड भी दे दिया, लाबा भी दे दिया, लामा भी दे दिया और ओरल स्टेरॉइड्स भी दे दिया. He says अगर इसके बावजूद भी क्या करोगे, इसके बावजूद भी क्या करोगे, if person is not improving, then high dose steroids के साथ में जो रिस्क है वो है एड्रिनल सप्रेशन का. बिकॉज ऑब्वियसली व्हेन यू विल गिव स्टेरॉइड्स टू समबडी, द ओरिजिनल प्रोडक्शन ऑफ cortisol from the body will become lesser. There can be a dissonant crisis if you stop. So nowadays the recommendation are consider biologicals. If in spite of all the aggression you are using, if I am like my patient is poor and he cannot afford that once a month injection, then obviously I will give high dose maintenance steroids. For Metrol I will give oral steroids also. But he says what is recommended nowadays is, he says कि इसके बाद में ideally क्या करना चाहिए. So ideally we will tell the patient कि सर देखो, there are two options. एक तो conventional है, side effects बहुत होते हैं, आप ready हो, consent ले लो. कह रहा नहीं सर, आई एम नॉट रेडी. तो फिर बोलोगे सर वी विल गिव यू वंस अ मंथ इंजेक्शंस. दिस इज वेयर द एक्चुअल MCQs will start from. Till now whatever I was teaching you was basics. Most MCQs that will come to you currently in your exam, whether FMG or NEET PG, will talk about once per month injections that are given subcutaneously for asthma to prevent attacks of asthma. Because nowadays is the era where we don't want the patient to suffer and land in intensive care unit. We want to prevent. These are the drugs which are to be remembered by you. That is mepolizumab, benralizumab, and obviously omalizumab, which was the first one to be introduced. Omalizumab, nobody will make a mistake, so he will not ask you that. Omalizumab usually will not be asked in multiple choice questions. Maybe 2020 से पहले उसने पूछा होगा because this is anti-immunoglobulin E. But at this moment he's asking you mepolizumab and he's asking you benralizumab. So you need to remember the following effects. First and foremost, remember what is the cytokine involved in pathogenesis, which is released from the eosinophils and causes asthma attacks, is interleukin 5. If you block interleukin 5 itself, that decreases eosinophil survival. Yeah, budesonide is an inhaled corticosteroid. ना budesonide is an inhaled corticosteroid. ICS lysis लिख रहा हूँ तो steroid तो हो गया. Interleukin 5 is the main villain in this particular case. So if you will block the production of interleukin 5, that is mepolizumab, और अगर receptor को block करते हैं तो benralizumab has a R present. तो आज एक याद करना है, benralizumab कैसे काम करता है. Hit the comment button. Does it decrease the production of interleukin 5 or does it block the receptor of interleukin 5? Please comment in the chat box. Yeah, dupilumab can be also used in this patient, right? Dupilumab, any of these molecules, mepolizumab, benralizumab, and then dupilumab can be used. Dupilumab की जगह पे most of the time what they will ask you is ये दोनों molecule. और क्यों पूछेगा इन दोनों मॉलिक्यूल्स का, क्योंकि ड्यूपिलीमैब तो इंटरलोकिन 4 और इंटरलोकिन 13 पे बेस होता है, तो दैट वुड बी फार्मा में आपने पढ़ा होगा 14 एंड 13, तो दैट एवरीबॉडी विल बी एबल टू आंसर। लेकिन इसमें गलती क्या होती है, दोनों में 5 है, तो इसलिए एमसीक्यू में मैंने आपको ये लिखाया है। सी द डेटा दैट आई एम गिविंग यू इज व्हाट द एग्जामिनर विल आस्क यू। एवरीबॉडी इज लाइक ड्यूपिलीमैब का क्या होगा भाई, ड्यूपिलीमैब तुम्हें नहीं पूछेगा क्योंकि इंटरलोकिन 4 और 13 के एक्शन को आप न्यूट्रलाइज कर रहे हो, दैट यू विल बी एबल टू आंसर। दिस इज द वन व्हिच इज अफेक्टेड, दिस इज वन दैट इज आस्क्ड। यस, योर आंसर्स आर राइट, इट इज interleukin 5 receptor that will be blocked in this particular patient, and the blockage of this causes the ADCC। इसके बाद क्या याद करना है, रिसेप्टर ब्लॉक करने के बाद होता है ADCC, that is antibody dependent cell cytotoxicity that destroys the body, destroys eosinophils, and eosinophils are the main villain, that predominant eosinophil, that cell would be neutralized in this particular case. So the point is benralizumab is like asked in MCQ, and mepolizumab is asked because both are related to interleukin 5. This was the preventive approach that I wanted you to be aware of, and like this particular slide को एक बार ही पढ़ने के बाद में अभी my suggestion to all of you is like if you got my questions that I was saying were correct। मेरे को बीच में ल्यूकोट्राइन्स और बड़े सारे आंसर आ रहे थे भाई, वो बच्चों वाली दवाइयाँ, ल्यूकोट्राइन से थोड़ी ना अस्थमा का अटैक ठीक प्रिवेंट हो जाएगा। This is the current algorithm, right? This is what they're asking. Leukotriene, तो जब patient cannot afford all this ना, injections are expensive. The one injection will be 16,000 rupees, 16 into 12, the treatment will go into lakhs of rupees. So patient नहीं ले सकता, तो अब वो leukotriene और मतलब montelukast और इन सब की बात करते हैं। And montelukast तो आजकल यूज भी नहीं करते ना। चलो कमेंट करो चैट बॉक्स में, अच्छा हुआ मैंने बोल दिया। montelukast, why it is not recommended? What is the black box warning? After that you earn your lunch. What is the black box warning on montelukast tablet nowadays? Yes guys, what is the black box warning on montelukast? Left, right, center, medical students भी montelukast खाते रहते हैं। Yeah, suicidal ideation. Yes, yes, yes. It is suicidal ideation, neuropsychiatric manifestation. So it is not recommended anymore, sir. It is the current algorithm that we'll be using for management of this patient. My humble request to you guys is, if you अगर एक भी पॉइंट आपका ट्रीटमेंट में इस स्लाइड पे गलत हुआ, एक भी पॉइंट बोल रहा हूँ, तो आपने क्या करना है, आपने पहले फार्मा के नोट्स, ड्रग्स एक्टिंग ऑन रेस्पिरेटरी सिस्टम फिर से पढ़ना है, देन कम बैक टू दिस स्लाइड एंड देन रीड द डेटा, and then you will be able to understand this is what I've explained for the preventive approach, that is to prevent exacerbations of asthma and an asthmatic. This is the current strategy to manage asthma, step up treatment. It is designed to prevent hospitalization in patients, क्योंकि ये तो हम करते ही रहते हैं ना, this we keep on doing, like patients keep on coming to the hospital, we keep on managing the patient, this decreases the quality of life in the patient. So our objective is to minimize the morbidity of the patient. We want to improve the quality of life in these patients. Yeah, lunch break है sir, I'm myself tired. So we go for a lunch break guys. We'll be resuming the discussion at 3:30, 3:30 पे डिस्कशन दोबारा से स्टार्ट होगा। Okay, when we come back, I'll try to do a summary of this one. So let's go for a lunch at the moment, guys, and 3:30 we'll start again. Then we'll talk about some छोटा मोटा easy वाला aspects, right? Okay, हाँ 40 minutes हो तो गया भाई, 40 तो करा है, 2:50 हो तो गया यार, तो 3:30 ही तो बोल रहा हूँ। Okay, okay guys, fine. 3:30 is we meet again. Okay, guys, I hope you joined back. You can come to page number 134. I'll be just discussing a summary for bronchial asthma before we go back to the next topic in respiratory system. Little bit is left. Okay, guys, fine. You guys had asked for like a summary, so I'll do that quickly and then we can move on. So 133, 134 are the page number where you can note down the data. I have already I will say like this that though I've already given an explanation, but still let me just finalize it once again. You can draw this circle which represents an alveoli. फिर alveoli के आसपास तो blood vessels होती हैं जहाँ पर gas exchange होता है. So this is a normal happening in all of us. Gas exchanges, gas diffuses from the alveoli into the blood vessels which are surrounding this. Bronchial asthma में क्या होता है? The difference from an asthmatic's lung from your and my lung is कि वहाँ पे the number of blood vessels is more. So I want you to draw more blood vessels here and represent hypervascularization of airways. And because of the hypervascularization of the airways, because surface area available for gas exchange is more, so therefore there will be more diffusion of gas. I repeat this again. What is the difference between the lungs of an asthmatic and you and me? Asthmatics tend to have hypervascularization of airways. ज़्यादा blood vessels present है. Hypervascularization implies that there is more surface area available for gas exchange, and because of the more surface area available for gas exchange, therefore in patients में diffusion capacity of the lung for carbon monoxide will be more. That's the main aspect that I explained to you. इसके contrast में if I draw a circle once again for the alveoli, but I show कि alveolar scarring हो गई है. If you're having alveolar scarring, now here I'm not showing any problem with blood vessels. Blood vessels are okay. Surface area of blood vessels is okay, but the surface area of the alveoli is affected. Like what you can see on the line diagram at the moment is कि alveoli में scarring हो गई है. So because of the alveolar scarring which is occurring in this patient, the diffusion of gas will be less. This line diagram that I basically shown before you is for a person of emphysema. So I had written the theory part for it earlier, but we are just summarizing the fact that asthma में और emphysema में difference क्या आ रहा है. In emphysema, there is a alveolar scarring because of cigarette smoking, because nicotine will go in the lungs, tar will also go in the lungs. The tar is a irritant. So it causes alveolar scarring, and as a result of it, the manifestations would be that there would be a decrease in the DLC of the patient. The diffusion capacity of the lung for carbon monoxide in this particular patient would be relatively less. अस्थमा के पेशेंट में DLCO मोर होता है, यहाँ पे लेस होता है. The problem lies with sometimes your internet. ना उसको कमेंट पे मत लिखा करो ना, otherwise it is a distraction for everybody. You just need to switch off and switch it on again. It will come back. Okay. The point is emphysema is a condition. मैं फिर से बोल रहा हूँ, अब डिस्टर्ब नहीं करना. Emphysema is a condition in which there is a alveolar scarring, and because of the alveolar scarring component, the diffusion capacity of the gas will be relatively lesser क्योंकि surface area is the main determinant for gas transfer. So in this patient the DLCO will be less. लेकिन एस्थमा में डिफरेंस क्या है? एस्थमा इज अ डिसऑर्डर इज हैविंग हाइपर वैस्कुलराइजेशन ऑफ द एयरवेज. इट्स लाइक मोर ब्लड वेसल्स प्रेजेंट, तो गैस बहुत ज्यादा डिफ्यूज कर सकती है, एंड देयरफॉर द डीएलसी ऑफ द पेशेंट इज मोर. सो दैट इज वन ऑफ द डिफरेंसेस दैट आई वांटेड टू ब्रिंग टू योर अटेंशन फ्रॉम फिजियोलॉजी स्लैश मेडिसिन परस्पेक्टिव. एंड नाउ इज लाइक व्हाट इज द इशू विद एस्थमा. तो पहले तो दो अल्फाबेट्स लिख लो, एक ई और एक आई. दो अल्फाबेट्स लिख लो, ई और आई. ए बी सी डी ई एफ जैसे होता है तो ई पहले आता है, तो बच्चा पहले आता है. तो बच्चों में जो एस्थमा होता है वो एक्सट्रिंसिक एस्थमा होता है. एडल्ट्स में जो एस्थमा होता है वो इंट्रिंसिक भी हो सकता है और एक्सट्रिंसिक भी हो सकता है. मैं अभी डिफरेंसेस बताऊंगा, बट पहले ई और आई लिख लो. जैसे ई अल्फाबेट कम्स बिफोर अल्फाबेट आई. ई अल्फाबेट कम्स बिफोर अल्फाबेट आई, सो पहले चाइल्ड विल कम एंड देन अडल्ट विल कम. सो वन आई वांटेड टू से दैट when it comes to adults, it can either be intrinsic or extrinsic asthma. But at the moment, the word is children have in extrinsic asthma. This extrinsic asthma is mainly related to E again. Immunoglobulin E levels are very, very high. And because immunoglobulin levels are very, very high, we aggressively treat the patient with help of steroids. And when we will be giving steroids in these patients, you will notice that there will be good response. तो धीरे धीरे क्या होगा कि जो एक्सट्रिंसिक एस्थमा होता है, जो चाइल्डहुड एस्थमा होता है, उसकी जो सिवियरिटी होती है वो धीरे धीरे कम होनी शुरू हो जाती है. The same thing can happen with adults also. The same thing can happen with adults also. Some adults will also be having asthma, which is of the extrinsic variety where immunoglobulin E will be more. Some adults can be having asthma where immunoglobulin E will be more, and these patients will be having response to steroids, and therefore like you will notice a very good prognosis in adults also. But some asthmatic patients ऐसे होते हैं, कुछ adult patients ऐसे होते हैं जिनमें जो inflammatory process होता है वो eosinophil से नहीं होता, वो neutrophil से होता. Like the extrinsic asthma that I was describing for child and extrinsic asthma that I was describing for children, that is mainly based on eosinophils, and eosinophils are related to immunoglobulin E. So what I want to bring to your attention is कि अगर asthma eosinophils से linked होता है, then it will always be having very good prognosis with steroids. But in adults, you will notice sometimes neutrophils being the preeminent cells present there, and you will notice a poor result to steroids, poor prognosis also. The disease will tend to worsen. The disease will tend to worsen, especially if asthma starts at 30 to 40 years of age. Then you will notice it will worsen with age. Normally asthma tends to improve with age, but here it will always worsen. So this is like a small introduction that I wanted to give, that sometimes you will notice asthmatic patients show very good response to steroids, and sometimes asthmatic patients show poor response to steroids. Who are those patients who are having poor response to steroids? They are having neutrophilic predominant asthma. If your asthmatic is responding to steroids, cool, that is standard. No, that is what they teach in medical college. Asthma is eosinophil, immunoglobulin E. So I'm not saying anything new. But what I'm trying to teach you is that lots of time your patients will not respond to steroids, and you will be at your wit's end कि यार हो क्या रहा है. These patients will worsen with age. That is neutrophilic dependent asthma. So one, I wanted to explain to you the disease spectrum. Pediatric onset asthma, super good prognosis. Asthma in some adults, good prognosis. But when it comes to some adults, neutrophilic dependent asthma, bad prognosis. That is one message that I wanted to give to you, that some patients respond and some don't respond. Now is the treatment part. For the treatment part, there are 3 MCQs that should be very, very clear. What do you do for acute exacerbation? That is one. Like he's having breathing difficulty right now. If the person will not be treated or he comes to the hospital late, then there can be severe acute asthma where the oxygen saturation at room air will become less than 90%. Pulse oximeter is easily purchased by most people, especially after COVID. 1500 रुपए का pulse oximeter आता है, person will purchase it. If oxygen saturation is less than 90%, that means it is severe acute asthma, and the person will not be able to communicate with you also. Then somebody in between had asked regarding brittle asthma. Brittle asthma, as brittle, glass is brittle. No, if I throw this glass, it will just break. So brittle asthma is like so severe that person will not even get time to reach the hospital and can deteriorate very fast. So I mentioned indirectly the treatment of brittle asthma also, but I'll write it once again. Somebody had asked that in between. And then is obviously how do you prevent attacks of asthma? So there are 4 domains that I want to just summarize once again. For acute asthma, अगर वो बोलता है कि आप क्या करोगे, तो आपने साबा नहीं बोलना है. आपका आंसर होगा LABA with rapid onset. There is no need to write rapid onset because now we have LABA with rapid onset with low dose inhaled corticosteroids. And if a person will be taking these with help of a PMDI, that is a pressurized meter dose inhaler, then the person's attacks will begin to resolve. But if the AQI is bad, then the person may not respond very well to budesonide and formoterol combination. LABA is formoterol, low dose inhaled corticosteroids is budesonide. Obviously, ask the patient always to rinse mouth with water. This is by default. Always ask a person to rinse mouth with water. This is universal information that you will be giving to your asthma and COPD patients. Rinse mouth with water to decrease the risk of oropharyngeal candida whenever ICS is being used. And obviously ICS is a standard part of the treatment. So rinse mouth with water to decrease the risk of oropharyngeal candida, because otherwise the person can have difficulty in swallowing, especially if esophageal candida will develop. So PMDI से हम उसको LABA and pressurized meter dose inhaler से LABA low dose inhaled corticosteroid दे देंगे. Now the patient can deteriorate into where the saturation is going less than 90% and he can't even talk to you. Here you will tell the patient, please come to the hospital. You will tell the patient, please come to the hospital. If he wants to, doesn't, like nowadays people are smart. They know going to hospital will cost 10,000 rupees in the whole night bill. So they purchase nebulizer themselves. And at home only they can manage. Obviously, they can't take IV steroids, but you can tell them that if you're having nebulization chamber at home, take nebulization yourself only. You can do nebulization with Duolin, you can do nebulization with Saba, that is short acting beta to agonist, which is recommended. And always attach now oxygen to the backside of the nebulization chamber to maintain the oxygen saturation. Don't give plain air driven nebulization, give oxygen driven nebulization. Sometimes the asthma can be so bad that person can die. When the attacks are very severe, person can die during the attack. Here I will share a small story with you. It was unfortunate it happened with me. I was taking a class in Hyderabad. This is like almost 10 years, more than 10 years ago. So I took a class in Hyderabad. So there was this guy, he in between the class now, he was getting up, going out, coming back in. So obviously I continued the class. It's not a medical college that I'll say, okay, why did you go and stuff like that. So after the class, he came to me and he said, boss, I'm an asthmatic. And like I was sitting near the AC vent. So that cold air was causing bronchospasm. So I'm sorry I was going out to the class and disturbing everybody, because like in a classroom you have to come down the stairs and go out. So everybody gets distracted. So he was just kind of a little apologetic. I said, man, you don't need to apologize. Like everything is fine, cool, man. I mean, I want you to just enjoy the class and no worries. So then he told me like, boss, I've also come to you because my asthma attacks sometimes are so bad. He was going to his car again and again. He was taking that puffer. He says, boss, sometimes my attacks are so bad that I feel as if I will die. I listened to him and I was like, are you serious? I mean, I'm like, we've seen asthmatics so many that they don't say that I'll die. He says, boss, my last time at time, his mom was HOD Pharma in Osmania University. So he said that boss, my attacks are so bad that last time like my attacks was very bad. My mom had to take me to Osmania casualty and my lips were almost turning blue. The attack was that bad. So when I listened to him, I just casually told him, this could be brittle asthma. And like ideally for this condition, though this treatment is not available most of the time in India in the form of EpiPen. EpiPen you need to get imported from abroad. It's not manufactured by Indian companies. So I told him कि तू ना किसी chemist को बोल के EpiPen मंगवा ले, so that like if something like this happens, then you don't need to rush to the hospital in an emergency, and like you can take this subcutaneous epinephrine and you will be feeling fine. So fine, the class ended, and like normally it's a 6-day class face to face. So I also lost contact. So next year when I went to like Hyderabad again to take a class, and like a couple of guys had come over because they got selected in NEET PG. So one of the guys told me about this particular guy who had approached me, the asthmatic guy, that this doctor like he got orthopedics are in Osmania only. So I was happy. Okay, gone. Orthopedics is a cool branch, and you'll enjoy your life. And then his friends told me something that shocked the core out of me. He said, sir, after the NEET PG was done, a couple of guys, like, this group, they went out to seafood restaurant and they were eating fish and prawns and everything. And like this guy started having breathing difficulty. And you will notice a lot of time asthmatics will be having allergy to various kind of food products also. So like somebody thought fish bone got impacted in the throat. Somebody thought he's having allergy to fish, and his attack was so bad, so bad, so bad that like he was telling his friends, he told his friends like, I'm not feeling well. He's trying to signal like this. And then his friend says, sir, he collapsed. And subsequently, when they took him to the hospital, it was brought dead. Can you beat that? A medical student, a doctor, a future orthopedician, cleared NEET PG. The boy died. The asthma attack was so bad that unfortunately we lost him. And one of his friends then, he was telling me that boss, like he was giving me his car keys again and again. When he was having this breathing difficulty, I was offering him water. I thought something got stuck in the throat of this guy, some fish bone or something. So he gave me his car keys, and he says later when I went and checked in his car in the glove compartment, this injection was there, EpiPen. He had bought the EpiPen, but he could not even tell that the attack is so bad that I need that pen. He says he was trying to signal to me, sir. I could not understand, because obviously, like if you don't tell somebody, then another person, even if he's a doctor, he or she cannot understand. So I wanted to tell you this story, which is like to explain to you that the attacks can really be so bad that the person can die. That's why the name is brittle asthma, where we give epinephrine subcutaneously to the patient. Then is prevention of asthma, about which I spoke about, step-up therapy. In the step-up therapy, it is LABA with low dose inhaled corticosteroids uniformly to be taken daily. Then we upgrade to medium dose steroids. Then we add LAMA. So I will just upgrade this by saying this is MD medium dose. And after that, the upgrade here is not high dose. We avoid high dose and we add LAMA. And after that, most of the time, the recommendation will be that we can subsequently add biologicals for management of this patient. I'm just putting a slash here to say that in government hospitals, when we don't have facility like biologicals, which are expensive, we do have to manage with oral corticosteroids. But now we have to use biologicals for management of this patient. So this is like a summary, guys, which I just wanted to share with you with respect to like what are we gonna do in asthma, what are the technical aspects that are gonna be dealing, which are valid for asthma, and the diagnostics part I've already highlighted. Diagnostics also I will write here. There are 3 tests for diagnosis of asthma. If he says best, then best would be answered as FeNO. That is like the single best test for diagnosis. FeNO showing nitroxide more than 50 particles per billion is like sufficient for diagnosis of this patient. Another test that I can do in the patient is obviously a flow volume curve. I drew that scooped out pattern before you. And the third test that I mentioned was like traditional जो routine करते हैं spirometry, where we check the value of FEV1 and then we will check the we will give salbutamol to the patient and FEV1 will be checked the second time. If you're an FMG student and you say कि सर मुझे एक पॉइंट बता दो जो कभी गलत नहीं होना चाहिए अस्थमा में, I said that right in the beginning. I'm saying it right now. If FEV1 shows more than 12% increment over the baseline value, if you get a 12% का increment over the baseline value, that is post bronchodilator. If you get a 12% increment post bronchodilator, you are like sorted for the diagnosis. अब मैं आपको सारा याद करना है, but ये तो ऐसा लाइन है कि this is inexcusable, non-negotiable statement that I've currently made here before you. This is the workup that I told. So this is like a one-page summary, though I could have said, man, I've already told you this, but I invested time into this since the request for the same came. I also wanted to share an unfortunate experience, which I normally avoid sharing. I took a live class. I did not even have the heart to talk about it. But then today I was like, okay, fine. Because when you are not in face to face with somebody, like, normally when you are maintaining eye contact, then it becomes difficult to describe a sad story. But today I was able to describe it. Yeah, methacholine challenge test is not done nowadays, na? It's a outdated test for reactive airway disease, na? Methacholine का मतलब क्या होता है कि we will be using acetylcholine and you will be using acetylcholine and there will be a bronchial hyperreactivity. तो मिथाकोलिन चैलेंज टेस्ट इज व्हाट वाज डन अर्लियर फॉर डायग्नोसिस. आज के डेट में इंजेक्शन लगाओगे तो पेशेंट तो मतलब लड़ना शुरू कर देगा कि सर मैं आपके पास डायग्नोसिस के लिए आया हूँ, इंजेक्शन लगाओगे मेरे को. इट इज स्पायरोमेट्री एंड FeNO. नाउडेज इज द एरा ऑफ नॉन इन्वेजिव मैन. सो लाइक आई कैन से लाइक 30, इवन व्हेन आई वाज अ स्टूडेंट तब भी ये नहीं करते थे. इट वाज स्पायरोमेट्री. सो आई कैन से 50 years ago when asthma was still a primitive disorder to be diagnosed, methacholine challenge test, yep, it indicates what is called as RAD, that is reactive airway disease. How much time we have to save a patient from brittle asthma to prevent death varies from case to case, but yeah, I think maybe half an hour is like a time that we can intervene there. Okay guys, so I think we are sorted for the description that I have given you, and I also want you to do a slight modification or a slight correction in the print in the handout there. Like in this handout I had mentioned the word extrinsic. Actually adults में दोनों वाला होता है, तो आपने क्या लिखना है कि इंट्रिंसिक एस्थमा प्रेजेंट्स इन अडल्ट एज ग्रुप. यहाँ पे बस एक चेंज मार लेना. इंट्रिंसिक एस्थमा इज मोर कॉमन. एडल्ट्स में दोनों होता है, एक्सट्रिंसिक भी इंट्रिंसिक भी दोनों बोला था ना मैंने. तो बच्चों में एक्सट्रिंसिक ज्यादा कॉमन होता है, ई फॉर इंग्लैंड, एंड एडल्ट्स में इट इज एक्सट्रिंसिक एंड एक्सट्रिंसिक बोथ, बट सिंगल बेस्ट आंसर इज इंट्रिंसिक. तो इसको थोड़ा मॉडिफाई कर लेना. इंस्टेड ऑफ राइटिंग द वर्ड एक्सट्रिंसिक, मॉडिफाई इट एज इंट्रिंसिक, बिकॉज एग्जाम में तो बस सिंगल बेस्ट आंसर मिलता है. सो इंट्रिंसिक एस्थमा प्रेजेंट्स इन अडल्ट एज ग्रुप कैन बी हैविंग नॉर्मल इम्यूनोग्लोबुलिन ई लेवल्स. दैट इज वन आई एम टॉकिंग अबाउट, वेयर द न्यूट्रोफिल्स विल बी इन्वॉल्व. So if somebody develops asthma at 30-40 years of age, and when neutrophils come in the picture, then you will have poor response to steroids. If you're having like eosinophils present and you are having elevated immunoglobulin E levels, then you will always be having like very good response to steroids. So I think we're sorted for asthma. I think most questions on this topic will come on like the drugs perspective only, from pharmacology perspective. That question I've solved before you, even in Instagram, that bernalizumab is the commonest thing that would be asked to you, that it will block the interleukin 5 receptor. And now I am gonna put a question to you guys, which is like on my mind since morning. I was literally itching to go for this. 25-year-old guy is having a bike accident and then the chap is hospitalized for polytrauma, and then there's a sudden onset breathing difficulty. The saturation is dropping. No, no, we don't intubate. We avoid intubating. सर इंट्यूबेशन हो गया तो इम्पेंडिंग रेस्पिरेटरी फेलियर हो गया ना, वो तो मतलब वर्स्ट वर्स्ट के सिनेरियो ना, वो तो वी डोंट वांट टू इंट्यूबेट. Yes, what is the best way? Bike accident in a chap, hospitalized for polytrauma. On day 3, there is a breathing difficulty. The saturation of the patient is falling 80%, and there is like blood pressure of this guy is 90/60. The prominent neck veins are present in this case. So, what is the diagnosis in this case? I want more people to hit the comment button. At this moment, I'm having like almost 600 students in the chat. So, I think the chat should be commenting. Like, I would expect more answers here. Right, and I have never pointed out anybody for any answer all these days. Right? I've never said, oh, why did you answer this? Right? Okay. Okay, I'll wait for another 5 seconds before we move on. Even without, if I don't focus on the CTPA that is given here, what I want you guys to realize is, see, almost like this is almost 60-40 going at the moment. 60% students are saying fat embolism, and 40% or 30%, I'll put it 70-30. I mean, most of the comments that are coming at the moment are fat embolism, and 30% comments are for pulmonary embolism. And the answer for this question is option number A. It is pulmonary embolism. It is not fat embolism. Let us look at why the answer to this question is option number A, fat embolism. Fat embolism does not cause hypotension. Fat embolism does not cause elevated JVP. The moment you saw this patient having elevated JVP, you should have understood that the person is suffering from a clot in the pulmonary artery. If you have clot in the pulmonary artery, yes, we will talk about. Pranav, you have a very good point. But at the moment, we will look at what is the data given in the question. Guys, this is a common question. Bike accident, trauma, saturation dropping. And in the recall session also, a lot of students are like, answering fat embolism. आया था sir paper में. Fat embolism पूछा ही नहीं यार उसने. Even coaching academies have given answer as fat embolism in the recall, saying कि sir student ने बोला था fat, student ने बोला था यार, student का तो आंसर गलत हो सकता है ना. The point is the guy is having heart failure. That must means that there is something blocking the pulmonary artery. And what is that something blocking the pulmonary artery? It must be a clot. You see, after trauma, if the person will keep on lying on the bed the whole day, there will be deep vein thrombosis. And because of deep vein thrombosis, there can be a clot which can be dislodged from the deep veins towards the lungs of the patient, and it will cause a pulmonary thromboembolism. That is why the right ventricle of the patient is failing and is causing elevated JVP, and if blood will not go in the lungs, there would be a hypotension. In most of the questions of your exam, to help you, they will also give you a CTPA. Even if they don't give it, you should still be able to crack the question on the basis of elevated JVP. But if they give, then it is super easy, because what you can see at the moment is the pulmonary artery, and in the middle of the pulmonary artery, there is a big clot. This is the ascending aorta. This is the ascending aorta. This is the descending aorta. And at the bifurcation of the pulmonary artery, there is a big clot present. Just for the sake of completion, I would also like to mention this structure present here is the bronchus. Two structures now, that means the trachea is bifurcated into bronchus. And what is present here? This is the esophagus. So when you look at the anatomy, you can notice this is the vertebra posteriorly, the VX is the vertebra posteriorly. Then you can see the spinal cord, the white area shadow of the spinal cord. This is the esophagus, the two bronchi, and a big clot. Bang. Yeah, we will talk about it, beta. Abhi, we will talk about Cleaxin or low molecular weight heparin used for it. But at this moment, yeah, that's the point. Long bone fracture पढ़ते ही हर कोई बात करता है fat embolism. अभी I will tell you the GERD criteria. Some guys have correctly picked it up. Even if it's a fracture of the long bone, so what? It is not a guarantee, na? Fat embolism will occur. It's a rare event. So how will the MCQ will you pick up in 30 seconds whether it is fat embolism? How in 30 seconds will you pick up whether it is fat embolism or pulmonary embolism? The word is GERD criteria. The black is the clot, which is the filling defect that is present here. This diagram that is shown here to you is called as CTPA, that is CT pulmonary angiography. And now I will explain to you that what are the keywords that you're supposed to look in the MCQ so that you can differentiate in 30 seconds whether it is a fat embolism versus pulmonary embolism. All eyes on the board, please listen to the data very clearly. Suppose it gives you a case of fracture of the long bones. This guy was driving a Harley Davidson. This guy, his father is a property dealer, and this family is like loaded with money. So they purchased him a KTM, or they purchased him a Harley Davidson, some fancy bike, and this boy is driving the bike fast. And unfortunately, he had an accident because of which there was fracture of the shaft of the femur, for which he was taken to the best hospital in Delhi or Gurgaon, where open reduction and internal fixation was done. The best orthopedician of Delhi has operated on this guy in the shortest possible time frame. Everything is going fine, and now let me say 24 to 48 hours have passed by. After 24 to 48 hours, this particular guy, like today morning when you went for round, this guy was doing Instagram live from the ICU. This guy was Instagram live for ICU. He was boasting in his biker club. See, I'm gonna show you how the ICU looks like. And when you walked in, he also included you in the Instagram scene. Hello, doctor, how are you? Right, this is my doctor. He's come for round. And see, this is the fracture that I had. I've had a ORIF. Guy is boasting. And right now at lunchtime, this guy starts having breathing trouble. The guy starts having breathing trouble because there is production of cytokines, because every time fat is released from the bone marrow, the fat released from the bone marrow will cause release of cytokines, and these cytokines will start causing damage to the pulmonary endothelium. So in this particular patient, at this moment, he is having shortness of breath. The nurse at this particular point of time checked his checked his SpO2 by pulse oximeter. The saturation at room air was less than 90%. She called up the orthopedician. Boss, you operated on a case. The patient is having breathing difficulty. He said, okay, give oxygen, I'm coming. Meanwhile, bedside X-ray has also been done, and the X-ray is showing snowstorm appearance, that white shadows that are present. In the question that I discussed, there was no mention of any mention regarding snowstorm appearance. It mentioned saturation drop, but did not mention any snowstorm appearance present. By the time the orthopedician will complete his case and come, the cytokines will damage the microvasculature of the brain, and this patient will also become unconscious or will become unresponsive. In the case that I had given you above, there was no unresponsiveness, there was no unconsciousness that is given. The cytokines that are present, not fat emboli, not fat emboli. It is the cytokines produced due to the fat emboli. It is cytokines produced due to the fat emboli that will damage the microcirculation of the brain, that will cause the patient to become unconscious and unresponsive. Some people had already commented a hemat manifestation here. That would be petechiae. This petechiae will develop in the skin of the axilla. Then it involve the whole of the chest wall. So suppose in this particular question there was mention of large number of petechiae starting in the axilla and involving the chest wall of the patient. If these kind of data were given in the question, then you will say I'm dealing with fat embolism syndrome. I am dealing with fat embolism syndrome. But in the case that I'm describing before you, this is not happening. Oh, it is a polytrauma case. What has happened in this current cases? What has happened in the current cases, that there is a blood clot or multiple clots that are unfortunately going into the pulmonary artery. So look at the comparison here. I would not suggest you to draw this at the moment. I would like you to listen to me because I'll modify the diagram. The clot is causing obstruction of the pulmonary artery. The blood is going only one lung. God has given us two lungs. Now only one lung functioning, saturation will drop. In this patient, the pulmonary artery pressure will rise because there is obstruction. Because of this obstruction, what will now happen in this patient is that the clot is obstructing the pulmonary artery and the pulmonary artery pressure is rising. So right ventricle will fail, and due to failure of the right ventricle, the neck veins will become congested in this patient. You will start getting a Kussmaul sign, and the congestion in the heart will keep on increasing. If the congestion in the heart will increase, it will also contribute to septal deviation because pressure बढ़ता जा रहा है. It will also contribute to septal deviation. This septal deviation was asked in FMG exam as McConnell sign. That is a echocardiography finding found in this condition. The septal deviation is called as McConnell sign on echo. If you look at the diagram here, what is happening is that the cavity of the left ventricle will become smaller. If the left cavity will become smaller, it will be able to receive less amount of blood. If it is less able to receive, if it is able to receive less amount of blood, the input is less, the output is less. That is why in this MCQ that I gave you, blood pressure was less. I never mentioned hypotension for fat embolism, but I mentioned hypotension for this case due to pulmonary artery hypertension in a patient. If I say the sequence is like this. First, there is pulmonary artery hypertension. Due to pulmonary artery hypertension of the sudden onset, there is a development of sudden onset right ventricular failure. Because of the sudden right ventricular failure in the patient, there is also a septal deviation. This septal deviation that is happening is causing the fall in blood pressure of this patient. There is a hypotension. The problem is in the right side. The BP is falling on the left. The problem is in the right side and the BP is falling on the left. This entire presentation, if I zoom out on the right hand side, this entire presentation, if I zoom out on the right side, is technically called as massive pulmonary embolism. This was the answer to the question that I was asking you, which a lot of people were casually answering कि sir trauma का case है तो should we not answer as fat embolism, because that is how wrongly it is taught. Most people say कि सर ऑर्थोपेडिक ट्रॉमा लिखा था मैं फैट एम्बोलिज्म मार्क करके आ गया. अरे डायग्नोसिस ट्रॉमा के बेसिस पे थोड़ी ना होता है. डायग्नोसिस इज बेस्ड ऑन द बेसिस ऑफ क्लिनिकल फाइंडिंग्स व्हिच आर प्रेजेंट इन अ पेशेंट. Here the clinical findings were not suggestive of fat embolism. This entire presentation is called as acute cor pulmonale. The cause of acute cor pulmonale where right ventricle is failing is massive pulmonary embolism. If you are listening to me carefully, before the break I ended the video by saying cor pulmonale is seen with COPD. But if I change the question and say acute cor pulmonale, their answer will be massive pulmonary embolism. I will repeat my statement. If you raise the word plain cor pulmonale, मतलब धीरे धीरे pulmonary artery hypertension, धीरे धीरे pulmonary artery hypertension. If slow pulmonary artery hypertension will occur, then the person will develop it due to COPD, because COPD is over so many years. But here 10 minutes ago the guy was okay, and then there is a sudden onset pulmonary artery hypertension due to a clot which is physically blocking and is causing the following manifestations in a patient. What I have done here in front of you is try to explain to you how in a question in the shortest possible time frame will you differentiate fat embolism syndrome, which is currently written as short form as FES. Fat embolism syndrome will be differentiated from acute cor pulmonale or massive pulmonary embolism. The differentiating feature will be if he himself says snowstorm appearance in a chest x-ray. At least remember at this moment, lungs should be involved, brain should be involved, and hemat should be involved. Petike. Lungs should be involved, brain should be involved, and petike should be present. This is what is technically called as major GERD criteria, which are used for diagnosis of fat embolism in a patient. So they will give you question in the paper where petike will be there, unresponsiveness will be present. The person will be having breathing difficulty, no problems. If unresponsiveness is there with breathing difficulty and petike, you answer fat embolism, cool. But if the question is reframed as, I will show you this question again, and now you will have a better idea regarding how to analyze these questions. A guy has a bike accident and is hospitalized for polytrauma. Don't assume it is a case of fat embolism. Assume it can be fat embolism versus pulmonary embolism. Check out the vitals. Heart rate is 100. Okay. BP is low. You don't have I never said hypotension for fat embolism, man. I never said elevated JVP or prominent neck veins for the same. The moment you read up the fact, yes, very high mortality in fat embolism, more than 50%. The moment I said the fact prominent neck veins, you should have immediately picked up कि ये तो pulmonary artery का problem है. Pulmonary artery block हो गया. And pulmonary artery is blocked by a clot, which I just showed before you, that came from the lungs of this patient. So at this moment, what I've tried to do is compare between you fat embolism and massive pulmonary embolism on like perspective of like what will you check out in the question. If CNS features are given, if petike are given, answer it as fat embolism. If only hemodynamic manifestations are given alone, if only hemodynamic manifestations are given alone, then you will say you are dealing with massive pulmonary embolism. In most of the questions of your paper, they will give you a CTPA also. In most questions, if they want answer as pulmonary embolism, they will give you a CTPA also. If CTPA is not given, then it goes more in favor of fat embolism, where you can see this huge clot occluding the pulmonary artery. It's literally like a saddle embolus. Now we will do the MCQs which have come in the exam for the current topic of interest, pulmonary embolism. This was a question I think is an FMG exam. What is the first investigation or screening test to be done for this condition? The first test would be to check for the state, because this guy is having a hypercoagulable state. Immobilization causes hypercoagulability. If somebody will keep on lying in the bed the whole day, in 48 to 72 hours, you could be having is a development of clot formation in the leg veins. That is why after any small or big surgery, we advise the patients to always be mobilized. The petike seen only in axial and chest wall, no, they are involved whole of the body, but they start initially in the chest wall. Clinically, if petechiae are appearing around the feet, if they're appearing around the ankles, that is what is seen in thrombocytopenia, which is due to dengue or due to ITP. In idiopathic thrombocytopenic purpura and dengue hemorrhagic fever, petechiae first involve the feet and then they start coming up. But here the disease is starting in the chest. So petechiae will be starting in the axilla and the chest wall of the patient. In dengue hemorrhagic fever, due to gravity, in idiopathic thrombocytopenic purpura due to gravity, the petechiae पहले पाँव में आते हैं, पाँव से ऊपर ऊपर आके पूरा बॉडी में आ जाते हैं, पूरी चेस्ट वॉल, एवरीथिंग गेट्स इन्वॉल्व्ड इन डेंगू हेमरेजिक फीवर और ब्लड कैंसर. Blood cancer also causes thrombocytopenia. But in this condition, the involvement is diseases where in the chest, where the fat emboli are causing a cytokine release, which is destroying the platelets. So the disease process in the chest, so the fat, the petechiae are present mainly in the chest wall of the patient. The next question said, yeah, even if it is hemodynamically stable, every patient will require a D-dimer assay. D-dimer assay is not a diagnostic test of pulmonary embolism. It is a screening test which tell you hypercoagulable state. Then he has asked, what is the non-invasive test to identify the cause? To find the cause of why is it happening? Why is it happening? Now this is, I think, a NEET PG question. He went a little deeper. कि क्यों हो रहा है? So because it is because of the fact that the clots is occurring in the legs. So you will be doing a Doppler of the extremities of the patient. The reason why you are doing a Doppler is because ultimately the clots are starting in the deep veins of the patient. Let me know quickly which are the veins which are usually involved here. Which vein the clot will be developing? Options are short saphenous, great saphenous, soleal vein, popliteal vein. Yes guys. Clot कहाँ पे बना होगा mostly? Sir, not saphenous vein, man. Not saphenous. Saphenous vein is the superficial vein. Saphenous vein is, sir, what is peripheral heart? Peripheral heart is soleus muscle, na? So if you are not gonna use your peripheral heart, there would be stasis of blood in the soleal vein. The clot usually develops in the soleal vein, then goes up in the popliteal, then goes up in the femoral, and then goes into the heart. The source is soleal veins. इस पेशेंट को हुआ क्या था? तो the person is ending up with development of soleal vein clots, soleal vein thrombosis. This clot broke off from here and retrogradely traveled to the heart and is causing deterioration. So I'll do a Doppler. The investigation of choice for this condition has already been explained to you. It is CTPA, that is CT pulmonary angiography, which is a test which is never ever forgotten because name is like this, CTPA, CT pulmonary angiography. In massive pulmonary embolism, which is the current case, the blood pressure of the patient will begin to fall. Most of the time he will say crashing blood pressure. Because the BP is crashing, you need to be aggressive. What I mean by aggressive is that you will be using thrombolysis in this patient, that is L-teplase, to destroy the clot in the pulmonary artery. If we will not do thrombolysis, the patient will die. And the second thing that we will give is injections of enoxaparin because he's having deep vein thrombosis. So you know that the clots can come up. One clot has gone towards the lung, more can go. Enoxaparin, I'm mainly giving heparin for treatment of deep vein thrombosis and for treatment of obviously the clot which is existing. But to destroy that clot, the main molecule that will be used is not enoxaparin or low molecular weight heparin. It is L-teplase that would be used in the patient. Now suppose if they give you a question in which the BP is recordable, it is low but it is recordable. In those circumstances, I will not do thrombolysis. In case the BP is recordable, then you don't need to use L-teplase because one of the biggest side effect of L-teplase is the side effect of brain hemorrhage. So in those circumstances, I will be using only low molecular weight heparin. If the person is having, if patient is having crashing blood pressure, we are more aggressive. Then we give L-teplase. And if the BP is normal to low, then we give plain heparin to the patient. Just remember like this, more sick patient, more number of drugs, less sick patient, less number of drugs. So enoxaparin is given subcutaneously to these patients, that is once a day. That is mainly going to handle some massive pulmonary embolism or plain pulmonary embolism where chota clots are going in the heart. If it's a big clot causing a physical obstruction, I will be more aggressive. If it is smaller clots, then I will be less aggressive. So the main difference is just like in arrhythmia topic. In arrhythmia topic, if BP was crashing, we were giving DC shock. Here we are doing thrombolysis. We are being more aggressive. That's the point, more aggressive. And when the person is having PE, multiple chota clots, then there's no need of like being L-teplase to be used. Then enoxaparin alone is sufficient for this question. Most of the time in the exam, he will assist you by giving you indirectly parameters of deep vein thrombosis. Deep vein thrombosis, how is it picked up? One of the findings is called as Homan sign. Homan sign means that ankle dorsiflexion. Woman sign means that or ankle dorsiflexion will develop or will cause development of calf pain in the patient. Ankle dorsiflexion will cause calf pain. Here I also want to give example of the tennis player Serena Williams. Like if you follow sports, if you follow lawn tennis, then Serena Williams, Williams sisters have been for 10 years they've been like leading the tennis circuit. Whether it is Wimbledon, US Open, Australian Open, all titles are mainly won by these two ladies only. Serena Williams, she got married, she had a baby, and after a delivery, like she was having pain in her calf muscles. So she told the gynecologist it was a weekend. The gynecologist was going on a holiday, and like Indian doctors don't go on holidays, right? This US doctor, she was going on a holiday, so she told her also, "Oh, I'm going on a holiday. I'm going for fishing on the weekend on the lake. Not be available. What's your problem? Oh, calf pain. Oh, don't worry, everything will be fine. It's natural to have pain after delivery." The gynecologist went for fishing, and in the evening, Serena Williams started having breathing difficulty and her oxygen saturation started falling. After that, her blood pressure started falling, so they rushed her into intensive care unit where the Indian doctor was present. Indian doctor did not go for fishing; he was doing duty because poor country, poor people, you have to earn dollars. So he was doing a locum duty. Locum duty means that you just get paid by the hour. This guy, Indian doctor, he was doing a locum duty, and he identified that she was having pulmonary embolism on the basis of the clinical profile, and she was given thrombolysis. She posted on Twitter. Now Twitter is X after Elon Musk took over. So she posted about this bad experience in an American hospital on X. And usually we think that America is like which is having number one best medical care. We try to we compete with American doctors, right? That oh, if they are doing it, we are also doing it. But medical negligence can happen anywhere. Medical negligence can happen anywhere. Not that I'm blaming the American doctor. In my opinion, what would have happened is because tennis players have big calf muscles. Tennis players have big calf muscles. So by looking at the calf muscle, like you and me don't have very big calf muscles, no. So if your calf muscle is swollen, doctor will be able to pick it up early. If you do sports, it's a different thing. If you do your calf training regularly, that's a different thing. But regularly, like we don't have very big calf muscles. So if calf muscle or somebody is swollen after delivery, it's easy to pick up, but like maybe she's a tennis player and the case got missed here. Yeah. Homan sign is not used. It's a old sign, na beta, but it is given in MCQ. So I need to say that is why it is not specific. That is why I never said this is parameters to be checked in the question. This may or may not be present. That is why there are three things that are highlighted. Homan sign is not reliable, sir. What is reliable is Doppler. That is what I said. Homan sign is not the best way. और यहाँ पे मैंने क्या बोला? Did I say calf pain? I said calf swelling. If you listen to me, what was I saying? I never said calf pain is diagnostic. I said this is just one of the findings present. And what was I teaching you? After delivery, if a lady is saying I'm having swelling of the calf, that is the problem, right? That is what I was saying. That Serena Williams she's a tennis player. No, calf muscles will be big. That swelling would have been missed there. So Homan sign is not reliable, but what is reliable is the presence of calf swelling. If you notice that after delivery, a patient is having limb asymmetry. That's the word that is given in your question nowadays. We don't base our diagnosis on the basis of Homan sign. We base our diagnosis on the basis of calf swelling and limb asymmetry. If one calf muscle is bigger than the other, a tennis player calf muscle वैसे ही big है तो bias आ गया होगा उसके mind में. That is why I was not defending the American doctor. I was trying to tell you why the case would have been missed. So the words of mine were not my words of mine were not calf pain. My words of mine were, if you're listening carefully, calf swelling. Blood pressure values in the patient. The blood pressure will begin to fall, and echocardiography in this patient will be revealing the following facts. One, there would be like the presence of McConnell sign. That's like easy to pick up, McConnell sign. And second, what I can say is you can even visualize the clot or clots in the pulmonary artery of the patient. Dance of death again in the pulmonary artery of the patient. Ventilation perfusion scan is done for small pulmonary, for multiple small emboli for PE, right? Not massive PE. अगर PE है ना, छोटू छोटू से clots है. So then we can go in for a xenon V by P scan, that is ventilation perfusion scan. If it is छोटू छोटू clots, like if I just do a line diagram representation here. In the patient, what entered is, you don't need to draw this. This is just for because the query came up in the chat. Otherwise, just let it go. ये diagram मत बनाना. सिर्फ सुन लेना query came in the chat. अगर ऐसे इतना छोटू छोटू clot आया, then you can't see them, na. These clots will go via the pulmonary artery into branches. Even in the branches are big. Even then also not. So it will go to the end blood vessels. It will go to the end blood vessels like this, and those blood vessels will get blocked. So if I'm having that, xenon ventilation perfusion scan, then yep, it is like this would be useful. But for the large clots which are present, large clots that are present, we would be going ahead with the standard investigations that I mentioned. And I hope it's clear. It's not human sign that I'm relying on. It is the calf asymmetry, the asymmetry of the limbs that I am basically harping on, along with the hemodynamic instability that can come up in the patient. Yeah, Indians, sir, they can pay 500 rupees, that would be less than $10, and they can go and see any doctor anywhere. यूएस में तो सर पैरासीटामोल का स्ट्रिप ही आई थिंक $6-7 का है. Paracetamol is itself, I think, $5 or $6, right? And Tylenol, they call it, right? For everything, Tylenol is available. So, like most Indian doctors are the most hardworking people, because all through our life, we are drilled that we have to study and we have to work and we have to earn and we have to save, right? So, like most like Indian doctors, Indian and Chinese, like if you look at US at the moment, so you will find Indian, Chinese, and Filipinos, right? Maybe like a lot of Filipino doctors or Filipino. It's more nurses, I think, right? Nursing program of Philippines is like very very robust, we would say. Even if you go to Dubai, I mean, most of the doctors there would be either Filipinos or Indians, right? Or Pakistanis, some Chinese, maybe. Chinese mainly go to America and Canada nowadays. But then, like, I mean, Southeast Asia is where like hard work happens. Hard work happens. In USA, there is only one district, no, California, where you have good universities and where you have very good graduates available. Otherwise, like most of USA is only Instagram and OnlyFans, no? Most of USA, आके बच्चे पढ़ते पढ़ते नहीं है सर. इंडियन बच्चे तो पढ़ने वाले होते हैं ना, यूएस के बच्चे कहाँ पढ़ते हैं सर, वो तो मजाक है. Ventilation perfusion scan, guys, is a test for small clots. I'll just say that again. BP scan is for small clots. It's able to target and tell you focal oligemia in the patient. So Doppler is preferred. CTPA. It is CTPA. CT pulmonary angiography is the CTPA. CT pulmonary angiography. Yeah, I think the chat came a little later, so you guys obviously understood that. Barb at the Americans. Americans do like this only. The president is also crazy, country is also crazy. Yeah, and gun crazy, right? That's all they do. Crazy people, they keep on bombing people, harming innocent people, crazy. Okay, coming back to the agenda, the only thing was uh, shots fired. Yeah, yeah, yeah. The points to be understood are that ventilation perfusion scan is only for like if the ultra small clots are present. For large clots, we don't need to, do anything much. And okay, I'll come back to the agenda. Keep the focus on, guys. But the topic I'm teaching you is pulmonary embolism. It is a super neglected topic, but like each of the lines that I've said here is super important. And why I'm like saying it is not because just because I'm discussing this topic, guys. Respiratory system का सबसे important topic from medicine is pulmonary embolism. Asthma and COPD you will keep on reading in other subjects also. But this is a pure general medicine topic that I've currently explained to you. So all of these words that are to be remembered are to be remembered. Perspective are fat embolism. Yes, was a good answer initially, but I hope I've been able to successfully differentiate and explain to you regarding why the answer is not fat embolism and it is pulmonary embolism for this case. Now, we will discuss couple of more questions here. This was last time's FMG only, or because they occurred very close together, so sometimes it gets overlapped. Okay, I'll come to S1 Q3 T3. It's not diagnostic ना बेटा. I mentioned S1 Q3 T3 even in my ECG finding. अब मैं दोबारा से बोलूँगा तो it will not give any diagnostic importance. It will just unnecessarily increase the data on the board, but it is not a diagnostic importance ना. S1 Q3 T3. Yeah. Let's move to the next one. Here having a person with colorectal cancer. The patient underwent a hemicolectomy. I want you to remember all cancers are hypercoagulable state. All cancers by default, all cancers by default are hypercoagulable state. The patient's ATCO2 is suddenly falling. The ATCO2 went from 35 to only 5 with hypotension. So that hypotension again is telling you that there is something which is causing less blood supply to the left side, because maybe the heart is not able to function properly. The ATCO2 fall, and this is the standard intraoperative presentation. This is a standard intraoperative presentation that you will get with pulmonary embolism in a patient. Yes, guys, you're perfectly right. ETCO to the patient, then suddenly there's a hypotension. All of the things which are given here, though I think recently you had anesthesia also. So everybody is able to understand the significance of this question. Hypercoagulable state and then sudden onset hypotension intraoperatively with drop in ETCO2. First thought process is pulmonary embolism in the patient. So good answers by everybody. Moving to the next question. Now you are having a guy with a bike accident and he is hospitalized for polytrauma. On day 3, there is a sudden onset respiratory distress and he becomes unconscious and unresponsive. Then the vitals of the patient are given with petechiae noted in the chest wall. The moment you read that, the moment you read the fact that there is petechiae noted on the chest wall and he is unconscious, unresponsive, then you will say that you're dealing with fat embolism syndrome. For diagnosis of fat embolism, we have criteria. Your answers are spot on, guys. Both answers have been beautifully answered by everybody here. I hope almost like 100% strike rate has been achieved in these two questions. And now I will make you practice the GERD criteria once again. For GERD criteria for fat embolism, we have major and minor ones. I'll just revisit the core things once again. Most of this information that I will say is junk. Saying myself, the information tell is junk because that will be filler options in the MCQ. They will not be the answer in the MCQ. Yeah, beta, I just told you, hemicolectomy. All cancers are hypercoagulable state. It is not hemicolectomy. All cancers by default are hypercoagulable state. Cancer surgery is double insult because surgery will again contribute to a patient's immobilization state. But here I'm saying not immobilization due to surgery. Cancer is a all malignancies are hypercoagulable state. What will you check for? You will check for petechiae. There would be hypoxia. Understandably, the PO2 will decrease dramatically. There might be a drop in the hemoglobin level, but the most important thing will be there is CNS manifestations that would be occurring in this patient. That sudden drop in hemoglobin is a lab parameter that may or may not be present in a patient. But the most important thing is like this is like I'm putting a line over to say this may or may not be present. This is like sometimes may be demonstrated, sometimes not. But the main thing is clinically what you check for. You check for petechiae. You check for the sudden drop in the oxygen saturation, which is always reflected in the ABG, and then there would be CNS manifestations, remembered. So I'll just draw a line diagram saying if any patient after polytrauma is having lung involvement, brain involvement, and petechiae, you can just symbolically draw like this. If lung involvement with brain involvement and petechiae is given, these are the major criteria. Filler options in the question will be there will be tachycardia, the body temperature will rise, and then he will mention regarding urinary fat globules. Urinary fat globules is the only thing to be noted or marked here. Urinary fat globules for this condition is a minor criteria for diagnosis. This is again a very peculiar term because you don't read about fat in the urine routinely. So that's just one of the findings along with thrombocytopenia, ESR, and a drop in the hemoglobin of the patient as well. The person will, all other things that I've said, no, they will basically be filler options in the MCQ. Yep, inflammatory states are cytokines, interleukin 1. Why there is a fever? What was the cause? Cytokine. What is the cytokine that adjusts the thermostat of the hypothalamus? Interleukin 1. So interleukin 1 जो होता है बुखार करवाता है. So that's why this manifestation of pyrexia is coming up in the patient. It's literally like a cytokine storm that is happening, right? It is not the fat globules that are going directly in the organs. It is the fat globules which are triggering something akin to a cytokine storm, which is contributing to damage to the pulmonary endothelium, which is damaging the microvasculature. यहाँ पे किस किस को डैमेज हो रहा है? तो cytokine को induced damage है to the microcirculation of the brain and microcirculation of the heart, and therefore there is no treatment available. The mortality rate is more than 50% in an era where जहाँ पे हम MI में mortality 5% 1% रहती है सेंटर्स में 1 to 5%. यहाँ पे कह रहा हूँ कि the leading cause of death like ischemic heart disease में mortality 1 to 5%. Here we will be having like mortality rate very high 50% mortality because there is no score by which, yeah, this is where the examiner will try to make the score question bigger. ESR डाल देगा, labs डाल देगा, thrombocytopenia डाल देगा, तो उसमें है. नेफ्रोटिक में फैट ग्लोब्यूल्स नहीं बोलेंगे ना, ओवल फैट बॉडीज बोलते हैं. Okay, coming back, abhi I'll not get into nephrotic Pranav, but I got what you're trying to say there. Microcirculation injury is occurring for these patients, and this is again an example of non-cardiogenic pulmonary edema. So what I've described in the end is the topic of fat embolism syndrome at the patient. Again, a very critically important topic that has been discussed here. FES in comparison with fat embolism in comparison to massive pulmonary embolism. Okay, I will have some questions for you at the moment, and this is a rapid fire questions that I'll be saying. All of these questions will begin by saying sudden onset respiratory distress in a patient. So here we go. The first question is that the doctor has put a central line in the subclavian vein. Like today, you are planning to give a total parenteral nutrition to a patient with cancer. You have put a central line, and after putting central line in the subclavian vein, you went for a coffee or a tea, and you had not even like sipped the tea and coffee. The call came from the ward from the nurse that sir, patient is having shortness of breath and patient is having drop in saturation, so please come. And you had to literally literally throw away your coffee or tea and you have to come back. So what is the number one reason why this would be happening? Options are pneumothorax and then is venous air embolism. Some people have started commenting without my options. I'm just giving options. One is pneumothorax and second is air embolism. What is the number one cause? Yeah. The answer in this question would be given as pneumothorax. I think it was 90 and 10. Some people did answer venous air embolism. So I will tell you when should you answer it as venous air embolism. At the moment, the answer is traumatic pneumothorax. What is happening is that when you put the central line, if you push it to ahead, then you can damage the subclavian vein and go into the lung parenchyma. So pneumomediastinum, pneumothorax is one of the number one reasons, and this would be a traumatic pneumothorax. This would be occurring in a patient. It is iatrogenic actually. It is a iatrogenic pneumothorax that would be occurring in a patient after putting a central line. Now I will change the question. The question is that the patient is undergoing neurosurgery. The patient is undergoing neurosurgery. What I say next will not be written in the question, but that is the explanation that during neurosurgery, the dural venous sinuses can be injured. What I mean by dural venous sinuses getting injured is like dural venous sinuses like superior sagittal, inferior sagittal, or it can be sigmoid sinus, transverse sinus getting injured. So dural venous sinus will get injured, then this will not be written in the question. But what he means is that if the dural venous sinus is injured, उसको अगर आपने खोल दिया, so then the atmospheric air will be sucked in. And that atmospheric air that will be sucked in will travel through the jugular vein towards the heart and will cause the development of venous air embolism. So specifically, if the question is on the topic of neurosurgery and mentions that the patient is having sudden onset respiratory distress with drop in saturation, then your answer would be VAE, that is venous air embolism. The third question that I would like to mention is for a patient who undergone a total hip replacement. Or instead of saying a total hip replacement, he might say orthopedic implant surgery like total knee replacement. He will specifically mention regarding orthopedic surgery which is done in the vicinity of the femoral vein or is done in the vicinity of the popliteal vein. These are big veins which are present. I hope you can quickly give me the answer. Orthopedic surgery was done in a patient, total hip replacement, total knee replacement, and there is a sudden onset breathing difficulty experienced within 24 to 48 hours. What is the answer there? Is it gonna be fat embolism? Is it pulmonary embolism? Fat embolism or pulmonary embolism? Yeah. Orthopedic surgery does not mean that it is fat embolism because the surgery has occurred in the vicinity of the big veins. Total hip replacement will be occurring in the vicinity of the femoral vein. Knee replacement will be occurring in the vicinity of the popliteal vein. So the hammering and the chiseling and the drilling that is going on, the vibrations of the drill machine can cause clot formation in the veins, and this can result in development of pulmonary thromboembolism in a patient. I want to say that he will deliberately write orthopedic surgery. He did not say orthopedic trauma, orthopedic surgery. Then all cancers are hypercoagulable state. All cancers, whether solid organ tumors, whether it is blood cancers, all solid organ tumors, all blood cancers, or majority of, in fact, I'll rephrase my statement, majority of blood cancers and all solid organ tumors are gonna be having a hypercoagulable state. So the person underwent some surgery, a patient went some procedure, then deep vein thrombosis and pulmonary thromboembolism can occur. One of the most important hypercoagulable state is pregnancy. He might say normal delivery. He might say after cesarean section on second day, a lady is having breathing difficulty. I've already told you, if after like delivery in a woman, if there is a cough asymmetry, then what you should do is you should immediately do a Doppler so as to identify the clots and manage the patient effectively. SV is subclavian vein. SV is subclavian vein. All pregnancies are hypercoagulable state, especially where cesarean section is done. That is always the cause of concern. The next point that I will say is valid for especially those who are sitting for NEET PG. Last times INICET had mentioned long distance air travel. Long distance air, this was like a INICET question where you had to do multiple correct answers. Pregnancy was there, cancer was there, that was okay. But long distance air travel, like Bengaluru to San Francisco flight is almost Air India 18 hours. And after closure of the Pakistani airspace and now even the Iranian airspace, it goes all the way to Russia and then loops over to US. So it's almost more than 20 hours. So that long distance travel, somebody sitting on the plane for long duration, there could be a high incidence or development of DVT. And the next risk factor to be remembered is nephrotic. I will not give any explanation for nephrotic at the moment. I will do it at the appropriate time when I discuss nephrotic syndrome before you. But at this moment, for especially NEET PG aspirants and INICET aspirants, I've added 3 more risk factors that were asked in last time's my INICET exam: long distance air travel, nephrotic syndrome, and OCPs of the older generation. OCPs of the older generation would mean estrogen concentration more than 30 mics. All of these conditions cause all the conditions in point number 3 result in development of a person developing deep vein thrombosis. All of these conditions which are given here will cause DVT, and since DVT will occur, the manifestations would be in the form of PTE, that is pulmonary thromboembolism in a patient. So I just wanted to bring to your attention a couple of these. Pranav, if I go into that changes the entire speed of the discussion. So sudden onset respiratory distress questions are the ones which I have currently covered before you. Again, super important data, neglected part in respiratory system. See, initial part of respiratory system that I discussed now, those diseases are read by you in other subtopics also. Like you keep on reading about asthma, COPD in patho also, pharma also, तो वहाँ से भी question solve हो जाते हैं. But then the point is what I'm discussing at this moment, especially post lunch session, the discussion that were taken, that is pure hardcore pulmonology, the lung involvement that I'm talking about. And there would be questions on sudden onset distress with respect to the following situations that I've currently explained to you. VAE stands for venous air embolism, air being sucked, for which a catheter aspiration would be required in the patient. SV means subclavian vein, PT means pulmonary thromboembolism. That is just to get used to the short terms that would be written in certain questions. To finish this, lastly, I would also mention the term respiratory failure. Respiratory failure would be total of 4 types, so I will just touch them one by one. Respiratory failure, one that I would like you to remember is type 1 failure. Meaning of the word type 1 failure is obviously there is a deficiency of oxygen, hypoxia, but the PCO2 of the patient can be normal also, or they can be like hyperventilation causing a CO2 washout. So if they give you a question in which oxygen is less and PCO2 is normal to low, answer it as type 1 failure. Leave some space below type 1 failure and now note down the word type 2. Type 2 will obviously be having hypoxia, but the main fundamental thing is here the PCO2 of the patient will be super elevated. PCO2 of the patient will be elevated. That's the main fundamental difference I want you to remember. If in any question PCO2 is elevated, by default the condition is respiratory acidosis. So all the conditions of respiratory acidosis that I said yesterday and I'll be saying today are going to be responsible for type 2 respiratory failure in a patient. Let's work out the causes one by one. First, I will focus on causes for type 1 failure. The best example of type 1 failure is person having fast breathing due to ARDS. That is non-cardiogenic pulmonary edema. Either the two terms can be written. Fast breathing will contribute to CO2 to become lesser. It hyperventilation होगा तो CO2 निकल जाएगा body से. So all routine lung diseases. Like if I say ARDS, I say pneumonia. Pneumonia is the cause of ARDS. Fat embolism syndrome, pleural effusion, pneumothorax. Routine situations that I'm describing. All of the routine situations that I'm describing would result in development of type 1 respiratory failure in a patient, including high altitude pulmonary edema, which may also be called as acute mountain sickness, because if somebody will be going up high in the mountain, then oxygen saturation will decrease and CO2 will also decrease because of the fast breathing efforts in a patient. The message is routine lung diseases always cause type 1 failure. The question will be all except they will mix up the causes of type 1 and type 2. For type 2, I don't want you to ever forget what I say next. Though I have mentioned that in its and bits at different points of time, but these are words which are never to be forgotten. Acute exacerbation of COPD causes carbon dioxide retention. It causes respiratory acidosis in the ABG that I explained to you, and therefore the person will be requiring non-invasive ventilation to remove this carbon dioxide. In patients having severe acute asthma, the person can deteriorate so bad that they might require ventilator support. Like somebody asked me, sir, will you not intubate in asthma? I said, no, I will not intubate because I will manage the patient on basis of aggressive drug treatment. But suppose patient came very late and the attack is so bad that now there is silent chest. This silent chest is now referred as, is formerly referred as status asthmaticus. Status asthmaticus is a very classical term. The current terminology that is given in books for it is called as imminent respiratory. The current term for it is called as imminent respiratory failure. If you go into English only, imminent respiratory failure means diaphragm is tired. There will be no rhonchi in the chest. It would be silent chest. The oxygen saturation will begin to drop to such a level that cyanosis will occur in a patient. Never in asthma I said patient is blue. I'm saying patient is turning blue. He starts developing pulsus paradoxus. Pulsus paradoxus is a very useless term. It's a misnomer, as I've explained to you. Pulsus paradoxus will deliberately be given in MCQ status asthmaticus. That is just to make you think as if he's talking some cardiac case. No, silent just likha hai na. That means it is a respi case. It's just a distraction pulsus paradoxus. Status asthmaticus is like total collapse of total obstruction in the airways by secretions, because asthma has a lot of mucus production also. There is like mucus plugs also present. They're occluding the airway. So no air is going in. Carbon dioxide is not coming out. That's why CO2 levels will begin to rise. So the word is status asthmaticus. Current new term is imminent respiratory failure. But most MCQs might still be using terms like silent chest, cyanosis, pulsus paradoxus. You read these terms, you know it's a CO2 buildup in the body. CO2 buildup in the body. The third scenario where carbon dioxide buildup will occur is tension pneumothorax. If I remove the word tension and just say pneumothorax, you can answer it as type 1 failure. If the question simply says traumatic pneumothorax, secondary pneumothorax, spontaneous pneumothorax, if pneumothorax word is given with any kind of prefix, you can answer it as type 1 failure. But if the question specifically mentions the word tension pneumothorax, because here one lung is gone, God has given us two lungs. If one lung is gone, then CO2 is bound to build up in the patient. These are 4 respiratory conditions that I'm mentioning before you, which will contribute to type 2 respiratory failure in a patient. Acute exacerbation of COPD, status asthmaticus, tension pneumothorax, foreign body glottis, or the 5th one, especially for NEET PG aspirants, we call it obesity hypoventilation syndrome. Obesity hypoventilation syndrome implies that there is so much of fat on the chest. Utna fat ho gaya that fat is limiting chest movement. There's so much of fat on the chest that chest movement is not getting, chest wall is not able to move. Point number 5 can be skipped by you if you're sitting for FFG exam. Obesity hypoventilation syndrome. The older name for this is what is called as Pickwinian syndrome. The older name for this is Pickwinian syndrome. Don't mix it with obstructive sleep apnea. Don't mix it with obstructive sleep apnea. I'm not saying obstructive sleep apnea. I said obesity hypoventilation. This is due to lot of fat in the chest. It is squeezing the chest of the patient. Obesity hypoventilation MCQ will always be mentioning a ABG report, and that ABG report will always be saying that these obese persons, ABG report will be revealing respiratory acidosis which will be partially compensated. Obstructive sleep apnea MCQ will never give you ABG report. That is the hack for all the NEET PG guys. If in any question obese man is shown to be having carbon dioxide buildup and the question is mentioning ABG report, please don't answer it as obstructive sleep apnea. Obstructive sleep apnea, I agree, there's a lot of snoring and there's an airway collapse in a patient, but the question will never mention the word ABG was done. Here this guy keeps on sleeping all day. We did ABG, the ABG report showed very high CO2 even at daytime in the patient and at night time also. If ABG report is given in a patient with snoring and obesity, if ABG report is given in a question of obesity and snoring, then answer obesity hypoventilation syndrome. If I remove the ABG, I say obese man is having loud snoring and is having apneic episodes. Obviously obstructive sleep apnea super easy. OSA के diagnosis में ABG use नहीं करते. If ABG is being used, then it is a totally separate disorder that is called as Pickwinian syndrome. These are a couple of respiratory conditions which are given in the question. And now part number 6 that I say is for everybody, that is वो जानबूझ के लिख देगा diaphragmatic paralysis. वो diaphragmatic paralysis कैसे लिखेगा? वो लिखेगा Guillain-Barré syndrome. He will write the word Guillain-Barré syndrome. He will write electrolyte imbalance like hypokalemia. He may write condition like amyotrophic lateral sclerosis. The point I just want to bring to your attention is that in all of these conditions, the common thing is diaphragm paralysis. I can write one more, cervical spine injury. If I say cervical spine injury, like this guy is driving a bike, he had an accident, and there is a C spine injury at the level of C3, C4, C5, then diaphragm will not work. Na? Suppose it's a Formula 1 race, the car goes off the track. Now, obviously, the sand on the side of the track is designed to stop the car, but when the car will come to a dead stop, it's going to result in a decelerative force on the neck of the driver, and the decelerative force on the neck of the driver will result in development of this kind of unfortunate scenario. I mean, like most of the time, it's going to be sports related injury. The guy who used to play Superman, Christopher Reeves, he fell from a horse, so he broke his neck. He's a wheelchair bound patient even today, never will be able to walk. And by the grace of God, his injury was C7, so he does not require a ventilator support. But if somebody can end up with an injury on the neck, which is special common in actors who do their own stunts, etc., then we'll definitely have issues there. Fox is for that central hypoventilation syndrome, na Ondine's curse jo hota. Fox2 gene is for Ondine curse. That Ondine curse is ki usko, when we were kids, I'm not sure whether that story you have heard. I'll just say that story quickly. There was this saint who was praying to Lord Shiva, and he was disturbed by like some Raja or some king. So he gave a curse to this Raja that tu soega to teri mrityu ho jayegi. The guy started pleading, please, please, sir, don't punish me, don't punish me. So this learned man, this sage, he gave a curse to the Raja that if you will sleep, you will die. And like this guy did not sleep for very long duration. Finally, when he slept, he died. So this was what is called as Ondine curse, and this is present in multiple cultures. Even in that Abrahamic cultures, you will notice that some kind of this kind of a curse is given, and the curse results in death of a princess. So like lots of time in that Jews literature, you will come across this kind of data also. So Ondine curse is central hypoventilation syndrome, as you commented in the chat box. But our cases are very clinical. They'll straight away told you old man, he will tell you obese man, loud snoring, apnea, and then ABG report will show metabolic respiratory acidosis. So answer it is not OSA, answer is OHS, as I explained to you. So these are causes of type 2 respiratory failure. And since you guys have been quiet for a while, so please now let me know. No, Michael Schumacher to had a head injury, no? Michael, right? Okay, so coming back. Tell me what is type 3 respiratory failure? Quickly, guys, we're just winding off and moving on to the next topic. We'll take a tea break and then go for the next one. What is type 3 respiratory failure? Type 3 respiratory failure is post-operative atelectasis. It is unlikely to ask a MCQ on type 3 respiratory failure because it is very easy to understand that if a person will keep on lying in bed after surgery, there will be a post-operative atelectasis of the basal lung segments, and this can easily be prevented as well as managed by incentive spirometry. You would have seen the device which will have 3 color balls. At COVID time, maybe if somebody in your family had COVID, you might have prescribed them that, that device by which they will exercise their chest muscles. That is called as incentive spirometry. That device will be having 3 balls. That is red, orange, and green. And when you put effort, that means like, you are able to breathe, you are able to generate sufficient amount of inspiratory force. Acute asthma is type 1. Acute asthma is type 1. Asthma is always type 1, except for status asthmaticus. Asthma of any variety is acute asthma, severe acute asthma, both are type 1. Acute asthma, severe acute asthma, both are type 1, fast breathing. But if it is impending respiratory failure, that is status asthmaticus, then it is type 2 failure. Yeah, it would be red and yellow and red ball, then there would be yellow ball, and then would be the green ball present. Just out of curiosity, if red ball alone is going up, then how much is the एयर गोइंग आउट ऑफ द लंग, इंस्पिरेटरी ना, इंस्पिरेटरी एफर्ट आप कर रहे हो ना, ऐसे इंस्पायर करना होता है, तो व्हाट इज द वॉल्यूम ऑफ एयर? It's red, orange, and green. So when you inspire, your chest muscles are getting exercise, no? Your diaphragm, we're basically trying to exercise the diaphragm of the patient. We're trying to exercise the diaphragm of the patient. So if only one ball is going up, what is the inspiratory effort? How much ml of air? 600. If two balls are going up, 900. If three balls are going up, that's gonna be something like 1.2 liters. That's the amount of air that the patient is trying to breathe in. Right? You can understand now, if inspiratory effort is only 600 ml, that's even close to the tidal volume only. Even when you and me breathe with force, we can put more air, na? After surgery, the person will be able to push up only one ball up. If only red ball is going up, that means this is a subjective assessment. This is for you as a doctor, not for patient. If suppose you ask the patient to breathe in like this, अंदर को सांस लेने के लिए, and only one ball is going up, that means respiratory effort is only 600 ml. If two balls are going up, 900 ml. If three are going up, it is hitting about 1.2 liter, which is considered to be healthy. So in majority of our patients, no, this is the aspect which is to be remembered. It is a type 3 respiratory failure is post-operative atelectasis, guys. That is what I want you guys to understand, right? So type 3 respiratory failure or type 4 respiratory failure में क्या होता है? Those are the differences that I basically want to remember. Give you. Then is type 4 respiratory failure. Type 4 respiratory failure is again something which is less likely to be asked because it is pretty straightforward. One liner only. It will be under perfusion of the respiratory muscles. It is not failure of the muscles. It is not failure of the muscles. It is hypoperfusion of the respiratory muscles. Question ध्यान से करके आना, वहां पे जल्दबाजी मत करना. अगर वो बोलता है failure of the respiratory muscles, then it is diaphragmatic paralysis ना. If I say failure of respiratory muscle, diaphragmatic paralysis, then it is gonna be point number 6, that is type 2 failure. Under supply of the muscles, भाई अगर खाने को नहीं मिलेगा तो मसल्स कहां से काम करेंगे? सो हाइपोपरफ्यूजन ऑफ द रेस्पिरेटरी मसल्स. Hypoperfusion respiratory muscles due to circulatory failure like shock is an example of type 4 respiratory failure. Here you obviously need to treat shock and you need to put the person on ventilator also, because obviously like without treating the shock and giving ventilatory support, the muscles are tired, they're not able to perform. So if he says kya karenge, तो we might have to ventilate the patient. So what I've tried to explain to you is the total 4 types of respiratory failure, out of which in my opinion most of the time the question will be asked on type 2 respiratory failure, and these are the examples that I've highlighted before you, including a very intelligent query came ki sir, asthma both varieties acute and severe acute, what will you answer? It is type 1 only. But when severe asthma deteriorates into status, that is where you will say that, oh man, this is gonna be now type 2 respiratory failure in a patient. So these are a couple of aspects of pulmonology that I wanted to explain to you. And what we will do next is talk about this will give us some breathing space also. So let's do some one-liners, guys, and after that we'll go for a tea break. So let's do like few one-liners there. I have them scattered over 1.5 page, and then we can like go for a tea. Okay, what is the leading cause? And I want fast answers here. I would like you to practice your typing speed in here. What is the number one cause of chronic kidney disease in a patient? Then the leading cause of chronic kidney disease in a patient is diabetic nephropathy. If you go to any dialysis unit anywhere in India, almost like 80% cases will be type 2 diabetes and they've had damages to their kidney and they don't have anybody for transplantation. Chat did not come. Okay, just check. Overall, the number one cause for, don't answer analgesic nephropathy, polycystic kidney disease. यार वो पैथो से नाम याद कर लेना ना, ILD के जो वैरायटीज होते हैं. चलो मैं बता दूंगा, ठीक है. I'll tell you the varieties also. Yeah. Leading causes diabetic nephropathy. Now tell me those kidney diseases where there's a normal size kidney or a slight enlargement is seen. So diabetes mellitus में the size of the kidney will be normal. In diabetes mellitus, the kidneys will not be shrunken. The size of the kidneys will be normal. One more cause to be remembered is amyloidosis, which is again a disease of the kidney, and there would be normal to enlarged kidneys present. Diabetes mellitus and amyloidosis are two standard conditions where, in spite of the fact that they cause chronic kidney disease, the kidney is not shrunken in size. It is a normal, बेटा normal to normal size kidney बोला ना, autosomal dominant यहाँ पे नहीं आएगा ना कि उसमें तो huge kidneys होती, यहाँ पे autosomal dominant नहीं आएगा क्योंकि मेरा क्वेश्चन था CKD with normal size kidney. The बेटा आंसर के नॉट बी पॉलिसिस्टिक किडनी ना, बिकॉज उसमें स्लाइट एनलार्जमेंट तो होता नहीं है उसमें तो, लाइक इट इज लाइक it is like huge renomegaly that is present in a patient. Yeah, amyloidosis causes restrictive cardiomyopathy also. My question was, which CKD cause will be having normal size kidney? Then it is diabetes mellitus and amyloidosis. Then polycystic kidney will usually not be the answer in this particular case. The reason is it will have like huge enlarged kidneys and they'll occupy whole of the peritoneal cavity. I mean, so huge kidneys that they occupy huge of the peritoneal cavity, then I can't call them normal or slightly increased. Putty kidneys, tuberculosis, man, that would be shrunken. That's not normal size kidney. Putty kidney is tuberculosis. No? TB will cause the kidneys to become shrunken in size. No, that will be an image that will be given. The kidney parenchyma will be totally white. Okay, tell me the leading cause of death in chronic kidney disease. Tell me the leading cause of death in chronic kidney disease. So two common examples of normal size are diabetes and amyloidosis. All others could be having variation. Yes. The leading cause of death in CKD is myocardial infarction. I can give example of Sushma Swaraj ma'am. She was a Minister of External Affairs in BJP one government. And ma'am, being a diabetic, she neglected her health. She went into diabetic nephropathy and end-stage renal disease. Then she was operated at AIMS hospital for kidney transplantation. And after the transplantation, ma'am rejoined parliament also. But after one of the parliament sessions, she told her secretary, adjutant, I'm not feeling well, I'm having a lot of sweating. Can you get me some juice, etc.? Maybe my sugar is falling. So the adjutant or the secretary went to get something for her. When he came back, she was dead. I gave you this example just to explain to you of Sushma Swaraj ma'am that being a cabinet rank minister, they have all the facilities. There are doctors posted, there is nursing staff posted, there are technicians posted, ambulance there. And in spite of that, like, you can understand that she could not be saved. So if a cabinet rank minister is having issues, then ordinary people will definitely die. So leading cause of death in CKD is cardiovascular disease, that is post MI. One of the most important risk factors for control of CKD is hypertension. So what should be the target blood pressure? Because you have a high renin hypertension in a patient. So the target BP in this patient should be kept at less than 130/80. That's a universal data anyway for all hypertensives. But you will notice that CKD patients will be the most difficult ones to manage. What is the most life-threatening complication of CKD? Because anytime kidney will fail, there is going to be electrolyte imbalance. What is the most life-threatening? And it will cause a cardiac arrest. It will cause a cardiac arrest. It will cause a diastolic cardiac arrest because it will stop the heart. Yes, guys. Yeah. Hyperkalemia. The most life-threatening complication of chronic kidney disease is hyperkalemia, because if the kidney will stop working, then potassium will not be excreted and it will stop the heart of the patient. Staging of CKD is based on this. I will be teaching you subsequently on the basis of estimated GFR. Sometimes in MCQ, he may not write the word estimated GFR. He may write in place of this creatinine clearance. And second, we will check for albumin excretion rate, that is albumin creatinine ratio. He will write it as ACR in the short. This will be explained to you subsequently. I will be giving explanation for this table. You can see this color table on the top. So I will be giving explanation when we meet for the next time with respect to this table. But at the moment, I wanted to remember two things for this table. That one parameter on the table is estimated glomerular filtration rate, alternative name creatinine clearance. The second thing that will be present in this table is albumin creatinine ratio. The alternative name for this is albumin excretion rate. All of you have given a correct answer, but what I've tried to do is just tell you surrogate terminologies, both mean the same. चाहे वो eGFR लिखे, creatinine clearance लिखे, albumin creatinine ratio लिखे, albumin excretion rate लिखे, या बेटा जैसे आपने लिखा GFR proteinuria means the same. But actually usually proteinuria नहीं लिखता है, ऐसे लिखता है. जो मैंने words लिखे ना, उनको थोड़ा practice कर लेना. ACR and AER is to be remembered. Then is stage at which complications appear. Stage at which complications appear is grade 3 of CKD. I will be teaching you 5 grades of CKD at which complications start appearing is usually grade 3, and uremia features usually develop in grade 4, grade 5. Uremic features develop in grade 5. The older term for this was end stage renal disease. Grade 5 is also called as end stage renal disease, but when you will write the word end stage renal disease on the case file, when you will write the word end stage renal disease on the case file, the patient's relatives feel very bad. The doctor, you are so heartless, you wrote the word end stage. My father was crying the whole night. My mother was crying the whole night. Doctor, you are so heartless. Why did you write this word on the file? The patient started a social media campaign against doctors that these people are so heartless and they keep on writing these words. My father was crying the whole night. So now Harrison 22nd edition that has come. He has written categorically that doctors should not write the word end stage renal disease. Now you should write the word renal failure. Strange word, right? End stage renal disease word is नहीं बोलना है. अब क्या बोलना है? Renal failure. So what is renal failure? It is grade 5. At this point of time, the estimated glomerular filtration rate will be less than 15 ml per minute. Normal glomerular filtration rate is 125 ml. If it becomes less than 15 ml per minute, that is almost around 10% of what is normal, then we will use the word renal failure. It is like renal failure. Like that's why, now MCQs will use the word renal failure. Renal failure. The new edition of Harrison was delayed, na? The red wala edition. Do you know why the new edition of Harrison was delayed? I'll tell you a quick story in 1 minute. The new edition of Harrison was delayed, the red one, because the chief author of Harrison is Dr. Fossey. You can Google his name right now. Dr. Fossey was the main guy who was running the lab in China, which was behind that COVID virus outbreak. The lab did not take precautions, and because of that, like the entire world suffered, and especially at that point of time, Trump's business interests were also hampered. So when Trump had campaigned for the last election, he had said that on the first day of my presidency, I will be giving punishment to Dr. Fossey. He will be sent to prison for rest of his life. Would you believe it? That Dr. Fossey, the authors of Harrison, would have gone to jail on the last day of presidency of President Joe Biden. Joe Biden on the last day of his presidency. Yes, Dr. Fossey I'm talking about. Dr. Fossey, he was given presidential pardon by Joe Biden. That is why he was able to write the 22nd edition of Harrison for us. Otherwise, Trump would have sent him to jail for like felony, right? Felony is like you did not take adequate care and the virus spread and the business interests were hampered. You read about it, it's shocking, man, the kind of venom that these guys can be having against doctors. Joe Biden gave a presidential pardon on the last day. Dr. Fossey was all sweating. He was planning to run away from America to Russia. He was planning to deflect. Just at the last moment, they gave a presidential pardon. Otherwise, the guy would have gone away. But I mean, the hats off to that guy, man. That guy writes Harrison every 2 years, right? 4,000 page book लिखना. It's not easy, man. Latest report के ऊपर में. It's not an easy job. चलो जी. One more atrocity I told you. Troponin I is elevated in CKD. Get the focus back. Troponin I is elevated in chronic kidney disease. Troponin I is elevated because it is excreted by the kidney, guys. So if a CKD patient will come to you with chest pain, Trop I can be elevated even without myocardial infarction. It could be chest pain due to maybe GERD in a patient. Don't rely on troponin I. Rely on ECG and serial troponin I. What I mean by the word serial troponin I is that you should do it more than once. If it's rising trend and ECG showing changes, it is diagnosis of myocardial infarction. This is again an important question. Troponin I is elevated in CKD. Why? Because it is not getting excreted from the kidney. So don't rely on single value. Rely on serial troponin I. Serial would mean that you have to do it more than once. As far as the grades of CKD, I'll be writing them down separately. I'll talk about this table that I said G1, G2, G5, A1, A2, A3. I will explain all of them to you at the moment. Yeah, what I want to say to you at this moment is at least the following statements. What is mild CKD, moderate CKD, severe CKD, and renal failure? Renal failure I've already told you. Now you need to remember values. And if you're wondering like, are these values important? Yeah, they are important. In NEET PG, they ask G3A. That will come up at the bottom of the slide. So yeah, I will be giving you break, man. I will be giving you break. This the values का sequence समझ लो सिर्फ, right? Values का sequence समझ. Otherwise, you will lose the continuity, man. Believe me, right? I've been doing this for a very long time. Give me like 2 minutes of your life. जिंदगी के 2 मिनट मुझे दो. And I know you are tired. I will give you a break. 2 minutes, guys. 2 minutes. It is the mathematical values which are to be remembered. You have to do this activity with me. मैं 2 मिनट से ज़्यादा नहीं लूँगा. Right? 2 minutes start now. G1. If you think you're gonna do this by yourself, it's not possible. So just listen to my words. G1 is when the GFR is more than 90 ml per minute, 1.73 meter square of body surface area. The point to be understood is that we agree the GFR will fall, but they've done a categorization. Now I want you to decrease by 30 points. So यहाँ पे लिखो 90 minus 30 is 60. Write down 30, 90 minus 30 is 60, and you will write the value that is gonna be 60 to 89 ml per minute, 1.73 meter square of body surface area in a patient. The GFR of the patient is progressively falling. I told you like end stage renal failure is 15, but we're looking at how will we reach that till that 15. So 90 में से 30 subtract किया 60 हो गया. Now you need to subtract only 15, 15. So you will write the value here. This is 45 to 59 ml per minute. This is what came in NEET PG. 49 to 59 ml per minute. And most guys were not able to do this because they were not oriented. They have read this. कह रहे सर हमने पढ़ा है लेकिन वहां पे दिमाग काम नहीं किया कि it is here, it is 30 points, here it is 15 point reduction. It is just that I lost track of it and I was not able to solve the question. I have written the data in front of you. Now you have to decrease again by 15 points. You have to again decrease by 15 points. This would be 30 to 40, 44 ml per minute. G3A and G3B, you have to use this as a benchmark. 45 to 59 ml per minute, 1.73. You have decreased by 30, 15, 15. I'll take another 15 seconds now. आपने सिर्फ ये एक्टिविटी करनी है और इसको कर लेना गाइस, कर लेना. आपको लग रहा होगा भी कि यार इट्स टू मच, बट when this will win a MCQ for you, you're gonna thank me later. If you look at this table, it looks like कि हाँ ठीक है यार हो जाएगा याद, but people are not able to do it. This is the subtraction. This is the only point. 15 15 अब सिर्फ 15 आप मेंटली करना है इसको. It is 15 15 का डिफरेंस. अगर ये लिख के नहीं करते तो याद नहीं होता. It is 90 60. फिर मेंटली विजुअलाइज करो 45, फिर 30, फिर 15 और फिर उसके बाद में 5. G4 is the time when you will be telling the patient that you need to go for renal replacement therapy. G5 तो end stage renal disease होता है, तो G4 पे we will tell the patient that you need to go for renal replacement therapy, that is kidney transplantation. पहले ट्रांसप्लांटेशन कैसी होगी, तो मैंने बोला कि भाई आपका ब्रदर या सिस्टर, रियल ब्रदर सिस्टर किडनी डोनेट करेगा या कजन ब्रदर करेंगे. तो उसने कॉल किया अपने ब्रदर सिस्टर को, तो कहता है कि सर आफ्टर योर डिस्कशन आई स्पोक टू माई ब्रदर सिस्टर और कजन्स, तो उन्होंने मेरा फोन ही ब्लॉक कर दिया, बात ही नहीं करते. रियल ब्रदर सिस्टर स्टॉप टॉकिंग व्हेन दे आस्क फॉर ऑर्गन. एंड वन गाय टोल्ड मी कि सर दे हैव रीलेबल्ड माय नेम ऑन द ट्रू कॉलर एज स्कैमर. When I call somebody now on the true caller it looks like scammer. नीचे लिखा है कमेंट्स में किडनी मांगता है. That's why dialysis is done nowadays. Now people, so rich people will come to you and they'll cry, sir my brother doesn't talk to me, my sister doesn't talk to me, mummy papa are agreeing. He is 85 years of age, papa is 85, mummy is 80 years of age, they are already having heart disease. Mummy is ready. Mummy will always say yes. Mama will say yes. Papa will say yes. They are so old and they are having heart disease. वो कहाँ से देंगे? And real brother and sister कहेगा स्कैमर बुलाते हैं सर मेरे को, कहता है स्कैमर साला किडनी मांगता है. ऐसे वर्ड आपको कस वर्ड बोलेंगे साथ में और बोलेंगे सर मुझे ऐसे ऐसे बोला, एंड they'll cry in front of you. You feel bad. So we do dialysis of these patients. But yeah guys, I want you to, I'll talk about that kidney scam also that happened in Delhi subsequently. But yeah, I just wanted to take your time to explain this fact to you because otherwise I would not been able to say about the values at the moment. Okay guys, so we go for a break here. We go for a break here. Yeah. I think we started 5:30, guys, right? It's almost like gonna be 5:10. So we start at 5:30. Is it okay, or you want a longer break? I can do that. Yeah. Okay, so we do it till 5:40. Done. Fine. I'll write the time here. The time is 5:40 is when we are restarting again. 5:40. Hey guys, please join back. Okay, fine guys, I think we're good to go. So what I was discussing prior to break was the aspect of CKD, that is chronic kidney disease, where we speak about estimated glomerular filtration rate. Now I will be putting up a question to everybody. The question says, which of the following is best to differentiate between acute kidney injury and chronic kidney disease? You can do a quick voting in the chat box with respect to what is best to differentiate acute kidney injury and chronic kidney disease. I'll start at ruling options also, because blood urine nitrogen and serum creatinine will be elevated in all the cases, whether acute kidney injury or chronic kidney disease, both would be affected. I could pick up a D there, urine output and serum creatinine in a patient. So, like, best to differentiate, you see, one thing is very clear: size of the kidney is never a differentiator. Size of the kidney is never a differentiator. Either it is gonna be urine output and serum creatinine, or it's gonna be like serum creatinine clearance and urinary albumin. My point is that urine output तो दोनों में कम होता है ना, चाहे acute kidney injury हो जाए, चाहे chronic kidney disease हो जाए. I mean, urine output की अगर आप बात करते हो तो urine output can be less in acute also and chronic also. So we cannot differentiate ना कि भाई ऐसा तो है नहीं कि urine output is more in acute or is less in chronic, और उल्टा भी नहीं होता कि suppose ऐसे urine output is less in acute and is more in chronic. It's not like that ना. Kidney, if it will fail, guys, answer is not D. Urine output will be less in acute kidney injury also and chronic kidney disease also. The answer to this question is option number A. Creatinine clearance and urinary albumin can be used for differentiation because they are findings which are specific to chronic kidney disease. These are findings specifically to chronic kidney disease in a patient. The answer to this question is option number A. Obviously not serum albumin, I'm saying. Serum albumin is something that is the liver function test. If I say serum albumin, then serum albumin is obviously a liver function test because albumin is produced by the liver. Answer to this question is option number A. Yes, it is a urinary albumin creatinine ratio. And I wanted to bring to your attention these mathematical values which I mentioned: G1, G2, G3. This is not Gravida 1, Gravida 2, Gravida 3. This is grade 1, grade 2 and grade 3 of CKD. And what they asked in last time NEET PG was G3A, so that mathematical value had to be remembered. And I've already explained to you that if a person is in G4, for all patients of G4, the management is in the form of renal replacement therapy. In renal replacement therapy, there will be two options. One option is we can go for an allogenic kidney transplantation. Allogenic would mean that it will be a first degree relative, that a cousin, brother, sister, real brother, real sister will donate the kidney. But as I told you about, like most of the time, like people will not be having either money or they will not be having a kidney because obviously nobody would like to part with them. So what you would do in this particular patient is, what I would like to part with or explain here is that the other option that I am having is hemodialysis. The point is कि अगर मैं hemodialysis करता हूँ तो उसके साथ में अपने खुद के side effects होते हैं. So I will be explaining to you the side effects of hemodialysis also. We'll talk about like what are the issues related to transplantation. But on a comparison basis, if I say which is recommended, if I say on a comparison basis what is recommended, then it is allogenic kidney transplantation recommended over hemodialysis because of more complications with hemodialysis. Hemodialysis needs to be done at least 3 times per week. One session of hemodialysis will be approximately for 4 hours. So patient will have to spend about 12 hours per week just coming to the hospital and getting the blood cleaned off. Normal person will not even like, think about going to the washroom and excreting the nitrogenous gases. Here the person will have to come to the hospital to excrete nitrogenous gases. So that's gonna be like a very I would say, emotionally taxing process of coming to the hospital again and again. Now, once we get the grades of CKD right, we'll now focus on the treatment part. And in the treatment part, 15 years. 15 years is the lifespan of transplanted kidney. Okay, diya hua, I think. Lifespan is transplanted. I have mentioned it. Lifespan. This is one question that I have highlighted. Life expectancy is 15 years. So that's already, donor will be able to live like without any problem. It is the receiver whose lifespan will be increased. Na? Life expectancy enhanced by how many years? It is 15 years. Okay. Coming back to the agenda, the question I was discussing was what is the management of CKD from the perspective of medicines? Obviously, we have to do dialysis or we have to do transplantation. But then here at this moment, it is the medical management which will be focused. So in alphabet A, I want to highlight that because majority of patients are diabetic, you need to keep HbA1c less than 7%. The cutoff for diabetes mellitus is 6.5. Poor control is defined as more than 7. So I need to keep HbA1c less than 7%. To achieve that, what I will do is, one, I will see that can metformin be given to the patient. Most of the time, metformin needs to be stopped if the estimated GFR of the patient is less than 30, as has been discussed multiple times. If metformin will be stopped, then what will you start? You will start insulin. And insulin is also like insulin is also excreted by the kidney. So if they ask you that what should be the dose adjustment, then you will do 80% of the calculated dose. The point to be understood is that suppose like the requirement is 40 units based on body weight. So I will not give 440 units before full 440 units because if I give 40, then it will not be metabolized by the kidney. It will cause hypoglycemia. So we have to give 80% of the calculated dose. In the exam, he said, what will you do? Options were regular insulin dosage. I mean, whatever is the recommended dosage on basis of body weight, increase the dose or decrease the dose. Your answer is decrease the dose. That would be 80% of the calculated dose. And then the drug that we'll be using in this patient is SGLT2 inhibitor, that is renoprotective. And then SGLT2 inhibitors are not effective at GFR less than 20. So specifically, if the eGFR of the patient is less than 20, then what we need to start in the patient is DPP4 inhibitor like sitagliptin in the patient. So I think I've already explained that to you. You can go back to the diabetes video for that. SGLT2 inhibitors are renoprotective. We spoke on detail regarding that. Okay. Yeah, eGFR less than 20 is DPP4 inhibitors. Then is the B component where we need to keep the blood pressure of the patient under control. So A is HbA1c, B is the blood pressure value. Keep the blood pressure value to less than 130 by 80. Now, when I'm saying keep the blood pressure to less than 130 by 80, the main drug that we'll be using in this patient is ACE inhibitors. So one of the biggest side effects of ACE inhibitors is hyperkalemia. So my question to you guys is that it is a patient of end stage renal disease, which is now called as renal failure, and his blood pressure is 140 by 90 in spite of ACE inhibitors, and his potassium is 6.5, or let me say a value a little higher, 6.8. So if a patient of chronic kidney disease or end stage renal disease or renal failure is having high blood pressure, potassium is 6.8, then I will not be given comfortable giving ACE inhibitors to the patient. So if it is ACE inhibitor which is not because ACE inhibitors, they cause also hyperkalemia. ACE inhibitors also cause hyperkalemia. So what is the medicine that you would like to give to this patient to control the blood pressure? The question, I'll be waiting for your answers in the chat. End stage renal disease patient, potassium is elevated. No, we will not be giving thiazides to the patient. Thiazides are not given. What we will give to the patient is calcium channel blocker, CCBs should be given to all of these patients. So traditionally, the drug of choice is ACE inhibitor. But if ACE inhibitor will not work, then we can add calcium channel blocker in the patient. CCB would be like amlodipine that would be given in a patient. And if the blood pressure is still not controlled, then we can give to the patient alpha blockers also. The alpha blocker that we can use in the patient is like prazosin. But the first answer that we'll be giving in this particular patient is calcium channel blockers in this patient. It is CCB that would be given so that we are able to manage these patients better. The thiazides have already explained the increased blood sugar, the increased lipids. So we don't use thiazides anymore. It is calcium channel blockers, so prazosin can be used in the patient. C would stand for keep cholesterol under control, because see, most patients will be having increased cardiovascular mortality. So keep cholesterol, that is LDL cholesterol, under check. So the question to you guys is, what is the target LDL that should be obtained in routine diabetic patients? I mean, traditionally, what is the target LDL that needs to be obtained? The second aspect is I am saying that I mean I need to keep target LDL below a certain level. So the question is, this is a diabetic, and he is already having diabetic is having coronary artery disease. So since he has already had an MI, atherosclerotic cardiovascular disease, what is the target LDL that you want to obtain in the patient? These are high risk patients, so the target LDL for these patients should be obtained as less than 70. The target LDL in these patients should be less than 70, and the medicine that I'll be giving in this patient will be atorvastatin. Atorvastatin or HMG coenzyme A reductase inhibitor is the word that will be written in the question. In case atorvastatin alone is not successful, and this is again a previous question, that if previous year question, NEET PG aspirants, please give me this answer here, that if atorvastatin alone is not able to bring down the target LDL, because if I will increase the dose of atorvastatin, myopathy will occur, muscle pain will occur. So what additional medicine can be added here? Can I have the name of medicine, please? Atorvastatin alone, if you keep on increasing the dose, you get myopathy. Statin induced myopathy, CPK-MM levels will elevated. So what is the medicine that will be added here? Your answer will be that I will give a medicine that will inhibit the absorption of cholesterol from the intestine. So the medicine that we'll be using in the patient is ezetimibe. What you will do in the patient is, in case you notice that atorvastatin is not able to reduce the value of the bad cholesterol, then additional medicine that will be added here is ezetimibe. And we need to keep A, B, C under check. A stands for HbA1c, B is the blood pressure, and C is the cholesterol. Now we will talk about the D component, because ultimately vitamin D in the body of these patients will also be less, because kidney produces vitamin D. The kidney has an enzyme by the name of 1-alpha hydroxylase, and it is responsible for synthesis of vitamin D. So yeah, we will not use fibrates. Fibrate दोनों एक साथ नहीं देते ना, उससे myopathy बढ़ जाती. Fibrates are only given when the value is more than 500. Otherwise, we don't give fibrates at all. We don't give fibrates in combination. Otherwise, that will worsen the myopathy in the patient. Now, vitamin D in the body is less. So, vitamin D is less. That means calcium will also be less. Calcium and phosphate have an inverse relation. So, serum alkaline phosphatase will also be more. And because the PTH in the body will be high, you know why this is happening is because of secondary hyperparathyroidism. So, it will weaken the bones also. Osteitis cystica fibrosa will occur in a patient. So here he will ask you like, what will you do to control the phosphate of the patient? And then he will ask you, what will you do to control the elevated PTH of the patient? I would expect you guys to quickly comment in the chat box, what is the preferred drug that you would like to give for control of hyperphosphatemia in this patient? Yeah, brown tumor can occur. Exactly. I mean, if PTH is more, it will remove the calcium from the bones. The bones will have cysts. Osteitis cystica fibrosa I said yesterday, and then they can be bleeding, and that will cause hemosiderin deposition. So what medicine would you be liking to give it to these patients so that you can decrease the phosphate value in the patient? Phosphate value, man, listen to the question. How to decrease the phosphate in the body? Your answer is sevelamer. You will start with sevelamer first. In these patients, you will start first with sevelamer to decrease the phosphate, and then the second medicine that you will be starting will be inhibiting the PTH release. Cinacalcet क्या करती है? वो inhibition of PTH release करती है, so that you don't have weakening of the bones. And sevelamer is a phosphate binding in a patient. So if he gives you this situation and he says क्या करोगे, तो don't straight away start with calcium gluconate intravenously. Most doctors here casually start answering calcium gluconate देंगे intravenously. भाई ये chronic condition है, ये कोई ऐसा तो है नहीं कि उसको अभी टेटनी के फीचर आ रहे हैं. It is not that the guy is ending up with tetany features right now. If most people focus on calcium. Most people focus on calcium here, and they answer calcium gluconate for management. My point is, I agree that calcium is low and I need to fix it. But at this particular point of time, if calcium was less than 7, like suppose he himself says calcium is less than 7, PCSK9 inhibitors are injections. Those are once a month injections that are given to the patient if the values are not coming down. If the target LDL is not obtained in spite of giving multiple drugs, that is when we start with PCSK9 inhibitors. So now we will not be using the drug. Coming back to the agenda, the question I asked you was what medicine should be given. The answer is not PCSK9, it is ezetimibe. And for the second question I mentioned, the point is, though calcium is less, don't answer calcium gluconate. Your main answer is, I will first treat hyperphosphatemia. Because phosphate chelates with calcium and causes calcification of blood vessels in the heart, and calcification will increase the risk of MI in the patient. So in these patients, it is hyperphosphatemia which must be treated initially. And after treating hyperphosphatemia, the second thing is you want to inhibit the release of PTH, that is cinacalcet. It is a calcium calcivimetic drug. That calcium mimetic drug, what it will do is it will inhibit the release of PTH. I also had a question, what will we do? Can't we give vitamin D to the patient? Vitamin D खिलाएंगे तो कैल्शियम बढ़ेगा, वो कैल्शियम चिलेट करके स्टोन्स कर देगा. Like one question was, sir, can't we give vitamin D to the patient? तो vitamin D देते हैं इसको, विटामिन देते हैं लेकिन थेरापेटिक नहीं देते. आई डोंट नोट इट डाउन, जस्ट आई एम ट्राइंग टू एक्सप्लेन टू यू कि इसको व्हाई द आंसर इज नॉट विटामिन डी, क्योंकि अगर मैं विटामिन डी दूंगा तो कैल्शियम बढ़ जाएगा. कैल्शियम के साथ में फॉस्फेट पहले से ही बढ़ा हुआ है, तो कैल्शियम एंड फॉस्फेट पे चिलेट विद ईच अदर, दैट विल कॉज किडनी स्टोन्स इन द पेशेंट. There would be increased incidence of kidney stones in the patient. So vitamin D that will be given to this patient will be recommended daily allowance. It is not therapeutic supplementation. जो रोज खाना है bone health के लिए, that will be given to the patient. So the point is vitamin D देते हैं लेकिन it is not therapeutic. It is RDA, and if I will increase if I will directly increase vitamin D, then the biggest problem will be increased risk of kidney stones and nephrolithiasis. So first enter hyperphosphatemia and then give cinacalcet to the patient. Patiromer is a potassium binder. Patiromer is a potassium binding in the patient. Now another reason why the problem is with vitamin D. Another reason problem with vitamin D. इनमें से बहुत सारे पेशेंट क्या करते हैं, खुद ही ना विटामिन डी कैल्शियम खाना शुरू कर देते हैं. उसको उसको आपने बता दिया ना कि सर आपके रिपोर्ट में कैल्शियम की कमी है, विटामिन डी की कमी है, या वो मतलब वो किसी डॉक्टर के पास गया जिसने उसको बताया था कि भाई तेरे को विटामिन डी की कमी है, तेरा किडनी खराब है. वी हैव टू डिस्कस द लैब्स विद द पेशेंट. Now, what this patient did was he started taking vitamin D by themselves. On regularly taking vitamin D, what happens is that फिर PTH का level suppress हो जाते हैं ना, because now the stimulus for release of bone turnover is gone, and that further causes further decreased bone turnover, which is called as adynamic bone disease. You will also find a question stating the statement adynamic bone disease is seen in, answer is CKD on vitamin D supplementation. I repeat the statement. Adynamic means bone turnover. Bone is always churning, no osteoclastic activity. Bone is always metabolically active. But now the metabolic activity of the bone will become lesser. If metabolic activity becomes lesser, it again becomes more prone to fracture. Normally, the bone is always dynamic. It will have osteoclastic activity. If the metabolic activity of the bone is lost, तो fracture का risk बढ़ जाता है फिर से. तो यहाँ पे what is the cause of adynamic bone disease? CKD guy who himself started taking vitamin D or calcium supplementations in therapeutic dosages. RDA में कोई दिक्कत नहीं है. This is, I'm putting a smiley to say RDA is fine. But if it is supplementation, then I'm putting a frown to say that अगर supplementation करेंगे तब दिक्कत हो जाती है. One, it will cause stones in the kidney, and second, even if it does not cause stones, it can cause a adynamic bone disease. So I hope, Kunal, your answer is queried. And now we come to the standard question which came in last time's FMG and NEET PG both. The question said, how will you manage the anemia of chronic kidney disease? The question said, what is the best management of a person, first line management of a patient of anemia of chronic disease? You can give quick comments in the chat box. What will you do for management? Will you give iron intravenously? Will you give oral iron supplementation? Or would you like to start darbepoetin? Can I have quick answers in the chat box? CKD patient presenting with anemia. What is the initial management that should be started in this patient? Should you give oral iron? Should you give intravenous iron? Or should you be giving to the patient darbepoetin so that darbepoetin in case because ultimately there is like anemia due to deficiency of erythropoietin, because the E part is, what is the E part? The E part is erythropoietin deficiency. भाई किडनी का काम होता है erythropoietin बढ़ाना. erythropoietin की कमी हो जाएगी तो पहले क्या करेंगे? तो हाँ जी, पहले हम पेशेंट में erythropoietin नहीं देते हैं, पहले हम आयरन के लेवल्स रिप्लीट करते हैं. आयरन के लेवल्स रिप्लीट करने के लिए दो तरीका है. एक तो है सिंगल डोज इंट्रावेनस आयरन. There are two ways to replete iron in the patient. Either I can give single dose IV iron, but obviously if it is a poor patient in India, he cannot afford that iron dextran infusion, so I can be using oral iron also. So between IV iron and oral iron, I can understand that still there can be some doubts present. So usually, like from Indian perspective, we start oral iron also, but your intravenous iron answer is okay, but सीधा darbepoetin start नहीं करना है. Here the error was that most people or most platforms were giving answer as darbepoetin. I agree to that. इतनी तो यार हमें भी समझ है यार, erythropoietin कमी है तो darbepoetin देंगे. पर क्वेश्चन में बोला था फर्स्ट क्या करेंगे, because most of the questions of your exam are like first step, next step. वहीं तो गलती होती है. इतना तो कोई भी कैजुअल, कोई भी मतलब नहीं होगा ना दिमाग, मतलब किसी का नहीं चला कि जी मुझे ये नहीं पता था कि erythropoietin deficiency is treated by darbepoetin, which is made by DNA recombinant technology. It is first to be given, that is correct the iron deficiency, and then subsequently what we can do in the patient is darbepoetin to be given. And then the point is toxicity due to which one? Toxicity of what? Please let me know. There are multiple causes of anemia in the patient. The first cause of anemia is erythropoietin deficiency. That's the primary one. Second is iron deficiency due to poor oral intake ना, because जो CKD वाले होते हैं उनको vomiting होती रहती है. तो vomiting रहता है, nausea रहता है, hiccups रहता है, because urea will irritate the GI tract. So there would be poor oral intake. That poor oral intake explains the iron deficiency, and then hyperparathyroidism causes increased bone turnover that damages the bone marrow. Hyperparathyroidism causes increased bone turnover, and increased turnover will also affect the bone marrow. We need normal, like, population of osteoblast, osteoclast, and the balance to need to be maintained. But now it's an accelerated phase, and this accelerated phase is the one where the bone marrow damage can occur, and as a result of this, like, the bone marrow is not able to function effectively. So there are three causes of anemia in CKD, but if you ask you to select one, I mean, first is erythropoietin deficiency, agreed, but what is first to be treated is not erythropoietin deficiency, it is iron deficiency, because without iron, if you will give darbepoetin, तो आरबीसीज तो बनेंगे पर उनमें आयरन ही नहीं होगा. तो व्हाट इज द पॉइंट ऑफ जनरेटिंग आरबीसीज वी डोंट हैव आयरन, बिकॉज अल्टीमेटली आयरन इज द वन कैरीज फोर एटम, one iron atom carries one Fe2 plus carries 4 molecules of oxygen. If the RBC is having less iron, the problem is one Fe2 plus carries 4 atoms of oxygen, so oxygen carrying capacity of the blood will be substantially reduced. The P part is what I've already highlighted, but I would like to say once again, hyperphosphatemia, and K is for the hyperkalemia. For hyperphosphatemia, the main drug that is used is sivalimer, that has been already told to you. Somebody had commented another drug, so I'm waiting for your answers. What is the other drug that you use for hyperphosphatemia? In fact, out of 3 drugs, 2 I've already written before you. Sivalimer is a phosphate binder, calcium acetate is a phosphate binder. Can you comment on one more drug? Yes, lanthanum carbonate. Another drug is lanthanum carbonate. This is the second drug which can be used to bind to phosphate and take care of the deficiency of calcium. Sivalimer. Okay. Fine, guys. Next is the potassium part. So this also somebody had commented, but then at that time I said that drug is basically for hyperkalemia. So yes, guys, you can yes, you can comment on the chat box for what are the drugs that would be used here for potassium binding. These are potassium bindings. Yes, patinomar is the main drug that would be used in this particular patient. Yeah, metazolone is a diuretic, beta. That is a diuretic that can be used in a patient. So it is patinomar that can be used in a patient. Very good, very good. Apart from patinomar, we can be using sodium zirconate. And then is sodium K-bind, that is sodium polystyrene sulfonate. SPS stands for sodium polystyrene sulfonate, which is a potassium binder that can be used. Among the 3 drugs that I've highlighted before you, the main drug that is used is patinomar. So A, B, C, D, E, and PK are basically the mnemonic which is used for medical management of the patient. At this moment, I also want to say that because these patients can be having swelling also, like pedal edema. So what is the diuretic that can be used in low GFR? Then most of the time the GFR is diuretic that is used in low GFR is metazolone. It is a thiazide diuretic that can be used, but not hydrochlorothiazide. We don't use hydrochlorothiazide in the patient. If he says what diuretic can be used in CKD, then diuretic in CKD can be used as metazolone. If potassium is elevated, then this is the safest molecule that can be used there. We cannot be using spironolactone because the problem with spironolactone is it is potassium sparing diuretic. So it is metazolone, which is a thiazide that can be used. The role is mainly to take care of the pedal edema component. I mean, most CKD patients will be having volume expansion and pedal edema. So for symptomatic control, we can be using metazolone in these patients also. So this is basically the medical control that I was talking about. ABCD. A is HbA1c control, B is blood pressure, C is cholesterol, keep it value less than 70 for LDL. D is vitamin D, then is erythropoietin, Kp is the potassium and the phosphate parts that I've highlighted. So this one pager is about the mnemonic ABCD PK to remember medical management of patients of chronic kidney disease. And obviously this is not the main thing. This is like the supplementary treatment that would be required. We need to obviously go for like dialysis and transplantation that I'll discuss before you. And before I do that, I would just like to revisit these 2 slides of diabetic nephropathy. So I'm going to call them A and B, and you can comment on the histopath findings here. Please let me know the histopathological finding. A versus B, please comment for A first. What is the histopath finding of diabetic nephropathy? And the hint is that this is overall the most common finding. And for the second one, the hint is that this is the most characteristic histopathological finding. So both of them have to be remembered, most characteristic and most common. First, A please, A finding. Slide A, please. Yeah, slide A will be, yes, this slide A is characterized by diffuse. Slide A is characterized by diffuse glomerulosclerosis. This is the most common. This is not Kimmel-Stein-Wilson. This is the commonest mistake made by people. The most common is not even Armani-Epstein. That is going to be glycogen deposition in the tubules. Your answer will be that the patient is having, because you can see all the purple and the big material involving whole of the glomerulus. So we will say diffuse glomerulosclerosis in a patient. This is the most common histopathological finding in the patient, not focal segmental. It is A is diffuse glomerulosclerosis. This is the most common histopathological finding here. If he says what is the most characteristic one, then you can see nodules. Then you can see this is one nodule, this is another area, right? So then the word will change. Then your answer will be given as most characteristic. That is Kimmel-Stein-Wilson change. This is what is called as nodular glomerulosclerosis. So they expect you to identify the slides and they are like doable. I mean doable because you can pick up the nodule separately, nodular glomerulosclerosis. It is for this the word used is Kimmel-Stein. So this word is like Kimmel-Stein-Wilson change is so in your face and like so characteristic कि पढ़ के लगता है कि यार यही सारा की सारी चीज़ है, जबकि ऐसा नहीं है. It is the characteristic finding because ये यहीं पे मिलता है, but then it's not the most common finding that is encountered. Then there's another finding which can be seen in the proximal tubule of the kidney. That finding in the proximal tubule of the kidney will be glycogen deposition in the tubule because glucose would be stored as glycogen in the tubules of the kidney. This proximal tubule change was asked in last by INISET exam. This is called as Armani-Epstein change. I mean not Armani the fashion designer, but maybe उसका भाई होगा तो वो डॉक्टर बन गया बेचारा pathologist. So Armani-Epstein change would be the glycogen deposition in the wall of the proximal tubule. Now comes the question, what is the earliest feature of diabetic nephropathy? I would expect you to answer this. Yeah, Armani-Epstein is Epstein नहीं, बोला नहीं वो पेडोफाइल वाला नहीं, ये दूसरा एप्स्टीन है, AB, वो EP है ना, वो EP है, ये EB है. या अर्लीस्ट फीचर ऑफ डायबिटिक नेफ्रोपैथी इज हाइपरफिल्ट्रेशन. इसको पढ़ के बड़ा सरप्राइजिंग लगता है बिकॉज नॉर्मली तो किडनी फंक्शन लेस होना चाहिए, बट यहाँ पे क्या होता है एफरेंट आर्टीरियल की कॉन्स्ट्रक्शन हो जाती है. द अर्लीस्ट फाइंडिंग दैट इज सीन इन डायबिटिक नेफ्रोपैथी इज हाइपरफिल्ट्रेशन, एंड बिकॉज ऑफ दिस हाइपरफिल्ट्रेशन लाइक द रीजन इज एफरेंट आर्टीरियल कॉन्स्ट्रक्शन. अब इमेजिन करो एक ट्यूब है, एफरेंट आर्टीरियल इफरेंट आर्टीरियल, एक एफरेंट है और एक इफरेंट है. अगर मैं इफरेंट को बंद कर दूं तो फ्लूइड आ तो रहा है पर इफरेंट से निकल नहीं पाएगा, तो ग्लोमेरुलस में प्रेशर बढ़ जाता है. सो हाइपर फिल्ट्रेशन इज द रीजन व्हाई इन दीज पेशेंट्स द फिल्ट्रेशन प्रेशर इन द ग्लोमेरुलस इज मोर एंड दैट रिजल्ट्स इन डैमेज टू बेसमेंट मेम्ब्रेन एंड proteinuria. What is the screening test that would be done in this patient? The screening test for this patient is called as urinary micral, or is also called as albumin creatinine ratio. This albumin creatinine ratio value should be how much that we will say that the person is having CKD manifestation starting. Then urinary albumin creatinine ratio will be between 30 to 300 milligram per gram of urinary creatinine. In the numerator it is albumin, and in the denominator it is per gram of urinary creatinine. In the denominator it is per gram of urinary creatinine. So the point to be understood is UACR लिखा हो सकता है, urinary albumin creatinine ratio is a screening test. When I told the patient your kidney is damaged, he is laughing on me. Sir, in my society there was a health camp and I got on Holi festival, there was a health camp in my society and my KFT was normal, my creatinine was normal. Like he's showing me his KFT report in his mobile phone और वो कहता है कि सर आप मजाक कर रहे हो क्या, स्कैम कर रहे हो क्या मुझे डॉक्टर साहब, कि मेरा सीरम क्रिएटिनिन 1.0 है. कहता है रिपोर्ट में लिखा नॉर्मल होना चाहिए 0.8 से 1.2, मेरा सीरम क्रिएटिनिन 1 है और आप कहते हो मेरा किडनी खराब हो गया. सर क्या बात कर रहे हो? तो मैंने बोला हाँ जी सर, आपकी किडनी को खराब होना स्टार्ट हो गया है और क्रिएटिनिन राइजेस व्हेन मोर देन 50% ऑफ द किडनी इज डैमेज्ड. मेरा क्या बात कर रहे हो? दिस इज नॉट द बेस्ट किडनी फंक्शन टेस्ट. आई सेड इट इज बेस्ट स्पेसिफिक किडनी फंक्शन टेस्ट, अगर मैं बात करूं व्हाट इज द मोस्ट स्पेसिफिक किडनी फंक्शन टेस्ट, it is not sensitive, it is not sensitive, it is specific. Serum creatinine will rise when the kidney will be damaged by 50%, but if the kidney is damaged 5%, 10%, then can we pick up the disorder? Yeah, that is the objective of screening test now. Why do you do a screening test? Screening test is always done for early diagnosis. Screening test is always done for early diagnosis. So you will say that for early diagnosis, the damage to the kidney, it is urinary albumin creatinine ratio, and serum creatinine the patient will write late. Yeah, the alternative name is microalbuminuria. तो पहले तो मान नहीं रहा था कि अरे नहीं नहीं सर ऐसे नहीं होता, सीरम क्रिएटिन नॉर्मल है. फाइनली ही कुड अंडरस्टैंड, थोड़ा बहुत मैं सब समझाया प्यार से कि देखो ये टेस्ट देर से राइज करता है एंड दिस इज अर्ली डायग्नोसिस. सो ही एग्रीड, कहता सर करना क्या. So you guys will hit it here. You guys will comment here. What is the first line drug? Objective of screening is early diagnosis. So the guy finally agreed to whatever I said. He said, "Okay, boss, I understand your point that the damage is there. Creatinine will rise later." So what is the first line drug that you will be starting in this guy? You will say that I will be starting the patient on very good low dose ACE inhibitors would be started in this patient. The objective of starting these low dose ACE inhibitors will be that they will dilate that efferent arteriole. By dilation of efferent arteriole, what will happen is the filtration gradient will become lesser and therefore damage to the basement membrane will become also lesser. The second medicine that will be started in this patient is SGLT2 inhibitor. Let me know, why do you give SGLT2 inhibitor? Yes, guys. Yes, guys. Why would you be giving SGLT2 inhibitors to this patient? I understand they're renoprotective. I understand they're renoprotective. Yeah, they cause salt loss from the body. They cause salt loss from the body. Salt loss is good because they will cause the systolic blood pressure to decrease by 5 millimeter. It causes only 5 millimeter decrease in the systolic BP. Only 5 millimeter fall in the systolic BP, but that is sufficient to prevent the damage to the basement membrane in the patient. No, it is not heart failure. It is simply that when the BP will become less, then the pressure on the basement membrane will become less. So the damage of the glomerulus will be also less, because high blood pressure also is damaging the kidney. Na? High sugar is damaging. And now concomitantly there is a higher renin hypertension. So I need to balance it out. I need to treat, basic problem is high renin hypertension. So you give ACE inhibitors and you give SGLT2 inhibitors for management of this patient. Yeah. Mainly I want to lose not sugar today. Sugar will be lost obviously, but it is the salt loss that I'm interested in. So low dose ACE inhibitors and SGLT2 inhibitors will be used in this patient. The aspect of metformin and insulin I've already explained to you. And usually at this moment, we will like to switch the patient over to insulin. बिकॉज उसको बोलेंगे सर इतना टाइम से आपने मस्ती किया ना, HbA1c आपका 12-14 ऐसे चल रहा है, तो आप अभी इंसुलिन के इंजेक्शन लगवा लो और बाद में हम आपको ओरल हाइपोग्लाइसेमिक ड्रग्स पे शिफ्ट कर देंगे. So most patients at when the damage is starting, they're little receptive, so they agree for insulin at this point of time. But whatever insulin that we will give is dose reduced format, that is 80% of the calculated dose, as I explained to you. That is because insulin is excreted by the kidney. Insulin is not metabolized by liver, it is also excreted by the kidney. So that would be the treatment that would be used. I just wanted you to be clear about the word hyperfiltration, which is one of the earliest feature of diabetic nephropathy. Couple of people were saying polyuria. No, it's not polyuria. It is just hyperfiltration, and GFR will come to be paradoxically more than 125 ml per minute. And therefore, in these patients, once they go into G4, that is when we'll be able to analyze these patients relatively better. Before I go to the next slide, I want you to listen to me for next 2 minutes, 1 minute, and after that, we will start noting the data once again. In all patients of chronic kidney disease, when they come to the hospital, we write the G grade and the A grade in the patient. What do you mean by A grade is that suppose if the amount of albumin in the urine is less than 30 milligram per gram of urinary creatinine, then I will say A1. If the amount of proteinuria increases to the value that I just explained to you, that is 30 to 300 milligram per gram of urinary creatinine, it is called as A2. And if the amount of protein increases to more than 300 milligram per gram of urinary creatinine, I call it A3. So when the patient came to me in 2023, the status of the patient was G3A and it was A1. So I told the patient that, sir, we need to intervene because you are fitting into the definition of chronic kidney disease. The guy laughed it off. अभी जब वो 2026 में मई खत्म हो रहा है, मेरे पास आया, अप्रैल एंडिंग में मेरे पास आया, तो इस पर्टिकुलर पेशेंट का जो स्टेटस है वो चेंज हो गया. नाउ इज गोइंग ऑन टू G4A2. So you can see that there is a deterioration of the patient. So I mean, why are we doing this staging of G4 and why are we checking out the estimated GFR or creatinine clearance is primarily to monitor the progression of the disease. The objective was to teach you that why are we calculating G4 in every visit is because we want to know what is the current value of the eGFR, which might also be written as creatinine clearance. Then the objective is like we can see now whether the person's status is remaining the same. Because अगर वो दवाई खाया होता, अगर वो पहले से ही लो डोज एस इनहिबिटर, मैं तो उसको 2023 में बोला था, आज से 3 साल पहले कि भाई एस इनहिबिटर ले लो, SGLT2 इनहिबिटर तो अभी आए हैं, तो उस टाइम तो लो डोज इनहिबिटर ही यूज करते थे. एंड या वन मोर ड्रग आई विल नाउ से आस्क यू. So it is like monitoring of the patient that is recommended at this particular point of time. I mean monitoring of patient के लिए ये सारी activity करी जाती है. And I've also mentioned the grades of A1, A2, A3 at the moment. I don't think so you need to note down. It is pretty understandably that we are trying to monitor the case. Question open to everybody. Patient is having high renin hypertension. So what diuretic is recommended in diabetic patients? One more drug here, which is a diuretic recommended in diabetic patients, which has shown to improve cardiorenal benefit or has reduced cardiovascular mortality. डायूरेटिक बेटा, डायूरेटिक. वो तो फिर यहाँ पे होगा ना, एस इनहिबिटर से कफ हो गया, मान ले एस इनहिबिटर से कफ हो गया तो आप टेलमिसर्टन दे दो ना. एस इनहिबिटर की जगह पे ARB यू कैन गिव इफ देयर इज अ साइड इफेक्ट दैट इज अकरिंग. बेटा एस इनहिबिटर तो की जगह पे ARB देते, मैंने डायूरेटिक पूछा. डायूरेटिक मिल रहे ना तो हार्ट फेलियर वाला है. नो 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 नो, ये मैंने बताया हुआ है. स्पार्नोलैक्टोन किसी ने बोला, बिल्कुल सही बोला, मैं उसका कजन ब्रदर बोल रहा हूँ. The mortality reducing drug, renoprotective drug is Finrenon. It is a cousin brother of spironolactone that is given to the patient. This diuretic will be given because they would be swelling in the body. Metazolone नहीं बेटा, metazolone नहीं. The diabetic nephropathy के लिए अगर बोलते हैं कौन सा diuretic है, then answer is Mindrenon, and this will be written in MCQ as MRA, that is mineralocorticoid receptor antagonist. But it is aldosterone antagonist ना. So because I said RAS system, and RAS system में तो बेसिकली कार्डियोवास्कुलर रीमॉडलिंग हो जाती है पेशेंट की. थाइजाइड्स बार बार आ रही. मैं आपको आई थिंक मैंने बताया था, बट मैं एक बार फिर से बोलता हूँ कि क्यों हाइड्रोक्लोरथाइजाइड आजकल लिखने में हर कोई मतलब थोड़ा सा डाइसी रहता है. थाइजाइड्स आपने अगर कभी दिए हो तो आपने नोटिस किया होगा ब्लड शुगर बढ़ जाता है. मोस्ट इंडियन पेशेंट तो वैसे ही डायबिटिक है, लिपिड्स बढ़ जाते हैं, यूरिक एसिड बढ़ जाता है. यूरिक एसिड बढ़ने की वजह से आप समझ सकते हैं ना, जॉइंट्स की प्रॉब्लम स्टार्ट हो जाएगी, उसको जॉइंट पेन हो जाएगा. थाइजाइड्स के साथ में हाइपोवोलीमिया होता है, मसल क्रैम्प्स होते हैं, हाइपोमैग्नीसीमिया होता है और मेटाबॉलिक अल्कलोसिस होता है. आप अगर फार्मा के नोट्स पढ़ेंगे तो उसने ये सारी बातें आपको बताई हुई हैं. Thiazides are a molecule which nowadays are little out of fashion, not because that they are old drugs, they are out of fashion. That is okay. When to answer metazolone, when to answer Finrenon. So if the question simply says CKD and what diuretic is recommended and low GFR in the patient, then your answer would be given as metazolone. But if it says in diabetic nephropathy, what is the drug that reduces the progression of the disease, then your answer is Finrenon. जो मेटाजोलोन है वो तो सिर्फ पाँव की सूजन कम कर रही है, उससे मोर्टालिटी रिडक्शन पे ज्यादा इंपैक्ट नहीं पड़ रहा और वो GFR में काम कर जाती है. बट फिनरेनॉन जो है वो हम जब G4 हो गया तब नहीं दे रहे, इसको स्टार्टिंग में दे रहे हैं ताकि वो G4 में ना जाए. इसको G1, G2, G3 में दे रहे हैं ताकि प्रोग्रेशन ना हो. मेडिकल ट्रीटमेंट कब देंगे? इनिशियल पार्ट ऑफ द डिजीज में वर्सनिंग ना हो. सो दिस मेडिकल ट्रीटमेंट व्हाई यू आर गिविंग इट, दिस ट्रीटमेंट इज गिवन इन G1, G2, G3 टू prevent the progression of deterioration. One will go into G4, G5, तब इसका फायदा नहीं मिनरेनॉन का, तब हम उसको एप्लेरेनॉन यूज कर सकते हैं. All these drugs are given to protect the damage. So if the simple words are, I'll say that again. If he says diabetic nephropathy, what drugs are given to reduce the progression of the disease? Then your answer is Finrenon. Reduce the progression of the disease. Your answer is Finrenon and all the other drugs that I've explained. In the later part of the illness, we can use like maybe at G4 or G5, we can be adding drug like the previous one that I mentioned, which is a thiazide only, that is metazolone for the patient. Okay, guys. So at this moment, the main aspect is why thiazides. I hope now like thiazides will not come in the discussion again because of the side effect. And each one of these is an MCQ, guys. Hypokalemia, hypomagnesemia, metabolic alkalosis, metabolic profile getting deranged. That is why like people are not very comfortable writing thiazides. Earlier like thiazides were written left, right, center for hypertension patients. Huh? Now you will notice we are using CCP. Why that change occurred was because we were showing that with patients with cardiometabolic disorders, these are not good drugs to add. Now patient has gone into G4. He's progressing to G4. So when person will go into G4 status, we will advise him कि सर या तो transplantation करवा लो, and if you don't want to go for transplantation, we can prefer a dialysis. If the question simply says what is the preferred modality for management of a G4 patient, then I will say kidney transplantation. But if patient is not having finances or is not having a donor, then most common used modality is hemodialysis. I repeat the statement again, two separate MCQs mentioned here. One, he will say what is recommended transplantation and what is most commonly used modality. Most commonly used because obviously cousin, brother, sister, real brother, sister stop taking phone calls. So kidney will be only available from a cadaveric donor, and cadaveric donor kidney, when it will be available, there would be so many people in the waiting list that only one lucky guy will make it. So most commonly used modality is hemodialysis. Both are both do not mean the same. One is what is recommended, and second is what is the most commonly used modality. And uh, okay, I'll talk about transplantation related issues in like just few minutes at the moment. It's just a phobia. Phobia to nahi bolunga. It's a procedure which will obviously have impact on the health of the recipient only, especially if the surgery is not done well. Okay. We do a hockey stick incision, that big J-shaped incision that is present. What is the most common complication of hemodialysis? Yeah, exactly, Karthik. What is overall the most, keep on answering. What is the most common complication of hemodialysis? Yep. The most common complication of hemodialysis is because when you do dialysis, you not only remove electrolytes, but you remove water from the body also. You will notice that the weight of the patient is taken before dialysis and after dialysis. And because water constitutes, when RAS is activated, water is more in the body. No? So when you will notice that patient will be losing some weight also after hemodialysis. You will lose bad things, urea, creatinine, potassium, bad things are lost. I understand that. But along with bad things, even extra water in the body will be lost. So that is why we check the weight of the patient before and after the procedure. And most of the time, like the commonest complication of hemodialysis is hypotension. One of the reasons for hypotension is because we are using a product in the dialysate fluid, that is acetate, and that acetate in the dialysis fluid will be having vasodilatory effects also. And if we chill the dialysate, like you will notice lots of time patients also complain of cold, they start feeling cold during dialysis, so we give a blanket to them. So that is because we deliberately cool the dialysate so that at least the chances of this hypotension complication can be reduced. But you would have noticed patients having chills, especially for second time when they're undergoing a dialysis, and we need to give like 2-3 blankets for the patient. Now, why is dialysis not recommended by doctors as first line? If dialysis is so commonly used, why do we as doctors don't tell the patient सीधा dialysis करा लो? Why do we say transplantation? Patients will obviously say, oh, you get more commission. See, somebody becomes a nephrologist, in every that cut will be very high. 50 lakhs is the bill. So even 10%, you can understand the guy will be making 5 lakhs approximately. So of the time, why people become a nephrologist or why DM nephro is in demand is because in India, diabetes means kidney disease, and kidney disease means ultimately a requirement of transplantation. And like people just convince people nowadays, they don't do intervention, they just convince them to go over to the hospital where the transplant, because it's a full team that is working now. So most of the time the nephro guy will be convincing, and they get good money out of that. Okay. Yes guys, what is the most, I did not get an answer. What is the most common complication of recurrent hemodialysis? The most common complication of recurrent hemodialysis is increased incidence of accelerated atherosclerosis. Guys, if a person will be done dialysis again and again and again, that is 3 times per week for the rest of his life, then there will be high incidence of heart attack in a patient, because we know that dialysis procedure causes increased incidence of heart disease. Look at the double insult I'm telling you. Kidney disease itself increases the risk of heart disease. Kidney disease itself increases the risk of heart disease, and the procedure you are doing is further increasing the risk of heart disease. So that is why we as doctors don't recommend dialysis as first line management. We recommend transplantation. It is on the patient. He says, I don't have money, I don't have a donor, koi baat nahi bhai. We will create a fistula in your non-dominant hand, and that fistula in non-dominant hand between the two blood vessels that you will tell me now will be doing very well, and we can do your dialysis. We will not straight away say that, okay, you will die because of a heart failure. We will just say, sir, recommended is dialysis. Otherwise, you have to come to the hospital again and again. Now it's up to you whether you want to get any of the two things done. He says, okay, boss, He says, okay, boss, as you say, I am like okay for dialysis. So in this particular patient, in the non-dominant hand, we will be creating a fistula between the radial artery and the cephalic vein. Very good, guys. Radial artery in the cephalic vein. We are creating a fistula, and this fistula is called as the Seminobrestia fistula. The advantage of the fistula is that now you don't need to, you don't need to suck out the blood from the body. This will create a pressure gradient. Now, artery pressure is more than the vein pressure. If artery pressure is more than the vein pressure, when you cannulate the vein, normally when you cannulate the vein collapses. Like all of you would have done venipuncture. When you take a sample from here, the vein collapses, blood stops coming in the syringe. Similarly, here when you will put a cannula, if I put cannula directly in the cephalic vein, then the vein will collapse after a few minutes. No blood will come. But here, if artery is connected to the vein, there's automatically a pressure gradient created. So the blood will come out of the body of the patient directly towards the hemodialysis machine. It will obviously be like a heparinized blood. We will add heparin to the circuit of dialysis machine. And when heparin is added to the, like you can see a heparin pump written here. So that heparin pump is written because obviously the blood will clot otherwise. So the blood, that is the impure blood, will come out of the body of the patient by itself because of the pressure gradient. Heparinization of the sample will be done, and then the machine will be doing the cleaning of the blood of the patient. A question for you guys is, all of the following will improve with dialysis, except which of the following will not improve with dialysis? Voting is open at the moment. Pressure gradient causes atherosclerosis. All of the following improve with dialysis except. Yes, guys. Yep. See, I said bad guys will be removed. What is the bad guy? Protons. What are the bad guys? Hydrogen. So when you remove potassium, when you remove hydrogen, the patient is bound to improve. And then apart from this, you can see pulmonary edema. Water will also be removed. You see, there is a volume expansion. So water is excess in the body. This water excess will also be taken care of. So when you do dialysis, potassium is removed, hydrogen is removed, water excess is removed, but kidney damage, I mean, whatever changes in the bones have occurred. Meaning of the word renal osteodystrophy is that PTH in the body is more. Meaning of the word osteodystrophy is, renal osteodystrophy is that like the damage to the bones is already there. So you can't reverse like bone damage in a patient. The correct answer to this question is option number A. Yes. The renal osteodystrophy causes changes also. Those changes are what are taught to you in radiology as Ruger-Jersey spine. One of the changes in the bones because of PTH that is more is what is called as Ruger-Jersey spine. The point is that whatever changes have occurred in the bones, I mean damage is done now, then you cannot do anything, but you can remove the bad things like potassium, hydrogen, water. So B, C, D will be responding, but A will not be responding. All of the following improve with dialysis except. The answer will be A. Yeah, we can minimize it, but we can't reverse it. No? All improvement does not mean stopping the progression of the disease. They would be two different things. Okay. In kidney transplantation, we don't remove the old kidney. Old kidneys are still in place. You can see the diseased kidneys are still not removed. You are placing the new kidney in the right iliac fossa of the patient. You place the new kidney in the right iliac fossa. One advantage of putting the kidney in the right iliac fossa is it is very close to the urinary bladder. So you don't need to maintain 25 centimeter length of the ureter. All of you know length of the ureter is 25 centimeter. If the kidney will be placed very close to the urinary bladder, then you don't need to maintain the entire 25 centimeter supply of the ureter, because otherwise you would have done a transplantation of whole of the ureter and whole of the kidney, and God forbid tomorrow if the ureter blood supply got compromised, the whole procedure got wasted. One of the rationale behind why you are putting the kidney in the right iliac fossa is that it will obviously get its blood supply from any nearby blood vessel, as you can see. But because it is a short ureter, the chances of a short ureter having issues with blood supply is lesser as compared to a long ureter having problems with blood supply. So we don't try to remove the old kidneys at all. They will remain in place, and the new kidney will be put in the right iliac fossa. And as far as the lifespan is concerned, the life expectancy is increased by huge 1.5 years. This is primarily the reason that there is so much of demand. And that is the reason why there is the illegal racket that is operating, and that is why recently some doctors have been arrested in UP also and in Delhi also. I mean, the top chief transplant surgeon of Apollo Hospital. Can you beat that? I mean, the chief transplant surgeon of Apollo Hospital, he would be so like rich guy with so much of money and so much of respect. He was involved in a racket recently, and like he was arrested by Delhi police, and that was because he was involved in this illegal purchase and sale. Yeah, Tamil Nadu, all places, man. In Delhi, what happened was these illegal Bangladeshis, they're coming to India, na? That Rohingya and all those people who are displaced. So these illegal people who are coming to India, they are like poor. So these scamsters, what they're doing is they are roping them in, and they are like, are telling them, we'll pay you this much amount of money, and you need to donate a kidney, and they're agreeing for this also. So it was like, yeah, through WB, they come in via Bihar circuit, and then they come to these places where like they are like illegally selling their kidneys. So I'll just take 30 seconds into this. This police constable, he was going on his bike, and he just came across a guy standing in a lungi and a dhuti, and like he did not look that typical Indian, the typical Indian look that would be having in Delhi, and he just started speaking to this guy. So he noticed that under the vest of this guy, he was wearing that banyan types, no, that vest. So that vest ke niche a lot of dressing was visible. Some blood was soakage was also there. So he asked him, "What is it?" So the guy got a little nervous. He started stammering. So he just told this guy that sit on my bike. We go to the police station and we talk. And in the police station, like this guy, police constable did not know anything. So he just called up the ACP and he said, "Boss, I have a guy. He's a little suspicious. Doesn't look to be a typical Indian. He's not able to even tell me his, Aadhaar card details, etc. And boss, he has undergone some surgery. And also, can you come?" Now, ACB being an educated guy, when he started coming and when he started talking, he realized that this is a kidney racket that is happening. And they traced it all the way to Apollo Hospital. So it was very shocking. I mean, reputed doctors falling for the track in this particular patient, and they're contributing to this. Yeah, we like you see, we are not supposed to allow illegal things to happen, right? I mean, once you get involved in that, once you get sucked in the circuit, you can never, Hotel California song, no? You can check in anytime you want, you can never leave. If illegality में फंस गए भाई कभी नहीं निकल पाते. You can check in anytime you want, you can never leave. That's the basic message. So never get involved with these illegal people. And now comes the aspect of lesion with high recurrence tendency after kidney transplantation. You see, lesion that does not occur after kidney transplantation and lesion with high. This is two pathology MCQs. Would you like to try it out, guys? What is the lesion with high recurrence tendency after kidney transplantation? I mean, it will come back. And second is lesion that does not reoccur after kidney transplantation. Okay, okay. I'm waiting for a couple of answers at the moment. Yeah, you will sleep peacefully. Most important thing is being able to sleep without stress. Chalo, 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 chalo. Okay. Yeah, absolutely. Yeah, lesion that does not reoccur. Absolutely. Like if I talk about Alport syndrome, so one, though I can mention like, Alport syndrome, mein, so you are changing the kidney of the patient, so the disease will not come back. Na? I mean, it's a defect of type 4 collagen. You are changing the kidney in the patient. So in which lesion that does not reoccur? Lesion that does not reoccur after kidney transplantation is Alport syndrome. In Alport syndrome, like what is the defect which is present? So Alport would be a 5 wala na, alpha 5 chains. It is alpha 5 chains of type 4 collagen that are involved here. High recurrence with a dense deposit disease. Exactly. Alport, we will just quickly mention. Alport is defect of alpha 5 chains or type 4 collagen. The gene which is involved here is COL4A5B. COL4A5. It is COL4A5 gene which is defective in this condition. The pattern of inheritance of Alport syndrome is X-linked dominant. It can be X-linked recessive also. It can be autosomal dominant. It can be autosomal dominant. It can be autosomal recessive. The most common pattern of inheritance is it's gonna be X-linked dominant. That's the peculiarity, because normally one disease will follow one pattern of inheritance, but in this every generation the pattern of inheritance will change. For this particular disorder, every generation the pattern of inheritance will change. And then we have a triad in this particular condition, which you all know, so I don't need to say that. I'll just quickly say. One is obviously that sensory neural deafness could be present. Second is obviously the kidney disease, which will start with hematuria. It will progress to renal failure, because now we don't use the word end stage renal disease, so I did not write ESRD. And then would be anterior lenticonus that would be present in this case. So most of the time, like the question is so easy that he will say grandfather died of kidney failure. father died of kidney failure. So considering the fact that if in the question he mentions the fact that father also died of like uremia and grandfather also died of uremia and multiple generations of the patient are getting affected, we think in terms of LPOT and genetic testing when those circumstances would be done. It is anterolenticonus, sensorineural deafness, and hematuria with subsequent progression to renal failure in the patient as manifestations of LPOT. But yeah, when it comes to dense deposit disease, the chances of recurrence in the patient will be relatively high. And now, like there are multiple diseases that can recur. One of them is dense deposit disease. And then comes the issue of which of the following is an absolute contraindication for urgent hemodialysis. I give a situation to you. You are attending my class right now, and you get a call from a distant cousin. That cousin has not connected you with you for so many years, but today he just calls you in a bit panic mode, and he says ki bhai kaise ho, and like my dad, like his dad and he's your uncle. He says that he's in ICU and the doctor there is saying that abhi transplantation abhi dialysis karna padega. So वो कह रहा है कि भाई just let me know brother, let me know whether this is a scam that sometimes hospital put undue pressure. They अभी give permission, and if you will not give permission then write that you are saying no to the fact that your dad will not be undergoing a hemodialysis. I mean we need a clear cut instruction from you, either yes or no में आप answer करो. That is the pressure that the hospital is putting on me, and is calling you brother, I'm in a dilemma and I'm not understanding, can you please help me. So which of the following is an absolute indication for hemodialysis? So absolute indication for hemodialysis में देखो तो I don't think so that anybody would answer as D versus B, because melena and asterixis तो can be managed later also. There are only two complications which are left here. One is uremic encephalopathy, that is second is uremic pericarditis. So let me explain. Uremic encephalopathy, even if you do dialysis tomorrow, it will not change the prognosis. If he is unconscious today, he will be unconscious tomorrow also. But uremic pericarditis, guys, answer is not C. Answer is not C. Answer is not both of them. Answer is only one. It is uremic pericarditis. Now listen to me very carefully. Why the answer is uremic pericarditis? The basic problem is that when uremia will occur, then uremia is a toxin. Uremia is a toxin state, and toxin state will cause development of bleeding in the pericardium. Uremic pericarditis is looking like a very harmless condition, but what is actually happening behind this is that there is a development of hemopericardium. If the blood continues to accumulate in the pericardial space, the space in the pericardium is only 20 to 50 ml. In the next 1 to 2 hours, it will get transported or transplanted into, or it will get converted into cardiac tamponade. And when cardiac tamponade will occur, I know that you will say that, sir, can't we do a pericardiocentesis? तो सारा blood थोड़ी ना निकाल देंगे. Even if I do pericardiocentesis, ultrasound echocardiogram guided, and remove the blood will come back again, the blood will come back again. You can't remove whole of the blood of the patient because the guy is bleeding. So there is uremic pericarditis, looks very harmless, but actually it is like a volcano below the apparent calmness on the top. You went to a mountain, you thought it is like a very fantastic mountain, and you came to know that it is a dormant volcano, and in the dormant volcano below is the lava. That lava is in the form of that bleeding that is happening in this patient, and when the lava will explode, nobody knows when the dormant volcano will explode. Similarly here, when tamponade will occur, you will lose the patient in next 2 hours. That is why the nursing home or the doctor was putting pressure on the family members that you give us a consent to do dialysis, and if you say no, then no problem, just write on the case file you're not giving consent, so that medico legally that doctor is safe. So uremic pericarditis is an absolute indication for dialysis. Guys, the word is absolute. At this moment, I want to say that when I was a student your age, even when this question came up in one of our ward rounds and my consultant asked me that what is the indication for dialysis, and between pericarditis and encephalopathy, I also answered encephalopathy like majority of you. A lot of you have answered A because you've listened to me earlier, guys. But if you are honest, then you will agree to the fact that the first thought process is usually encephalopathy. First thought process is usually encephalopathy because guy is unconscious. So even I told my consultant encephalopathy, and the moment I said encephalopathy, he said, okay, get out. Staring at his face, sir, what? But get out of the ward. Sometimes in the wards, like they just say it like this rudely, and I felt so embarrassed, so bad. And he said, answer ढूंढ के आजा, library में जा. And I did not know कौन सा book पढ़ना है. मतलब that Harrison is so big and Davidson में तो concise दिया होता है. So I was like fumbling through books and everything, was not able to find an answer. Finally was able to locate it in one of the books, but then the point is like lots of time when they put undue pressure on us, then that also tends to either break or make a doctor. And most of the time it breaks a doctor. So never like be that senior who tries to break a doctor. Always be that senior who motivates and teaches. After teaching, like after I've taught you and I say, okay, doctor, tell me, and you say wrong, I have the right to scold you. But if I don't teach you anything and in the front of patients, if I scold you, not like in the ward, you all see in the status, no, they make you wear that white apron. After that white apron, you stand and then they start scolding you. So I mean, scolding and whatever, they put that pseudo thing. I am bada doctor, this guy is chota doctor. That should not be happening. Even auto rickshaw driver will say this is a junior doctor, this is a senior doctor. Do we know who is a junior auto rickshaw driver, who's a senior auto rickshaw driver? Do we know who's recently started working and who's not started working? Only in our fraternity this artificial classification is created of hierarchy level. Oh, ये तो intern है, अरे 5 साल पढ़ा है, intern है, right? That kind of discrimination should not happen. Be the senior who with whom people want to work with. I was a senior where people used to say, sir, आपके साथ काम करना है, मजा आता है. I used to let them, near our hospital, Pandara house, Pandara road is there, very good restaurants. So at night I used to order, everything, whatever they wanted to eat. I said, buddy, you eat whatever you want and just chill. It take 2 hours for your dinner, come back. तो आते थे पता है वापस. I never had to tell them तुम्हें ये काम करना है and everything. I mean, as a resident, I'm telling you, when I was a resident, I was telling you that people wanted to work and I want you to imbibe the same work culture, that never torture interns, never be bad to interns. I went through the bad experience. I did not translate it, and still today, I know some of my batchmates who are like consultants at MAMC, at GB Pant, and big hospitals, and they still tend to carry that negative traits with them, which should not be happening. The answer to this question is option number A. Yeah, have more is the best place to have that. Okay, great. Now, once you have done a kidney transplantation, opportunistic infections will occur because you will be putting the patient on anti-rejection drugs. I mean, the rationale behind why is this happening? The rationale behind why there is unfortunately opportunistic infections developing in a patient is because you are giving anti-rejection drugs to the patient. Just to mention like couple of anti-rejection drugs, obviously steroids are there, but these medicines like cyclosporin, azathioprine, prednisolone, all these kind of molecules. I have not written tacrolimus at this particular point of time. When time comes, I will write tacrolimus also, sirolimus also. But at this particular point of time, yeah, that हम लोगों ने किया, तुम भी करो. That should not happen. You have to be positive person. So I hope I'm able to teach you that through though I'm very far away from you, maybe you guys would be hundreds of kilometers away from me, but I think I'm able to instill that positivity in you. One is the positivity of ensuring that medicine is very much doable, and the second positivity is that never be bad with fellow doctors and never take fees from fellow doctors. Even आज भी मैं देखता हूँ, big consultants, and they take money from medical students. यार वो अपनी मम्मा को दिखाने या पैसे ले लेते है ना, ₹1 का डिस्काउंट नहीं देते. कह रहे भाई, बिजनेस यार. आप देखोगे इलेक्ट्रिशियन की मदद करता है. ऑटो रिक्शा ड्राइवर खराब हो जाए, दूसरे ऑटो रिक्शा वाले आ जाते हैं. आप एक ऑटो रिक्शा वाले को मार के दिखाओ, 10 आ जाएंगे उसको डिफेंड कर. यू हैव अ फाइट विद वन ऑटो रिक्शा ड्राइवर, मैन, you will have the worst night of your life, right? If you're doing it in Delhi or these places, everywhere, man. I've been to Telangana, I've been to every places. You misbehave with one auto rickshaw driver, 10 people will come and beat you up, है ना. बट विद डॉक्टर्स, एक को मारते हैं बेचारे को, 10 उसके, बल्कि वो कहते हैं इसने कोई गलती करी होगी तभी पिटाई. Now, coming back to the agenda, what is the most common opportunistic infection that occurs due to graft failure after 3 months of kidney transplantation? And you can see a image also present here. Like this is a very characteristic image that is present at this point of time. In fact, I would like to give these images as A versus B. Can you tell me the answer in B, please? Can you yes, can you tell me the answer? Okay, the first one is very clear. Can you tell me the second one, please? Yeah. So most guys are getting it spot on when it comes to option number A, because it is occurring in the first 6 months. Obviously, you know it is gonna be answer as cytomegalovirus. But I would also like to just quickly draw this before you. Like if this is the nucleus, if this is the, okay, if I draw it, try to draw blue only. Give me a second. This is that bluish cell that you can see, and then the dark thing is the nucleus. And around the nucleus, there is a bit of halo also. Like around the nucleus, there is a halo also present. Perinuclear halo is present in the patient. So the basophilic inclusion body is present. That basophilic is that owl eye appearance, that a big eye that you can see. So at this moment, I want to say that if you are able to see a basophilic intranuclear inclusion body, IN stands for intranuclear inclusion body. That basophilic intranuclear inclusion body is a characteristic of that owl eye appearance, and therefore we will be saying that this is cytomegalovirus infection which is contributing to graft failure. But in the second report, they slightly modulated the diagram, and this was INI said, and he said after 8 months this is happening, and then the microscopy finding was different. Like my student said that sir, it was still blue, but then there was a ring. There was a ring of blue. Like you can see the ring of blue in the periphery of this cell. These are neutrophils, obviously. These are neutrophils, but what is present here is the renal tubular cell. What is present here is called as the renal tubular cell. This renal tubular cell is having a ring in the periphery, which is again basophilic. Yes, this is what is called as a decoy cell. This is what is called as a decoy cell. And now the answer will change over to, the answer will change over to BK cell. The answer will change over to, the answer will change over to BK virus. The alternative name for BK virus is called as polyoma virus. So good guys, good going guys. This was like a good input and a healthy discussion that we had regarding two opportunistic infections that can contribute to graft failure after kidney transplantation. The answer will not be on the basis of duration. Obviously, duration is important, that first 6 months is cytomegalovirus, but I just want to say that it's not a guarantee that cytomegalovirus cannot occur after 6 months. It is not a guarantee that cytomegalovirus will not occur after 6 months. So it's not the duration, it is the finding that is present in this particular case, and therefore graft failure is a big time risk. Apart from the graft failure risk, I also want to bring to your attention the aspect related to graft rejection. So one is graft failure due to opportunistic infection, second is graft rejection. So graft rejection can be occurring immediately after surgery. Like this would be even before the surgeon would be closing the abdomen of the patient. That is when this would be happening, immediate or within like first few hours, that the kidney is getting damaged because of preformed antibodies. So he's asked what is the type of hypersensitivity here. So this would be type 2 hypersensitivity. For chronic delayed hypersensitivity, nobody will have an issue because chronic is gonna be like type 4 hypersensitivity reaction. So that is very, very easy. But type 1 is gonna be like ultra fast here. मॉर्फोलॉजी यार इसमें ना वो कई बार इंट्रा न्यूक्लियर नहीं होता है, इंट्रासाइटोप्लाज्मिक नहीं होता है, तो मेनली विल बी ब्लू बॉडी इन द न्यूक्लियस ओनली, एंड साइटोप्लाज्म में कई बार ऐसे एक डॉट हो सकती है, कई बार नहीं भी होती. सो मेन इज इंट्रा न्यूक्लियर इंक्लूजन बॉडी इफ प्रेजेंट इंट्रासाइटोप्लाज्मिक गोल्ड. बट हेयर इन द सेकंड सेल आप देखोगे तो इफ यू लुक एट द टू सेल्स ऑन द स्लाइड टुगेदर, there is no reason why we should mix it up, no, because the first cell is having the dark blue in the center and the inferior cell is having dark blue in the periphery of the cell. So the morphology of the two cells is different. I hope it's clear. Now is the hypersensitivity reaction, which you guys have already answered without me, acute, because there would be a humoral component and cellular component. So for acute, it is both type 2 and type 4. For acute, it is both type 2 and type 4, but for hyperacute, it is type 2 hypersensitivity in a patient. And chronic is pretty straightforward. No, देखो chronic तो nobody will have an issue. That is delayed hypersensitivity, so that would be 4. And the cutoff is a little, I would say, मतलब chronic will usually occur after 6 months, acute will occur usually in the first 6 months, and if it is occurring immediately or in the first few hours, then it is a hyperacute rejection that is occurring in a patient. This is just an artificial cutoff present here. Like for some MCQs, it might be written weeks to months. So you will say acute. And if you say months, then you will say chronic. I mean, there's no ऐसे कोई, there's no Lakshman Rekha like that, no, that beyond this and beyond before this, it's just artificial data that we have created. So it would be weeks to months and months. If it is months to years, then it is chronic. Months to years, chronic. If it is weeks, if it is like weeks, days, weeks, going towards months, then it is acute rejection that is happening in a patient. So there's no fixed line beyond which or before which we can say, and our objective is to basically reduce the chances of rejection by giving anti-rejection drugs to the patient. But yeah, there should be a watch on opportunistic infections that could also be developing. Now, after talking about CKD, I will talk about acute kidney injury. For acute kidney injury, first I would like to handle certain definitions. So you guys will be again commenting here. What is the definition of chronic kidney disease? I mean, normal eGFR, you all know, that is 125 ml per minute. Estimated glomerular filtration rate should be, eGFR should be less than how much? To say that the person is having chronic kidney disease in the patient? Can you quickly let me know regarding what is the answer here? CKD eGFR कितने से कम हो that the person is said to be having chronic kidney disease? Your answer is less than 60 ml per minute. No beta, it is not 20. If the estimated GFR of the patient is, no beta, no, come on, who said 20? If eGFR is less than 60 ml per minute, 1.73 मीटर स्क्वायर बॉडी सरफेस एरिया फॉर 3 consecutive months, अगर 3 महीना लगातार किसी पेशेंट को उसका ग्लोमेरुलर फिल्ट्रेशन रेट 60 से कम रहता है, दैट इज व्हेन वी विल से दैट द पर्सन इज सफरिंग फ्रॉम क्रॉनिक किडनी डिजीज इन अ पेशेंट. But as far as the grading is concerned, the grading does not start from 60. I today taught you now the gradings there, G1, G2, like I will write it fast here also, like G3, G4, and then G5. It will just take maybe 15 seconds for me to write the data. I explained that to you now. The grading deliberately does not start from 60. He says, why should you be wait कि किडनी खराब हो जाए तभी डायग्नोसिस बनाएंगे? अर्ली डायग्नोसिस करेंगे ना, जैसे डायबिटिक नेफ्रोपैथी में तो GFR कैन बी फॉल्सली एलिवेटेड. सो व्हाई शुड वी वेट टू द GFR टू डिक्रीज टू लेस देन 60? फिर यहाँ पे आप डिक्रीज करेंगे 60 to 89. देन आप 30 पॉइंट डिक्रीज करेंगे, दैट इज गोना बी 30 पॉइंट करते हैं तो दिस वुड बी 30 to 59. आई होप यू रियलाइजिंग दैट G3 को मैंने दो भाग में बोला था, G3A, राइट? In earlier I had mentioned the word G3A and G3B. Now I'm just going like G3 standard data. Then is 15 to 29, and then this is less than 15. In the earlier part I had subdivided into 6 categories, but this time I've not subdivided into 6 categories. I've divided into 5. So how can CKD grade 1 patient be labeled as a chronic kidney disease patient? G1, no, I will not say it is CKD word. I will write only when, but that is at risk patient na, so screening should be done. Monitor the patient, screen the patient. Our objective is not to say that, again, it's not a Lakshman Rekha, it's not a straight line that we say this is when the disease has occurred in a patient. That is why if you check out this printout or the handout that I gave to you, and if you've gone through it, तो आप देखोगे मैंने उसमें ये बताया हुआ है screen. No, your query was, sir, how can we write on the case file CKD? I will not say that he is having CKD. I will say he can go into CKD. So at this value, I will say to the patient that you will progress into CKD. So screening is G1, G2. Treatment starts where? This is what we discussed today. Na? That is G3 in a patient. So I cannot write on the case file that you are having G1 CKD. I will just tell the patient that G1 tells us that you are at risk for development. मैं ये तो लिख सकता हूँ ना, G1 is at risk for CKD. That is legally correct statement of mine. G1. No lawyer can challenge the statement if I write at risk for development of CKD. The risk factor and prognosis has been explained to the patient, and the person will then go into G3, and that is when the treatment in the patient. So the point at the moment is, if the question says this handout is like that KDIGO guidelines, if you check out, and now I will speak once again regarding the grades of CKD, which I was explaining to you for like chronic kidney disease. I just revisited the values here, because now we will be talking about acute kidney injury in a patient and then acute kidney disease in a patient also. In acute kidney injury, I want you to put these horizontal arrows to say that the spectrum of disease, just as CKD के लिए I was saying 3 months, na 3 consecutive months, like in April, May, June consecutively, or suppose in May, June, July, 3 consecutive months. If the patient is having, if 3 consecutive months, if the person is having eGFR less than 30, we call it chronic kidney disease in a patient. For acute kidney injury, the time duration, the horizontal duration is 7 days, 7 days, 7 days. And if he says the word acute kidney disease, look at the new term that I'm creating before you. The new term is called as AKD, that is acute kidney disease in a patient. For acute kidney disease, the time frame, अगर वो सिर्फ आपको time frame में पूछता है, then don't answer 7. Write it in this fashion that it cuts through the 7 days. Then for acute kidney disease, you will say that the damage should be progressing over 30 days. These are artificial cutoffs that have been created so that we are able to at least monitor the patient and then say that the kidney is damaged. Nobody said single visit you will diagnose kidney disease. Nobody said single visit you can say CKD in a patient. You need to monitor the patient over a period. So at this particular point of time, I hope it is clear for the duration. 3 महीना, 7 दिन, and then 30 days are the definitions for the span of illness. Acute kidney injury, acute kidney disease, 7 days, 30 days, and CKD is more than 3 months. In the light of this data, now the kidneys are screaming for help. So let us look at, like, when will we say that the kidneys of the patient are getting affected? What are the functional criteria? And the functional criteria will revolve around the values of serum creatinine and urine output. I'll come back to this slide once again. I'll speak about this functional criteria once again, but let's put some mathematical inputs at the moment. So I want you to now note information with me. When do you say stage 1 of acute kidney injury? This that I'm teaching you, this that I'm teaching you is definition of acute kidney injury. This that I'm teaching you is definition of acute kidney injury. When will a doctor write on the case file that his patient is having stage 1 of acute kidney injury? When the serum creatinine of the patient rises to 1.5 to 1.9 times above the baseline. And what is the baseline value? It is usually taken to be 0.8 to 1.2. So serum creatinine of the patient rises by 1.5 to 1.9 times above the baseline. Then I will say that the patient is having a possibility of stage 1 acute kidney injury over a duration of how much? Over a duration of how much time? Now I want you to pause and listen to me very carefully. I'm saying 1.5 to 1.9 times rise over the baseline over. If I tell a non-medico दैट 7 days के बाद बताऊंगा तो बोलेगा क्या बात कर रहे हो सर, 7 दिन के बाद बताओगे कि किडनी खराब हो गया, 7 दिन के बाद में डॉक्टर साहब बताओगे? तो ऑब्वियसली लाइक इफ आई मॉनिटर द पेशेंट और 7 days आई कैन इवेलुएट. आजकल तो पेशेंट्स वांट अर्ली डायग्नोसिस ना, सो यहाँ पे जो आप क्लासिफिकेशन में नोट करोगे उसमें उसने बोला है कि आप वेट मत करो 7 days के लिए. वो तो डेफिनेशन के लिए भाई 7 days हमने बोल दिया है, बट एक्चुअली में वी वांट टू डू अ डायग्नोसिस फास्ट. सो सपोज लेट मी से लास्ट वीक व्हेन आई मेट यू, दैट इज व्हेन दिस गाइस creatinine was 1 and today his serum creatinine is 1.8. That means his AKI has started in the patient. I repeat that again. 48 hours have passed, more than 48 hours have passed by before my last class with you. Now you had intervening classes also. So suppose last week the guy's serum creatinine was 1 and today it is 1.8. More than 48 hours have passed by. So over 48 hours or like, a little more than that, then I will say it is starting of acute kidney injury. How much is normal urine output per hour? Can you comment in the chat box how much is normal urine output per hour? Normal urine output per hour, it will be 1 ml per kg per hour. Normal urine output is 1 ml per kg per hour. For a 60 kg person, it would be 60 ml per hour. You multiply by 24, this would be in the range of about 1500 ml. So normal urine output is 60 ml per hour. And if the urine output decreases by 0.5 ml per kg per hour, that is 50% of normal. That is 50% of normal for 6 consecutive hours. We will say that the patient is having stage 1 of acute kidney injury. 50% normal. That is stage 1 of acute kidney injury. When I say stage 2 is unlikely to be asked in the paper simply because here most doctors will never ever get this wrong. It is a rise of serum creatinine to at least 2.9 to 2.9 times above the baseline over the previous. Rest of the data is the same, above the baseline over the same 48 hours. Everything is same, but the creatinine values are rising to doubling and even the urine output is reduced by half. So I don't think so. Only out of sheer carelessness can somebody mess up between stage 2 of acute kidney injury because it is a doubling. Urine output is half over 12 hours. Stage 3 is also very unlikely to be asked क्योंकि यहाँ पे serum creatinine will rise by more than 3 times above the baseline. Everything else is the same. Rise above the baseline over 48 hours and the urine output will be decreasing here by 0.3. If you look at the table here, it's not 0.5, it is 0.3 ml per kg per hour for 24 hours. So I don't think so that in the paper he will bother you with stage 2 and stage 3 क्योंकि उसको कोई गलत कर ही नहीं सकता है. It is just carelessness जिससे कोई इतना भूल जाए कि यार डबलिंग के equal to or more than this होगा और यहाँ पे 3 और 3 लिखा हुआ है तो and also 0.3 लिखा हुआ है. So I don't think so that the examiner will put up this data for you to consider at all. What he will ask you is stage 1. वो पूछेगा क्या आपसे मेरे ओपिनियन में, तो he should be asking you regarding like stage 1 and obviously understandable stage 1 because I want to go for early diagnosis in a patient. So the statement to be remembered is stage 1 of acute kidney injury is what I've highlighted at the moment. That is 1 to 1.9 times of serum creatinine over the baseline over 48 hours and the urine output is down to like less than 50% of normal over 6 hours. This is the data, guys. This is the data which is to be remembered. Now today I have a person who is studying in IIT. His dad is admitted in our hospital with acute kidney injury. He says, sir, you need 48 hours for diagnosis. He says, sir, you need 48 hours for rise of serum creatinine. For urine output, you're saying 6 hours of creatinine rising is like 48 hours. So I told him creatinine rises slowly. No, he says, sir, why you are taking this value aside, sir, creatinine rises slowly. So he says, sir, don't you have any test available apart from this? Can't you have a biomarker? Like I read that you doctors are doing a lot of research and you are having biomarkers for myocardial infarction. So if it is biomarker, If it is a biomarker which is present, yes, biomarker of acute kidney injury. Yes, guys, quick answers, please. Biomarker. This particular guy, he says, docs, like, why should I wait for like 48 hours for creatinine to rise? I appreciate it rises very, very slowly. So, what is the biomarker of acute kidney injury? I'll wait for your answers at the moment. Just like your biomarker for MI, you have a biomarker for heart failure, no? Pro-anti-BNP biomarker for AKI. What is the biomarker of acute kidney injury? Exactly, exactly. Rajesh and Ipsita were the first ones to answer there, including cystatin C. Very good. So the biomarkers that we can use in this patient is Kim1, not Kim Jong, right? That crazy nuclear guy. Just Kim1. It is called as kidney injury molecule 1. We can check this in the urine of the patient. This is specially elevated in case the person is having damage to the tubules, and they tend to become elevated in the first few hours of kidney damage. So Kim1 is a very good answer. Another one is by the name of, yes, very good, cystatin C. Another one is by the name of NGAL. So I'll write the full form of NGAL also. The full form of NGAL would be neutrophil gelatinase associated lipocalcin. Why, in my opinion, will the examiner ask you this is because when you read the name, it looks like as if it is some test related to immunity, but it is not a test related to immunity. It is rather a test related to kidney damage, the tubular damage, neutrophil gelatinase associated lipocalin, interleukin 18, and yeah, one more is cystatin C, which I would like to write here. So what I wanted to say at this moment before you is that biomarkers of acute kidney injury are gonna help in like early diagnosis. Cystatin C is again what is produced from all nucleated cells in the body, and it is like lost in the urine. So we can check these products. Like you can read questions that might say urinary NGAL. So the normally when you read the word urinary NGAL, it looks like some test for immunity, some test for maybe pyelonephritis diagnosis, but no, it is a test of tubular damage in a patient. Yeah, osteopontin is another one. Yeah, the entire list is fairly extensive, guys. But I'm talking about like what I wanted to say was that why should we wait for this long? For early diagnosis, we should be able to identify on the basis of biomarkers of acute kidney injury is what I have currently highlighted. Another question that I would urine sample. In the urine sample, na, just like we check urine में sodium, we check urine potassium. Similarly, these biomarkers would be checked also. So these are indicative of damage, tubular damage, and that's why the positivity comes in the urine of the patient. Then what is the best method to calculate the GFR? If the question says what is best, you have to note this on this slide only. This is page number 144 on which you will note it. If he says what is the best method to calculate the glomerular filtration rate? No, beta, that FINA will come later. That is for differentiating between pre-renal and renal variety. Sai, the point that you wrote, that is for differentiating between the pre-renal and the renal variety. At the moment, what is the best function to calculate the glomerular filtration rate? So the best method for calculation of GFR would be answered as CKD, EPI. Yeah, very good, very good. Inulin, I was waiting for that. And actually, I wanted you to say that because physio में तो वही बताते हैं. Now, when you will call a lab and you will say कि मुझे ना सर वो ना inulin clearance करवाना है. When you will call a lab and say कि सर मुझे ना inulin clearance करवाना है, तो बोलेगा हैं ये क्या होता है? We have never heard about it. Sir, inulin clearance is looking very attractive option in the MCQ from physiology perspective. But if they will give you a MCQ in which both of these are given, then your practical answer is CKD EPI cystatin C method. It's an online calculator. Even while listening to me at the moment, if you just Google or put in ChatGPT or anywhere else, a formula, complicated formula will come where you will put various parameters. What are the parameters? Standard ones. Age of the patient, gender of the patient, right? Age of the patient, gender of the patient, weight of the patient, race of the patient, serum creatinine, cystatin C. You don't need to remember these names here. You don't need to remember the names of these parameters. I wanted just to give you an idea regarding the fact that there's an online calculator in which you are able to feed the age, gender, weight, race, creatinine, cystatin C, and you are able to calculate the GFR. So the best method to calculate the GFR is CKD EPI cystatin C method, and that's also called as creatinine clearance. In government hospital, because we don't have like too much of facilities for CKD EPI, like online calculator is like now app and internet connections are there. So lots of time we do another test that is simply called as 24-hour urine collection, and we go for creatinine clearance in a patient. So creatinine, I agree that physio teacher will say creatinine clearance is having a bias and inulin is best. So suppose if I give you a question from physiology, suppose I give you a question from physiology where it says creatinine clearance, inulin clearance, urea clearance, glucose clearance. If this is a hardcore physiology question like this, and between the four you have to select and you answer it as inulin clearance, I am okay. Between the four options that I just explained to you, if you say that boss, the question was creatinine, inulin, urea, and all those typical physiology questions, and you say that the answer is pH. Yes, one more pH, right? That's another one, pH. Instead of glucose, I can write it. A good input you said, right? Glucose. One option can be pH, that is hippuric acid, no? Para-aminohippuric acid, pH clearance. So if it's a hardcore physiology question and you say that what is the best way for identification between the options I wrote here, I'm okay with answering as inhaled clearance. But otherwise, practically speaking, what do we do? Practically, we go for CKD, EPI, cystatin C method in a patient. Now, I will be expecting you to calculate the GFR for me. This is like a child, and you will be using Schwartz formula, like pediatrics being revised at the moment, pediatric nephrology being revised, Schwartz formula. The question said calculate GFR of this 4-year-old child. He mentioned he was 100 centimeter in height, because in children when we do anthropometry, we take height also and we take the weight also. So I think the weight given of the child was something in the range of about 12 to 16. So let's take like a value of 12 kg. Height of the child is 100 centimeter. Normally Indian children have height of like 100 by 4.5 years, and the serum creatinine of the child is today 1 milligram. The question is open to all NEET PG and INISET aspirants. For FMG students, you can just take a breather at the moment while I'm discussing this numerical based question. In FMG exam, usually I've not seen any numerical based questions. They just ask you fact wale questions. But in NEET PG and INISET, they make you calculate numerical. So you can take a breather for a second. And yes, guys, next 1 minute you can relax. Remaining people, please, can I have the answer to this particular question's mathematical value? In Schwartz formula, you will take into kappa. I will tell you the value of kappa. You have to put the height of the patient. You have to put the serum creatinine of the patient. Absolutely. The value of the kappa is taken to be 0.41. Height is 100 centimeter and serum creatinine is 1. If you put this, you will notice that the GFR will come at 41 ml per minute. This has not been asked in FMG exam, so my humble request to you guys, please don't bother yourself with numerical based questions. Just skip them and let them go. But yeah, I just need to be making you aware that these kind of questions are very much there. I mean, they exist on the planet, right? So just don't bother yourself with the mathematics there. But yeah, the mathematics that is asked is never rocket science. If you're doing some complex mathematics, some rocket science, that means your thought process is wrong. It is one step multiplication or it is a one step division. There's one step multiplication, one step division. And this that I've currently described before you is basically called as Schwartz formula. Schwartz formula is used in children to calculate the glomerular filtration rate, that is kappa into height divided by the serum creatinine of the patient. Otherwise, the standard data is the online calculator CKD EPI cystatin C formula. At this moment, I have introduced you to both the concept of CKD as well as AKI, acute kidney injury. One more term, चलो अभी पहले questions कर लेते हैं, उसके बाद I'll introduce that term. Acute kidney injury is overall the number one cause of ICU admission, guys. I mean, most patients who are admitted to ICU, two diagnoses will be there. Either it will be sepsis or it would be acute kidney injury in the patient. And most of these patients, because they go into kidney injury, they'll end up with anuria, which is defined as urine output less than 100 ml per day. Oliguria is less than 400, but anuria would be less than 100. Then is what is the most common type of acute kidney injury? It is pre-renal variety, that is perfusion of the kidney will be less. Acute kidney injury of the pre-renal variety is where the perfusion of the kidney will be substantially reduced. The best example of perfusion of the kidney being reduced is like now summers have come, so children can suffer from cholera. And if cholera child is not given ringer lactate on time, then he can go into a renal shutdown in a patient, or a bleeding patient, bleeding varices. He pukes too much of blood, under perfusion of kidney will result in development of pre-renal variety. What is the fluid that is used in these patients? Well, standard normal saline is the fluid that is used. So one more indication for normal saline has been added to your vocabulary. At this moment, I also want to say that pre-renal variety is overall the commonest type of kidney failure that we see. What are the causes for a pre-renal variety? Most of the time, renal shutdown will be seen in patients of burns because they lose plasma from the skin. Or instead of burns, I can put up a complication like acute pancreatitis where you can have a third space loss. I mean, pancreatitis can cause ARDS. It can cause a third space loss into the parietal cavity. So the perfusion of the kidney will be less. So burns, pancreatitis, yeah, okay, yeah. Very good. Painkillers, right? I can mention name of painkillers also. Now, any patient with underperfusion of the kidney, I'm not supposed to use any kind of painkillers because prostaglandins help in maintenance of GFR. Prostaglandins help in maintenance of GFR. If you use a COX-1 inhibitor, you are inhibiting prostaglandins which help in maintenance. So NSAIDs can result in development of acute. Normally we read about NSAIDs causing gastritis. We read about NSAIDs contributing to epigastric pain and erosive gastritis. I am saying they can cause a renal shutdown in a patient. So burns, pancreatitis, painkillers, any drug that interferes with prostaglandin production can contribute to this kind of a scenario. Obviously, then the routine tropical diseases would come in: diarrhea, cholera, bleeding. Those are the easier ones that we can comprehend for the pre-renal variety of acute kidney injury. But now I would also like to use this opportunity to mention a renal cause of acute kidney injury in front of you. And this renal cause of acute kidney injury, this renal cause of acute kidney injury is because of a bacteria which we call as a superbug. So today what has happened is that this particular individual, he went to a local sandwich shop. The sandwich shop is using poor quality mayonnaise and is also using chicken which is stale, or maybe the sandwich was made yesterday and is being sold today. It is so hot and they're selling that chicken sandwich dish even today. A person will suffer from E. coli infection. This person had a sandwich from a local restaurant. रूटीन पैटीज बेचते हैं ना, पैटी बेचते हैं, चिकन बेस्ड डिशेज बेचते हैं नॉन वेज वाली. समर में नॉन वेज खाना वो भी ऐसे लोकल पॉइंट से, तो मतलब बेवकूफ़ी वाली बात है. मतलब nobody should be trying and doing that experimentation because half the time these vendors, they don't have any sense. They just keep कल का खाना आज में भी and they sell it in the market, and these cold sandwiches which are present, we think they're okay. You take one bite into it, you know the taste is bad. I mean, one should not be eating it and trying an experimentation. So this guy got infected with E. coli O157H7 that will cause acute dysentery. And when he came to the doctor initially, like the doctor was not aware that this guy got infected with E. coli 0157. So he gave him standard fluoroquinolones. Fluoroquinolones can be like norfloxacin or ofloxacin. So some antibiotic was given to the patient. Now the bad news is that due to this bacteria, at this moment you can stop noting for a while and listen to me. This bacteria produces a toxin by the name of Shiga. And this Shiga toxin activates the complement system. And due to the activation of the complement system in this patient, the following things actually begin to happen. One is that the complement system starts attacking self RBCs. The complement system starts attacking खुद के RBCs, and because of the complement system activation, in fact इसको थोड़ा और elaborate करता हूँ. When the complement system is activated, what happens is that there can be formation of microthrombi in the circulation, in the microcirculation of the body, especially in the kidney. The complement system activation can result in microthrombi. This microthrombi in the renal circulation or the renal microcirculation are the cause of concern. So you can imagine this to be like a mesh. ऐसे मान लो एक जाल सा बन गया, माइक्रोथ्रोम्बाई का जाल बन गया in the blood vessel. It's like this. And then this is the red blood cells. These are the red blood cells. They are basically coming and they're smashing into this jal. It's like a mesh microthrombi in the renal circulation. RBCs are smashing into this mesh of microthrombi. So the surface of the RBC will get scarred. So when you draw the RBC now, I wanted to draw it in a little irregular fashion to show that due to friction, there was scarring of the surface of the red blood cell, scarring of the surface of the red blood cell. And the second time possibility is that some of the RBCs will die. While they are traversing here, you can see that I've shown a RBC which is not a sickle but is a schistocyte. It has that peculiar appearance that I've shown. So in a peripheral smear, the question will be easily solved because peripheral smear in this patient will be given in the form of schistocytes or in the form of burrs in the patient, burst cells in the patient. So microthrombi are occurring in the renal circulation. Microthrombi are occurring in the renal circulation of this patient. Due to this microthrombi, one of the manifestation that is currently evaluated is that RBCs are getting destroyed in the small blood vessels. So one, he will use the word microangiopathic. You can see small, because I'm saying the word microcirculation, so microangiopathic. And the RBCs are getting destroyed. So one, in hemolytic uremic syndrome, hemoglobin of the patient will begin to fall. The hemoglobin of the patient was healthy 15. But after a few days of taking this medicines, that is fluoroquinolones, now the hemoglobin of this patient has suddenly dropped to, let me say, 7. And the relatives are arguing with you. वो कह रहे हैं कि your medicines have caused this side effect or drop in hemoglobin. Now it's very difficult to convince them. वो बोलेंगे आपकी दवाई से रिएक्शन हो गया है. Our patient took fluoroquinolones under your care, and our patient has developed a hemoglobin drop, and because of this hemoglobin drop, he is admitted. He's totally white, he's totally pale. In fact, sometimes he can go into heart failure also because of the severe anemia. And you are medical students, you are doctors. I can explain to you that this is what is complement, what is Shiga toxin, and what is damage to microcirculation. Non-medicals simply refuse to acknowledge that there is a problem. बोलते आपकी दवाई का रिएक्शन हो गया, and becomes a very unpleasant situation while handling these patients of hemolytic uremic syndrome, which are at the moment causing H, that is hemolysis. H, that is hemolysis. The second thing in this patient would be that there could be occlusion of the microcirculation because of the microthrombi. So the second thing that I'm writing in this particular case is that there will be a drop in the GFR also. Whenever the renal vasculature is damaged after the Shiga toxin is damaging the renal microvasculature, it's in the kidney, the renal microvasculature is getting attacked. So whenever renal vasculature is damaged by the complement, GFR will become less. When GFR will become less, one, the RAS system will be activated. So one, this guy will be having very severe headache, and that's gonna be hypertension. So the relatives will again say कि आपके दवाई का side effect है. And more importantly, the patients, because GFR is less, will go into oliguria and anuria. So all the onus will be on you to explain to them that this particular patient is going into uremia के symptoms. उसको uremic pericarditis, uremic encephalopathy. Urea is a toxin, so it accumulates in the body spaces. It irritates the stomach, so vomiting चालू हो जाएगी. And all these manifestations that I've described at the moment before you are the main reasons why I've gone into the topic here at the moment. I'll say the main reasons once again, just as a quick recap into hemolytic uremic syndrome. The first word I wanted to pick up in the MCQ is not dysentery. That dysentery history may or may not be given. But what will be always given in the question somehow will be the word MAHA, or the word written will be Coombs negative hemolytic anemia. Either of the two words, when you pick up in a question, especially in a person who's had like a history of a sandwich consumption previously, and there's a Coombs negative, the word is Coombs negative hemolytic anemia, because like auto antibody nahi hai. Auto antibody nahi hai. And along with the H component, there is a U component present, uremia. How will he will not write uremia. He will say anuria, hypertension, decrease in the kidney function of a patient. This means that the person has gone into hemolytic uremic syndrome. In this condition, you have to stop antibiotics, guys. In this condition, if you continue antibiotics, the mortality rate is even higher. Mortality rate increases 17 times when you give antibiotics for this superbug, because when you kill the superbug, more of this toxin that comes in the circulation by killing it actually worsens the situation. This is the first time ever that I am teaching you that don't give antibiotics in infection. Otherwise, whenever I'm discussing a topic with you, I say always, man, give antibiotics to the patient. But here we are not giving infection is there, but we are giving antibiotics. We are stopping antibiotics. So how will we remove the toxin? How will we remove the toxin in the patient? The toxins will be removed by doing hemodialysis. When I will do the hemodialysis across the filter, we can lose the Shiga toxin from the body and the patient will begin to improve. This particular patient is said to be having what is technically called as D positive HUS, that is dysentery positive hemolytic uremic syndrome. If you say, sir, can't you give me a shortcut to remember it? Then yes, in this question, there would be mention of what couple of people were commenting also, and I'll just reinforce that statement. Like suppose you say, sir, I may not remember this information. Can you tell me how to crack this question? Then the keywords which I would like you to remember are like the word Helmut cells. The words I want you to remember are like schistocytes or Burr cells, and they would make it like your life easier. That especially in a kidney topic, if Helmut cells are given, if schistocytes are given, then you have to think in terms of the topic that I've currently highlighted before you. That is hemolytic uremic syndrome, written as D positive HUS. The peripheral smear makes life easier. I mean, if he gives you Helmut cells, schistocytes, I mean, I was trying to prepare you for that medicine question. ना पैथो में तो बस इतना बोलेंगे शिस्टोसाइट लिखा तो HUS बोल देना. अगर इतना ही आसान होता तो यार लोग स्लाइड पकड़ लेते ना. लोगों को नहीं समझ में आता स्लाइड में शिस्टोसाइट कैसा है. image that they will show you is like very fancy image of schistocyte ना, that is at maybe 40 or 100x. They give you a 10x magnification, उसमें नहीं पता चलता लोगों को. You got my point, right? 40x and 100x magnification, they show you this cell, anybody can pick this up. But from that sea of cells at 10x, normally the low power we use 10x only. You see so much sea of so many RBCs, उसमें ढूंढना मुश्किल हो जाता ना. तो that is when the लोग fumble, that is when people fumble के साथ smear तो समझ में आया नहीं, diagnosis भी नहीं आया. That is why I mentally prepared you to the fact that even if you're not able to interpret the slide, you still should be able to get the question right on the basis of the combo of the findings that I've highlighted before you. MAHA, Coombs negative hemolytic anemia, and the renal shutdown that occurs after the so-called chicken sandwich or like poor quality sandwich that was consumed by a patient. This condition needs aggressive treatment with hemodialysis, by which the kidney function will come back to normal and the toxin will also be removed from the body. And like since I said hemodialysis, what are the indications for hemodialysis? We will just revisit hemodialysis again, but in a different way. The indications for hemodialysis are AEIOU. AEIOU stands for metabolic acidosis, which is refractory. Like if acidosis pH is less than 7.1, if pH is less than 7.1, I will plan hemodialysis. Though standard treatment for metabolic acidosis is soda bicarbonate. Standard treatment for metabolic acidosis is soda bicarbonate. But in this case, like if the pH is low, then yep, I would be doing dialysis. E is electrolyte imbalance, but check out the word refractory hyperkalemia. I said that even yesterday. Refractory word should be written. If refractory word is not written, your answer will be calcium gluconate followed by insulin drip followed by salbutamol nebulization. Answer drugs. If only he says the word refractory hyperkalemia, that is when we'll be using it. Then for intoxications, like, for example, amitriptyline toxicity, any drug toxicity. So it like I'm trying to keep the discussion broad. Like if a patient has taken overdose of sleeping pills, then or amitriptyline, then I can be doing hemodialysis in a patient to get rid of the drug from the body also. Then is fluid overload. He may not write fluid overload. He may say heart failure, which is refractory to diuresis, because kidney failure causes retention of water in the body. So O will stand for overloading of water in the body, because kidney is a state where there is overloading of the circulation. And then was obviously the standard questions that I discussed with you. Uremic pericarditis is more important than uremic encephalopathy. So I'm putting double arrows in front of pericarditis, a single for encephalopathy. That question I've already done with you. दैट अगर पेरिकार्डिटिस भी लिखा है और एनसेफलोपैथी भी लिखा है तो क्या मार्क करके आओगे, तो आपका जो मार्किंग होगी दैट विल बी पेरिकार्डिटिस. लेट्स रिवाइज AEIOU. A stands for metabolic acidosis with pH less than 7.1. That means we have already tried everything including soda bicarbonate. E stands for electrolyte imbalance but not hyperkalemia, it is refractory hyperkalemia. Then I is for intoxications, that is drugs. Then is O, the fluid overload, which is like, the expansion of the plasma volume due to RAS system in a patient. And then is U, that is uremic pericarditis and uremic encephalopathy. So this is like a broad general statement how we remember indications for dialysis in a patient. आप लोग कमेंट कर देना चैट बॉक्स में, अगर डायलिसिस एक बार करना है, बार बार करना है तो सिमिनोब्रेस्टिया फिस्टुला. सपोज डायलिसिस हैज टू बी डन ओनली वंस और ट्वाइस और मे बी थ्राइस, AKI के पेशेंट में वंस ही करना है. आई एम पुटिंग द फिंगर ऑल्सो फॉर लाइक वेयर वुड यू डू द डायलिसिस फ्रॉम. कैन यू टेल मी व्हाट इज द एक्सेस साइट? If hemodialysis has to be done for whole life of the patient, we will be taking Seminobrestia fistula, non-dominant hand, radial artery, cephalic vein. Excess site for hemodialysis, excess site for hemodialysis in acute kidney injury, because here I don't need to do dialysis again and again in a patient. Maybe once, maybe twice, and everything would be fine. So we will take a access into the jugular vein. No, beta, we will be using internal jugular vein. The preferred one is internal jugular vein. We put a double lumen catheter. उसी डबल लुमेन कैथेटर से we can remove the impure blood and we can remove the clean blood. So access site for hemodialysis in acute kidney injury, क्योंकि वहाँ पे जिंदगी भर तो डायलिसिस करना नहीं है ना, आपको एक या दो बार करना है, तो we will put the double lumen catheter into the jugular vein and hemodialysis can be done. But yeah, if the dialysis has to be done again and again and patient goes into CKD, then we will have to plan it by creating a fistula, which will require a surgeon's support, and at least 4 weeks for harvesting would be required in these patients. Now comes the aspect of what couple of guys were commenting as FINA. So मैं पहले explanation दे देता हूँ और उसके बाद में आपने question में answer करना है. There is two types of renal failure, guys. One is called as the pre-renal variety, that is where the blood supply to the kidney is less. And second is like the renal variety, where there can be like damage to the tubules of the kidney, like there could be tubular damage in a patient. In a pre-renal variety, what will happen is that the blood supply to the kidney will become lesser. Listen, hear me out for 30 seconds and you will get a hang of it. The perfusion of the kidney will be less. If perfusion will be less, so जो ultrafiltrate होता है, like suppose this is the glomerulus, this is afferent, efferent, this is glomerulus, this is tubules. So body क्या करेगी? तो body will try to conserve. You see, if you are having dehydration, if you are having under perfusion of the kidney, what will the body do? The body will try to conserve the sodium, body will try to conserve the salt. So whatever salt is present here, all the salt will come back here. So I'm just drawing a thick arrow to say कि जितना भी salt है वो वापस खींच लिया, जितना भी salt है वो सारा का सारा सॉल्ट जो है हमने वापस खींच लिया. पानी भी खींच रहे हैं क्योंकि भाई पानी की कमी हो गई है शरीर में. जैसे डायरिया वाला बच्चा है, तो डायरिया वाले बच्चे में फिजियोलॉजी क्या करेगी? इट विल ट्राई टू गेट बैक ऑल द सॉल्ट इन द वाटर. नाउ लेट अस टेक अप दिस सिचुएशन वंस अगेन. मान लो ये टिब्यूल्स हैं, दिस इज सॉरी, ये एफरेंट और इफरेंट आर्टिकुलर ग्लोमेरुलस है, एंड दिस इज द टिब्यूल्स ऑफ द पेशेंट, एंड अनफॉर्चुनेटली द लाइनिंग ऑफ द टिब्यूल्स इज डैमेज्ड. इफ आई जूम इन, आई एम सेइंग दैट द लाइनिंग ऑफ द सेल्स, ये जो यहाँ पे सेल्स होते हैं, इन सेल्स का काम होता है वाटर का एब्जॉर्प्शन, सॉल्ट का एब्जॉर्प्शन. इन सेल्स का काम होता है कि सॉल्ट एंड वाटर की एब्जॉर्प्शन करेंगे. बट नाउ पुटिंग अ क्रॉस क्रॉस टू से कि अनफॉर्चुनेटली ये जो सेल्स है ना, ये डैमेज हो गए. These cells have got damaged. If these cells will get damaged, then they will not be able to absorb the salt and water. तो सारा का सारा जो salt and water है वो यहीं से निकल जाएगा. So I'm just drawing a arrow here to say, like I've drawn a green arrow to say कि अब salt absorb ही नहीं हो पाएगा. Salt will be lost in the urine of the patient क्योंकि absorb ही नहीं हो पाएगा. I'll just compare the two diagrams. In one, I was saying if somebody is having pre-renal variety, perfusion of the kidney will be less. If perfusion of the kidney is less, what will happen is that the body will try to conserve salt and water. But suppose I introduce a technical term before you by the name of acute tubular necrosis. In acute tubular necrosis, as you can see in the diagram, there will be loss. There is a salt loss from the body. The reason for that salt loss is explained as because the tubules are damaged. They are not able to retain the salt and water in the patient. Based on the explanation that I mentioned here before you, my question is very simple and I want everybody to participate and answer in the phases I mentioned. My question to everybody is, and I want everybody to participate here. If you're thinking FMG students, if you're thinking आपके एग्जाम में नहीं आया तो ये आपके एग्जाम में भी आया हुआ है. अगर आप कहीं ये सोच रहे हो ना कि मैं सिर्फ आपको नीट पीजीआई नीसेट का बता रहा हूँ, नो गाइस, दिस क्वेश्चन हैज कम इन योर एग्जाम आल्सो. He asked you to differentiate, and the parameter that we are checking is urinary sodium. So please comment in the chat box. I would like answers here for pre-renal variety. Pre-renal variety, I'm calling it A. In pre-renal variety, what will happen to urine sodium? Will it be high or will it be low? Can you comment in the chat box? A lot of people, Pranav, Sai, you have already answered. Great. For all others who are still passively listening to me and putting the effort of coming up here, what is going to happen? Will you have high urinary sodium? Will you have salt which is going to be low? Because everything is coming back. ना सब तो आप खींच लिए, suck back कर लिए. तो urinary sodium in the patient will be low, and this is written in some MCQs as FeNA, fractional excretion of sodium less than 1%. But if I look at point number B, if I look at point number B of the discussion, I'll make it a little smaller. If I focus at point number B of the discussion, tubular lining ही खराब हो गई. अगर tubular lining ही खराब हो गई तो तब यहाँ पे salt absorb ही नहीं हो पाएगा. The salt loss will be occurring because I'm focusing on the word salt loss. तो यहाँ पे मैं आपसे पूछ भी नहीं रहा हूँ कि क्या होने वाला है. यूरिनरी सोडियम ऑब्वियसली हाई होने वाला है क्योंकि salt loss लिखा हुआ है. That is why the FeNA in the patient will turn out to be more than 1%. And that is the main concept that you need to identify, that we want to differentiate pre-renal from the renal variety. और अब इस क्वेश्चन को कर लेते हैं. बहुत ही सिंपल सा ही था कि चाइल्ड प्रेजेंट्स विद डायरिया विद सिवियर डिहाइड्रेशन एंड ओलिगुरिया. सीरम क्रिएटिनिन इज 4, तो 4 तो हो गया, तो मतलब ट्रिपल से भी ज़्यादा हो गया, तो एक्यूट किडनी इंजरी तो हो गया. फिर उसने क्या करा, यूरिन कर दिया, ऑस्मोलैरिटी ऑफ 700 एंड यूरिनरी सोडियम ऑफ द पेशेंट वाज हार्डली लाइक 12 मिलीक्यूलेंट्स. तो पहले तो मैं आई वुड लाइक टू जस्ट शेयर अबाउट द यूरिन ऑस्मोलैरिटी एस्पेक्ट ऑल्सो. I want answer as A or B. मुझे बताना which of the two conditions will be having very high concentrated urine. Which of the two conditions will be having concentrated urine and which condition will be having dilute urine. Remember, जब salt absorb नहीं होता है तो फिर salt के साथ पानी भी रहेगा, और जब salt absorb हो गया तो सारा पानी खींच के ले जाएगा. Please comment in the chat box which condition will have concentrated urine. वेरी गुड गाइज. आप ऐसे सोचिए ना, गर्मी का मौसम है, अगर आप पानी कम पीते हो तो यूरिन थोड़ा डार्क आता है ना और कॉन्सेंट्रेटेड आता है. वैसे यहाँ पे तो प्री रीनल हो गया, तो पर्सन का जो यूरिन होगा वो कॉन्सेंट्रेटेड होगा. तो यूरिन ऑस्मोलैरिटी इन दिस विल बी मोर देन 500. I hope everybody has understood this. The answer is A. As for the question that I raised, urine concentrated will be more. If you've not understood it, please let me know. बाद में मत बोलना, because then it becomes difficult to come back. Yes, I think everybody has answered correctly. If anybody is having an issue, please let me know. I'll explain this again. सर मैं I'll say this in हिंदी first so that if you have not understood it, सर गर्मी में आप पानी कम पीते हो तो भाई यूरिन थोड़ा डार्क आता है ना, कॉन्सेंट्रेटेड आता है। इसको तो किडनी शट डाउन हो रहा है, इसका बॉडी जो है वो पानी खींचे जा रहा है, तो यूरिन बहुत कॉन्सेंट्रेटेड आएगा, गाढ़ा आएगा। सो द यूरिन ऑफ दिस पेशेंट विल बी सुपर कॉन्सेंट्रेटेड। सो वेन एवर यू डील विद अ पेशेंट ऑफ प्री रेनल वैरायटी, एट दिस मोमेंट इट इज प्री रेनल वैरायटी टू बी रिमेंबर्ड, द यूरिन विल बी गाढ़ा, concentrated. This is the words to be remembered. Urine will be concentrated and the urinary sodium in the patient will be low. वो उल्टा चलेंगे, sodium will be low and at the same time, क्योंकि सारा तो salt आप वापस खींच लिए, तो urinary sodium in the patient will be low but urine will be concentrated, it will be gaढ़ा, and that is what is given in this question. What the examiner is trying to do here is he's given mathematical values, but the interpretation of these mathematical values is urine is concentrated and the urinary sodium of the patient is low, and the moment you identify that the urine is concentrated more than 500 and the urinary sodium is low in a patient, don't FINA will make it very easy na, percentage then to kya baat hi kya hai? If questions were so simple that he mentioned FINA less than 1%, FINA more than 1%, things would be super easy, then everybody will be able to answer the question. The point in this question is, what I have said is, after diarrhea in a patient, after diarrhea the urine is concentrated and urinary sodium is low, so what is the type of renal failure here? Then I hope everybody could pick up that the answer in this question is option number A, that is the pre-renal variety. What is the rationale to be used? If you say sir मुझे 15 सेकंड में क्वेश्चन सॉल्व करना कैसे होगा, मैं सिर्फ ये कह रहा हूँ कि अगर यूरिन कॉन्सेंट्रेटेड होता है तो वो सिर्फ प्री रिनल वेरियम में होता है। सर बर्न एंड क्रिएटिन रेशियो नॉट रिलायबल, वी गेट इनटू दोस मैथमेटिकल वैल्यूज, इट विल जस्ट मेक आवर लाइफ मिजरेबल। Just focus on two things. It is urinary osmolality and urinary sodium. If you want to keep it simple, obviously there's a 5-point table, sir. If I get into the 5-point table, at the end people are not able to solve the question. So what is the aspect to be remembered? That is, the urinary sodium in the patient should be low. Why? Because सारा salt वापस आ गया and the osmolality should be high. Exactly. Kirti, you said it very well. Ankit, you said very well. A lot of you should type these words: concentrated urine with low urinary sodium. If you do that, you will be able to remember this information better कि दोबारा पढ़ने की जरूरत नहीं पड़ेगी. Hypovolemia, yeah, Pranav, you're right, spot on. Cardiogenic shock can cause perfusion issues in a patient. So yeah, this could be a trick question also, but usually they don't get into that much of trick aspects there. The aspects are like straightforward at this particular pattern. Exactly, very good. 146 is sorted. We come to 147, which is again a question, because acute kidney injury is like a topic where they will give you cases. This is a electrician who's admitted to the emergency room with a burn and passage of red color urine. The lab shows increased CK-MM levels with serum creatinine 4, which will not be seen in this patient. So first and foremost, very good guys, keep commenting for that. Electrician is admitted to the ER with burn, so it will be electrical burns, and there is passage of red color urine. This tells me that the guy has had suffering from rhabdomyolysis. This particular question that we are discussing at the moment is rhabdomyolysis in a patient. Rhabdomyolysis will be either crush injury under a truck, like either the question will be very easy. He will say person was crossing the road, a truck went over the limbs. ट्रक ड्राइवर ने रियर व्यू में देखा कि बच गया, उसने ट्रक को स्टॉप किया, रिवर्स किया और फिर चढ़ा दिया उसके ऊपर से. You will notice that truck drivers are so heartless that they run over a person twice because they want to eliminate the witness who's the victim. You know, if the guy will survive, there will be a police case. They mangle the body, unidentifiable body, that 3-4 दिन तो फैमिली मेंबर को पता ही नहीं हमारा बंदा कहाँ चला गया. द गाय वेंट फॉर बाइकिंग, यू नो, अपनी साइकिल लेके वो गुड़गांव द्वारका एक्सप्रेस वे पे, क्या नया एक्सप्रेस वे खोला है मोदी जी ने, मैं ना साइकिलिंग करूंगा, और ट्रक वाला जो था उसने उसके ऊपर से रन कर दिया. The law is like that, na? The body does not get recognized. There is no forensics. There is no digital evidence that is happening, and the policemen don't want to work. I mean, it's a very bad situation that happens, guys. You will see mangled cases, no? And like these guys are so heartless. और एक और पॉइंट बोलूंगा, हाईवे पे कभी भी ड्राइव कर रहे हो, if you have ever a fight with the truck drivers or anything, like they brush your car or anything, don't ever fight with them. They're heartless people. They half of them are criminals. They've already gone to jail, and you will lose maybe 5,000, 10,000 rupees ki accessory, like you lost a side view mirror, and like let it go, let it go. You get out of a car and you start fighting on the highway. There is nobody to protect you. These guys, two, three guys will come. They'll have a rod with something, and they can do anything under the sun. So I mean, never ever interact, never do fighting with these people. I'm trying to you to be considerate because yeah, dash cam तो है ही है भाई, वो तो बाद की बात है. You can file court cases. They also go for 3 years. You tend to lose, right? Okay, crush injury is there, electrical burns is there, crush injury is there, electrical burns is there. So initially it is crush injury and electrical burns which are the trigger for rhabdomyolysis. Myoglobin is the protein here. Myoglobin is not brown and black. Myoglobin is red in color. Myoglobin is red in color. In this particular patient, myoglobin, red urine is a feature of myoglobinuria. Red urine is a feature of myoglobinuria. So that's why the person was having this red color urine, myoglobinuria present. And the bad news is myoglobin is a high molecular weight compound. It will block the tubules of the kidney. It will clog the tubules of the kidney. That is why in this person there is acute tubular necrosis, and that is why the serum creatinine is 4. So question says, which of the following will not be seen in this patient? Yes, guys. Can I have answers for this one, please? Slightly a tricky one. Which of the following will not ever be seen in this patient? Yeah, hypokalemia कभी नहीं हो सकता. Other complications, hypo वाले can be rarely present in a patient, but obviously it cannot be hypokalemia because if kidney is damaged, it will always be hyperkalemia present. So though the build up to the question was very 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 crazy one, but then the remaining aspects may or may not be present. The point is hypo तो कभी भी नहीं हो सकता. The correct answer for this question is option number B. Let's look up one more case of damage to the kidney, and this time it is a disorder that causes CRAB. I will not mention the full form of CRAB. This man is having multiple myeloma. This man is having multiple myeloma. He is having lytic lesions also. I mean, you know that in multiple myeloma, multiple lytic lesions will develop. I want you to come up quickly on the answer of this question and also comment simultaneously what is the most common site of lytic lesions present. Quickly, guys. Yeah. The cause here is, no, it is not. It is not Benn's proteins, man. It is hypercalcemia. The most common cause is hypercalcemia. It is the CRAB manifestations that are present. Hypercalcemia is the most common reason because multiple myeloma, there are cytokines which are produced by the plasma cells. It's a plasma cell tumor, and the plasma cells will be producing cytokines that will cause bony lytic lesions in a patient. So it is hypercalcemia which is the main reason here. Question for everybody is, what is the most common site of bony lytic lesions in multiple myeloma? C is hypercalcemia, R is renal failure, A is anemia, and B is a bony lytic lesions. The question is, bony lytic lesions can be present in, one is obviously the spine, second can be the pelvis, third can be the ribs, and fourth can be the skull. I think I made it super easy for you guys. You don't need to put too much of efforts at the moment. Spine, pelvis. Okay, Sai has already commented there. Prashant has commented. Spine. Yeah, that's vertebra, ribs, pelvis, and skull. Overall, what is the most common site of bony lytic lesions in the patient? Yes, absolutely. Yes, 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 yes. Waiting for some more people. Yeah, it is spine, which is the answer here. It is bony lytic lesions are mainly in the vertebra in the spine. That is why the question will always begin by old man, and then he will be having severe back pain, and this back pain will be mainly picked up on the basis of either the back pain patient went for MRI and there is lytic lesions that are seen, so we'll think in terms of multiple myeloma in the patient. Spine is most commonly involved. Skull is the last one to be involved. Skull is the last one to be involved. That is, the bony lytic lesions would come up the least in those patients. Now, how hypercalcemia? Yeah, because it will cause nephrocalcinosis. It will cause damage to the tubules. Calcium, if it is high, it will get deposited in the tubules. It will cause renal nephrolithiasis, nephrocalcinosis. So that damage to the tubules is the reason which is present in this patient. It is spine, pelvis, ribs, and the skull. The sequence is spine, pelvis, ribs, and the skull is the last one to get involved in this patient. how kidney is damaged, there are multiple reasons, but the first reason for damage in the kidney, that is what was asked, and I think that's a easier question, so you were able to get this spot on. The kidney damage owes its origin to, first is nephrolithiasis. Higher calcium will be damaging the kidney tubules of the patient, so nephrolithiasis. Yes. The second reason is obviously Bence-Jones proteins. The Bence-Jones proteins will damage the tubules of the patient. Therefore, there would be manifestations of tubular damage. The third reason of this patient why the kidney is damaged is blood viscosity is more. Multiple myeloma is a condition where proteins in the body are synthesized more, that causes hyperviscosity. So the blood supply to the tubules will be affected, because if you have hyperviscosity happening, then circulation will become sluggish. So supply of the tubules is sluggish. Supply of the kidney tubules is sluggish. There are three reasons why the kidney gets affected: nephrolithiasis, Bence-Jones proteins, and hyperviscosity. Out of the three reasons, this happens to be the number one cause why the kidneys in the patient will begin to shut down. The investigation of choice, yeah, tumor lysis syndrome, we will come to. Right, Sai, you have a good point. The investigation of choice for this condition is a bone marrow biopsy. Can you quickly let me know, bone marrow biopsy should be showing plasma cells more than how much percentage for diagnosis of multiple myeloma? Options are 10%, 20%, 30%, 60%. If you do a bone marrow biopsy in the patient, in a bone marrow biopsy, the plasma cell should be more than how much? Yeah, tumor lysis syndrome can cause renal AKI. Absolutely, yes. Yes, 20%, 20% is the answer coming. 30 to nahi hai. More people, please. Sir, it is 10%. Plasma cells more than 10%. And along with this, Kraft features are present. Plasma cells more than 10% and Kraft features are present, we will say multiple myeloma in a patient. It is multiple myeloma. For the treatment of these patients, can you tell me drugs? For the treatment of this condition of multiple myeloma, because it is causing renal failure, I will do hemodialysis to treat the hypercalcemia. Very high calcium now. I will do hemodialysis to treat the hypercalcemia and save the kidney of the patient. Sir, 20% is cut off for leukemia. Guys, cut off for leukemia is 20%. Read your pathology notes. Yes. Treatment. For treatment in this patient, what are the main drugs that are used? It is lenalidomide. Along with that, we use Dexona. And the third molecule that we use is a proteasome inhibitor. Yeah. That is bortezomib. Lenalidomide, Dexona and bortezomib is used for this patient. Another question that always come in the exam, prognostic marker of multiple myeloma. What do you check in the urine of this patient for prognosis? What is the prognostic marker for multiple myeloma? Quickly guys. यूरिन में क्या टेस्ट कर रहे होते हैं? Multiple times asked in the exam. I've already written half the answer for you. What do you check in the urine of this patient for evaluation of damage to the kidney? Yes guys, urinary beta 2 microglobulin levels. Yes, it is urinary beta 2 microglobulin levels and albumin that is used for evaluation. But most of the time in the single best answer, two must know MCQs for multiple myeloma. You know about causes of death, etc., infection from pathology. But what you need to remember, yeah, serum albumin also. But most of the time in the exam, they want to hear this name, that in the urine of the patient, you will be checking for urinary beta 2 microglobulin levels. In the urine of the patient, you will be checking for beta 2 microglobulin levels. That is point number one. And second, the question is kidney failure occurs due to hypercalcemia in the patient. So these were a couple of those important. Yes, very good. Beta 2 microglobulin. It is not beta 2 transferrin. That beta 2 transferrin is in the CSF of the patient. This is gonna be beta 2 microglobulin, which is a prognostic marker. Sir, ये question तो लोग neglect करते हैं. So I think you guys have done it beautifully. Let's take care of few more aspects to finish for today. What is the most common cause of what is, इसको खत्म कर लो यार, acute kidney injury खत्म कर लो ना. Yeah, rhinorrhea, CSF rhinorrhea. Yes, 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 yes. What is the most common cause of a post-renal acute kidney injury? Post-renal acute kidney injury. Post-renal means obstruction, and that obstruction will be due to enlarged prostate, that is BPH, that is benign prostatic hyperplasia. मोस्ट कॉमन कॉजेज बीपीएच, दैट इज बिनाइन प्रोस्टैटिक हाइपरप्लेजिया. So आज आपने सीखा प्री रीनल इज अंडर परफ्यूजन. रीनल कैन बी पैरेंकाइमल causes like hemolytic uremic syndrome affecting microcirculation or tubular necrosis, but post renal is obstructive uropathy, that is benign. It is not stone, sir. Stones दोनों साइड पे नहीं होते. Stones won't occur on both sides ना. Stones will occur on one side only. How can somebody be so unlucky दोनों साइड पे stone हो जाएंगे? So it is benign prostatic hyperplasia, which is the most common cause responsible. Carcinoma bladder is a good answer. Stones in the bladder is a good answer, but not stones in the kidney, because somebody will not be so unlucky to have four stones bilaterally. So it is benign prostatic hyperplasia. Now I'll discuss 1, 2, 3, 4 scenarios classical for like the kidney topic that come. One is the word non-oliguric acute kidney injury. The first time you read it, you are like, what? ये क्या हो गया? Kidney damage always causes oliguria. Here the word is non-oliguric acute kidney injury. So how on earth is it possible that the person will be having, how on earth will the person be having non-oliguric acute kidney injury? Then yes, सारों में ही, this is not an MCQ. All three cause non-oliguric damage. This is not an MCQ. All three cause non-oliguric kidney damage. How is it possible, guys? I did not ask for answer. All of them cause non-oliguric acute kidney injury. There would be polyuria. No, guys, this is not an MCQ. This is not an MCQ. All three cause non-oliguric renal failure, acute interstitial nephritis, contrast-induced nephropathy, and aminoglycosides. My question is ki why is it happening? Then your answer is collecting duct will be damaged. ऐसे बना लो, imagine this to be collecting duct. In the collecting duct, we are having V2 receptor, and V2 receptor is responsible for absorption of water. So if there is damage to this part of the kidney, that is where the V2 receptors are present. Like if I just put random crosses like this to say that if the lining of the tubules of the kidney is affected, in the collecting duct is damaged. You see, the damage is primarily to the collecting duct. Then water will not be absorbed and you will lose water from the body, and when you will lose water from the body, you will not be having oliguria. Surprisingly, you will be having polyuria. Normally when kidney is damaged, you will always have oliguria. Na? Here you have a polyuria. There are three causes for it: acute interstitial nephritis, CIN, and aminoglycosides. जो routine antibiotics होते हैं, antibiotics जैसे कि amikacin, they are contributing to damage to the kidney. Amikacin से ज़्यादा, like I can write kanamycin, और उससे भी ज़्यादा, right, I can write like tobramycin, netilmycin. Tobramycin, netilmycin are nephrotoxic drugs. Tobramycin, netilmycin are nephrotoxic drugs. They damage what? Yeah, obviously gentamicin, amica. I did not write genta and amica because we use them clinically in our practice. So like, you know, the impression will come that they're nephrotoxic, they should not be used. But tobra and netilmycin are like the nasty guys there. Your answer is right, Ashok. Gentamicin will also cause this when if it is given in excessive administration. But I wanted to teach you guys which part of the kidney will be damaged. It will be the collecting duct in the patient. It is collecting duct of the kidney that will be affected. Then is the aspect of CIN, contrast-induced nephropathy. Like there was a health camp in my hospital, and we were doing angiography at the flat rate of 5,000 rupees. Normally angiography will cost anywhere in the range of maybe 30 to 50,000. Now it is like maybe only 5,000 rupees. So lot of patients came, and there was a diabetic whom I did not check KFT properly. If in any patient who's a diabetic and you don't check KFT, if you will give contrast for angiography, there can be CIN in a patient, then you will know it is specific damage to the V2 wala area. Say the damage is only to the V2 wala area. I'll come back to the case again. There was a health camp in my hospital. I was doing like coronary angiography for 5,000 rupees flat, and there was lot of rush. तो एक डायबिटिक नेफ्रोपैथी का पेशेंट था जिसको मैंने आइडेंटिफाई नहीं किया, और मैंने उसको एंजियोग्राफी तो कर दी. एंजियोग्राफी तो हो जाएगी, उसके बाद में उसका रीनल शट, उसको किडनी में डैमेज हो जाएगा. पर्सन विल स्टार्ट हैविंग पॉलीयूरिया एंड क्रिएटिनिन विल स्टार्ट राइजिंग. दैट इज व्हाट इज कॉल्ड एज CIN, दैट इज कॉन्ट्रास्ट इंड्यूस्ड नेफ्रोपैथी. Contrast induced nephropathy is common with respect to diabetic patients where KFT of the patient was not checked. Question is open to everybody. What is the antidote for contrast induced nephropathy? What is the antidote? Though आजकल तो उसको बोलते हैं कि it's not very effective, but still for the MCQ sake they've always asked it, and the hint is it is also the antidote for paracetamol toxicity. So I hope now the comments can come very fast. भाई पैरासिटामोल टॉक्सिसिटी वाली दवाई कौन सी होती है जो यहाँ पे भी यूज कर लेंगे? या वी कैन डू फोर्स्ड अल्कलाइन डायूरेसिस आल्सो. एग्रीड. या एनासिटाइलसिस्टीन. Though after writing it, I'll say plus minus, but I just want to say that like N-acetylcysteine is like one of the questions that is asked in pharma, which can be used along with forced alkaline diuresis for this patient. N-acetylcysteine is not recommended nowadays, but for older MCQs. Now, next is acute interstitial nephritis, AIN, acute interstitial nephritis. मुझे आपने बताना है कौन सी दवाई खाने से AIN होता है. दो दवाइयां बता देना जो acute interstitial nephritis करती है. मेडिसिन दैट कॉजेज एक्यूट इंटरस्टिशियल नेफ्राइटिस इज PPI, प्रोटॉन पंप इनहिबिटर. जो लोग ऐसे ही खाते रहते हैं ना कि भाई गैस की गोली खानी है तो पेंटोप्रोजोल खाने से. उसने क्वेश्चन बोला पेशेंट ने पेंटोप्रोजोल खा रहा था लंबे टाइम से, उसको किडनी डैमेज हो गया. तो PPI का साइड इफेक्ट क्या होता है? वन ऑफ द साइड इफेक्ट्स ऑफ PPI इज acute interstitial nephritis, and the second one that somebody has commented very rightly is long term intake of vancomycin. Both of these molecules can result in development of AIN in a patient and can cause a non-oliguric renal failure. Yeah, amoxicillin, absolutely. Amoxicillin can again contribute to this, but PPI is like notorious to contribute to it. Proton pump inhibitor के जो side effects होते हैं उनको मैं आगे भी discuss करूंगा, but I would just like to mention them here. I will be discussing the side effects of PPI later also. One of the side effects is pseudomembranous colitis, PMC. Another side effect of proton pump inhibitors is that it can cause bone damage, that can cause osteomalacia and osteoporosis. And the third is acute interstitial nephritis. This will come up in the discussion subsequently also. Yeah, painkillers also contributing to it. Yep, exactly. The list is fairly extensive. But PPIs can cause pseudomembranous colitis, they can cause osteomalacia, osteoporosis, they can cause acute interstitial nephritis. So it's not a drug that should be taken very, very regularly. I've given 3 clinical situations here. वो बोलेगा PPI खाने के बाद में रीनल शटडाउन, रीनल डैमेज हो गया. वैंकोमाइसिन दिया उसके बाद रीनल डैमेज हो गया. कंट्रा डायबिटिक का हमने एंजियोग्राफी करा और रीनल शटडाउन हो गया, या एंटीबायोटिक्स दे रहे थे सेप्सिस के लिए और उसको रीनल शटडाउन हो गया. सो दीज आर ऑल नॉट वन लाइनर्स गाइस, दीज आर लाइक केसेस दैट वुड बी गिवन. एंड नाउ आई विल मेंशन रिगार्डिंग अ पेशेंट जिसको कीमोथेरेपी मिल रही थी. कीमोथेरेपी देने से रीनल फेलियर हो गया. हम तो ठीक करने चले थे, हम तो कैंसर के सेल्स को मार रहे थे. वी वर किलिंग द कैंसर सेल्स लेफ्ट राइट सेंटर, एंड व्हाट हैपेंड वाज दैट द टाइड टर्न्ड इन अगेंस्ट अस, एंड अनफॉर्चुनेटली like the renal shutdown happened in the patient. Yes. Now the aspect is that cancer cell, when you kill a cancer cell, the problem is that in the cancer cell, inside the cancer cell, it is loaded with DNA, and when this DNA will break, it will produce uric acid. In any cancer cell, there would be lots of potassium, there would be loss of energy in the form of ATP, because cancer cell will require energy. So when you will kill this cancer cell, the DNA breakdown will produce uric acid, potassium will come out, ATP will generate phosphate. So in this particular patient, the features or tumor lysis syndrome in the patient will be, the word is puke calcium. Puke calcium would mean, P would stand for, alphabet P will stand for that the phosphate in the body of this patient will begin to rise. The reason for phosphate rising in the patient is ATP generation. ATP is broken down, that is why phosphate is rising. The reason for the U component is uric acid is elevated. The reason for elevation of uric acid in the patient is DNA breakdown. The DNA in the body is breaking down in excess, that is why uric acid is elevated. In puke calcium, the K part is potassium. Potassium is maximum present intracellularly. So when you will be destroying these cancer cells, the good thing is that the cancer cells are dying. The bad thing is the potassium spike can cause a cardiac arrest in a patient. Now when the word is puke calcium, puke means you are losing calcium. The mnemonic is puke calcium. That is just to remember that all 3 parameters will become less. All 3 parameters will become less, but one parameter will become, all parameters will become more, one parameter will become less, and that is calcium. It is hypocalcemia. The rationale behind that is phosphate will bind with calcium. The rationale is phosphate binds with calcium, so you get hypocalcemia in this patient. So the message at the moment is impure calcium, PUK. It is phosphate that is more, it is uric acid that is more, potassium is more, and then the calcium would be lesser in the patient. Can you tell me the drug of choice for management of this condition? Because mostly in chemotherapy sessions this can occur, so we have to be ready even before time. What medicine should be started in these patients even before chemotherapy? One is obviously hydration. But what is the main medicine in high risk malignancies that should be used in a patient? Human body cannot break down uric acid. Human body cannot break down uric acid. So he has asked, what will be the drug of choice for management of tumor lysis syndrome? It is rasburicase. But if he changes the question from drug of choice to what is first line for the patient, then first line for the patient will be answered as adequate hydration with IV fluids. Flush the kidneys. Give lot of IV fluids to the patient. If you will aggressively give IV fluids for management of this patient, then subsequently you will notice that the damage to the kidneys can be prevented. This is a very dense slide, guys. It is lot of data which is incorporated on this tumor lysis syndrome, drugs causing non-oliguric renal failure. And now I will discuss in front of you renal failure after coronary angiography coming up once again. Because in the MCQ, there can be two possibilities for renal failure after coronary angiography. Possibility number one is CIN, which I already mentioned. Good prognosis, KFT comes back to normal within 7 days, and you manage with N-acetylcysteine as you had answered already. Sometimes to this we can add soda bicarbonate, force alkaline diuresis, but even that is not recommended. So it's like conservative management and the kidney function comes back to normal for CIN. Now look at the technical aspect that I'm saying before you, especially if you're a NEET PG aspirant, you need to listen to this with lot of care. Let us imagine a patient is undergoing a coronary angiography. This is the aorta, this is the iliac artery, and in the aorta of the patient, like let me say this is the renal artery, this is the aorta going up again, and in the patient, in the aorta, there is a atherosclerotic lesion present. So I'll zoom in. This is where atherosclerotic lesions are present. This is atherosclerotic lesions present. Now I am doing angiography in my patient, so my guide wire is going up like this. The guide wire in the patient is going up like this. The guide wire went up from the iliac artery and it's going up to the aorta. It's going still up, still up, still up. And unfortunately, the guide wire scraped against this atherosclerotic plaque. The guide wire went up right up to the coronary arteries of the patient, but on the journey, उसने atherosclerotic plaque को damage कर दिया. जो मेरी guide wire थी, उसने atherosclerotic plaque को damage कर दिया. तो जो atherosclerotic plaque के fragments हैं, जो fat के fragments हैं, atherosclerotic plaque के fragments हैं, these fragments will travel downstream and they will go into the छोटा-छोटा branches of the renal artery. I'm doing an angiography, the guide wire scraped against the atherosclerotic plaque and the fragments will go and block into the renal artery fragments. This is what is called as atheroembolic. You can see embolism happening at the moment, atheroembolic kidney disease of fat fragments into the renal circulation. How in a MCQ in 30 seconds can you pick up atheroembolic from contrast-induced nephropathy is, he will mention regarding livedo reticularis. Livedo reticularis basically means like a like I can say livedo reticularis would be like a fishnet appearance of blood vessels on the skin. This appearance, livedo reticularis, you read 2 times in a career, polyarteritis nodosa and atheroembolic kidney disease. There would be rash that would be present there, fishnet appearance of the skin. I'm not saying immunofluorescence finding, mark my words there. I'm not discussing immunofluorescence finding a fishnet. I'm saying fishnet physically on the skin. Yeah, 113 is a good answer, Maria. Then is rash, blue toes because of atherosclerotic fragments in the patient. And suppose you say कि sir इतना सब कुछ हम कैसे याद करेंगे? So in the patient, the fourth point which is to be remembered is urine microscopic examination, urine eosinophil. आपको और कुछ भी याद नहीं है, आपको अगर इतना याद है कि एंजियोग्राफी हुई है, if the question mentions angiography was done and then is going blah blah blah, बहुत बकवास कर ली उसने और बोला examination shows, urine examination shows eosinophils. Yes, Hollenhurst plaques would also be there. If the urine of the patient will be having eosinophiluria written, no, livedo reticularis, no, absolutely not, man. Livedo reticularis is a physical examination finding on the skin, that is fishnet appearance of the skin, even seen in polyarteritis nodosa. Coming back to the agenda, keep the tempo on. If angiography is given in any question, coronary angiography के बाद renal shutdown is given in any question, what are you supposed to check? You are supposed to check 2 aspects. One is he describing some kind of a rash on the body, which is due to atherosclerotic fragments getting disseminated along with eosinophiluria? If that is true, atheroembolic kidney disease. On the other hand, if he says that, oh, only creatinine increased and patient is passing more urine than normal, आप कह रहे हो अरे क्या बात कर रहे हो भाई, किडनी खराब हो गई बोलते यूरिन आउटपुट बढ़ गया? जी हाँ, कॉन्ट्रास्ट इंड्यूस्ड नेफ्रोपैथी causes non-oligary damage, so creatinine is elevated, but creatinine is elevated, but the urine output of the patient is increased, self-resolution, and like I mean, both of these conditions, the key word to be picked up is eosinophils in the urine with the presence of a rash for angiography. We come to the last question for today. Should bring smiles. Renal failure after dysentery or diarrhea. Renal failure after dysentery or diarrhea, though the case has already been discussed, that schistocyte case has already been discussed, and the presentation in this particular case is hemolytic uremic syndrome, that is HUS. I described about the superbug by the name of E. coli O157. Can you tell me which variety of E. coli causes it? Options are enterohemorrhagic, enteroinvasive, enteroadherent, enterotoxigenic. Can you quickly comment on the chat box? What is the organism responsible for causing hemolytic uremic syndrome? What is that nasty organism? Enterohemorrhagic. No, bache, not enterotoxigenic, not enteroinvasive. EHEC, you all know the answer. Enterohemorrhagic E. coli is the other name for E0157H7 strain of Escherichia coli. Yep, it is enterohemorrhagic. In this condition, the size of the kidneys will be normal, but if they change the question, they say diarrhea, dysentery, and after that there is a renal shutdown and the kidney of the patient is enlarged, then the answer will change. If the kidneys are enlarged, then this is mainly because of renal vein thrombosis, that blood is coming in the kidney, it cannot come out, so the kidney will enlarge in size, that is RVT. The points to be remembered by you are last 30 seconds of today's discussion. After diarrhea, if there is an acute kidney injury. After diarrhea, if there is an acute kidney injury in a patient, these are the possibilities which you have to consider in the question. The first question on diarrhea followed by acute kidney injury will be, that question will give you concentrated urine. And he will say urine sodium is low, urine sodium is reduced. In those circumstances, you will just answer this is a type of renal failure which is called as the pre-renal variety of acute kidney injury. That is the first question that I discussed. The second question will be in which schistocytes will be given. There will be mention of pallor. There will be mention of pallor. There will be mention of normal size kidney. You will say hemolytic uremic syndrome. It could be diarrhea, it could be dysentery. You know, it could be diarrhea, it could be dysentery. The third possibility is when there is mention of renal shutdown, the question will say anuria, and he will say the word bilaterally enlarged kidneys. He will say anuria with bilaterally enlarged kidneys. The moment you read that bilaterally enlarged kidneys present, इसका मतलब क्या होता है कि जैसे मान लो this is the renal artery and this is the, I'll draw different color. Let's say this is the renal artery and this is the renal vein, and there's a thrombus in the renal vein. Blood is coming in the kidney but is not coming out. Blood is going in the kidney, it is not coming out. So the whole kidney of the patient will become enlarged. Renal vein thrombosis. This is RVT, renal vein thrombosis. Yes, guys, any set aspirants, quick answers, please. What is the cause of renal vein thrombosis in a child and in an adult? If you are a FMG aspirant, you can skip these last 2 points. Yes, guys, NEET PG guys, quickly answer me. What is the cause of renal vein thrombosis in a child versus adult? I'm covering both of these questions of pediatric nephrology as well. Child is obviously diarrhea. The cause is dehydration. The technical answer of yours would be, doctor, it would be dehydration. Diarrhea is fine. It is dehydration. Dehydration will cause hyperviscosity. Dehydration, Nadeem, you are right, perfectly right. Dehydration will cause hyperviscosity. What is the cause in adult, please? Very good. Nadeem has already commented. A bit of slight improvement is what I want. A bit of improvement in your outputs I want. Yes, Ipsita mentioned it very rightly. Membranous glomerulopathy in the patient. Guys, the grind is real. The exam is not difficult, but it is a test of your patience and virtue. Most people run away कि भाई अब नहीं हो रहा. The word is fatigue that has to be removed from the vocabulary. There is nothing like nothing is going in the brain, and there's nothing like if you keep on saying those words, you know that I'm tired and I am nothing is going in my brain, you tend to internalize negative energy. It is we have to force our brain to understand कि भाई fatigue होता ही नहीं है, right? So we are sorted for today, guys. I still have another 2.5 hour session that will be our TNE that I'll be taking with these NEET PG guys. That is, I think, okay, Opthal would be discussed. But yeah, I'm ready for one more session, one more bout after this. So thank you, guys. हिंदी में बेटा किस चीज़ को हिंदी में रिपीट करने के लिए बोल रहे हो? डायरिया डिसेंट्री वाला. हाँ जी. डायरिया डिसेंट्री वाला बेटा वही है कि रीनल शटडाउन हो गया, यूरिन कॉन्सेंट्रेटेड है तो प्री रीनल वाला पूछ रहा है. अगर वो शिस्टोसाइट्स की बात कर रहा है तो HUS हो गया, और अगर एनलार्ज किडनीज बोलने की कोशिश कर रहा है फिर वो रीनल वेन थ्रोम्बोसिस होता है. चलो जी, ओके गाइस, सी यू अगेन टुमारो एंड वील टेक केयर ऑफ द रिमेनिंग इश्यूज. कल तो और भी आसान है, GI वगैरह है तो उसमें तो यू गाइस आर धुरंधर्स इन दैट. ओके गाइस, टेक केयर, टेक केयर. नो नो, टुमारो इज द लास्ट. टुमारो कल कल खत्म हो जाना चाहिए यार. अब तुम बैठ जाना यार. कल तो क्या दिक्कत क्या है, मतलब कल GI पढ़ने में क्या दिक्कत है? AHLAsia कार्डिया एंड पेप्टिक अल्सर तो इतनी बार पढ़ लिया ना, तो आई डोंट थिंक सो दैट टुमारो विल बी चैलेंजिंग फॉर यू गाइस फ्रॉम एनी पार्ट. द चैलेंजिंग पार्ट इज व्हाट आई हैव हैंडल्ड ऑलरेडी. चलो, टेक केयर, गॉड ब्लेस, गॉड ब्लेस, टेक केयर.